trainings, they have to teach us how to give people pain medicine when you do it for years.
very part of an important team for pain management for sure. So I'm glad you're here. Thanks for coming, everybody. What kind of nursing do you do?
I'm internal medicine.
Internal medicine? So are you in an office setting or a hospital setting? Oh, good. Okay. And I'm sorry, what was your name?
Tanya.
Tanya.
I'm Melissa Turner. I'm actually an internal physician.
I'm sorry?
I'm a physician.
Oh.
Tanya and I work together.
Great, great. Welcome. I'm glad you're here. I'm glad you're here. And I'm sorry, what was your name? I should ask everybody to have a name. Melissa. Uh-huh. Courtney. And what's your name, sir?
Chandler, and I'm a retired radiologist.
Excellent. Well, thanks for coming. Getting those CEUs, huh? Keeping that mind smart.
I have to have something interesting to do.
Well, I'm hoping to keep it real interesting today. And I'm sorry, what's your name, ma'am?
I'm Ellie Vance.
Ellie.
Yes, ma'am.
And
I work here.
you were,
With wellness.
uh-huh. Well, is that like a wellness center?
We
Like,
have an office across the street.
Oh.
Small building,
okay,
and it's the wellness department for the hospital, and we go out into the community and do clinics.
okay.
We offer health coaching and
Cool.
all kinds of things.
I hope you guys find it interesting. I know you're not here to see me. I know you're here for the CEs. But that's okay.
We appreciate you doing this.
Oh, thank you.
Actually, I really like the overview and new things.
Good.
And I've seen you before.
Uh-oh. And you're back for more? Oh, Lord, she's back for more. Yeah, yeah. Well, I appreciate you guys coming. I think probably normally, if Don wasn't here, I'd be like coming around and talking to you guys while I was lecturing, but I have to stay at my perch because Don's gonna other.
They're
Yeah.
sending you over the nation.
Yeah, they're sending me over the nation. So much for being retired, eh? Yeah, there you go. So, well, thanks you guys for coming. And as usual, Lisa's got this down to a science. She's feeding us and everything. Hey, Don, can you make me look taller and get rid of the double chin too while you're at it? Yeah.
I think there's a clinic here in the hospital that can do that.
Do they? Yeah, I'm getting kind of tired of this pose like this. Yeah.
So Lindsay, are you gonna go straight into your second PowerPoint when you're done with this one?
Yeah. I'm going to try. I have it up already. All I have to do is hit it. That's the idea anyway. Best laid plans. Pardon? You know what? I have a little sandwich. I got a sausage one, and it's in my purse back there for when I'm done. I'd like to hear the physician that's talking about marijuana because it is he? Yeah, because it's a really, really interesting subject. And I talk about it just a little bit in mine because I knew he was coming. And then there's a physician, I think, speaking on legal, which will be very interesting also. So, because we are in turbulent times, to say the least. Being a physician and writing for opioids is extremely difficult. And as an NP with my DEA license, you know, even doing pain management for a living, I look at things different than I did even 2 years ago. So unfortunately, the world is different. Much.
All these bad habits start on each coast and move inward.
Oh, is that what happened?
Oh, yeah, we were having narcotic problems in the early 1960s in Los Angeles.
Yeah, yeah. Well, you know,
Dosing on stuff.
there's some really, really great books out, but you got to have a strong stomach to read them. Like the one that first came out is called Dreamland, and that chronicles the opioid crisis. But the one I just got from Amazon is called Fentanyl Inc., INC, just came out, and it's about the third wave of the opioid crisis, which will be fentanyl. Well, we already know that people are dropping left and right.
And it's something you can completely control yourself.
I know. You know,
That's the bad part about it.
to tell you the truth, I don't understand. I really do not understand why people that are selling drugs to somebody would lace the drug with fentanyl, knowing full well that person could die. Why would you kill off a customer? It doesn't make any sense to me. But the interesting thing is I had a patient just before I retired. I'm not going to be able to tell as many stories as I usually do, but I had a patient before I retired, and he was in and he had been resuscitated, and they had been doing these parties. So they're called the Lazarus Party. You've probably heard of them. And one person in the group holds the Narcan, so that if somebody gets in trouble, they resuscitate them. That's the idea anyway, okay? And this one person holding the Narcan is also a user, but they rotate who's gonna be the Narcan holder. Okay, fine. So the patient I saw received 3 amps, straight amps of Narcan, and barely came back to us, okay? And when I talked to him about it, he said, you know, the guy next to me died, and they couldn't resuscitate him. And my patient said to me, I told the supplier, whatever that was that guy had, I want that too. Here's me, really? He goes, yeah, it must have been a great high if they couldn't resuscitate him. And that just goes to show you how terrible addictive disease is. You have absolutely no regard for your well-being. You know, you're gonna die if you keep doing that. And I don't know how else to say it. Are you ready? Are we ready? Oh,
Can you hear it?
I'm sorry.
No, that's fine.
No, I'm glad you can't
As
hear
long
it.
as you're not saying anything.
No, that's
Oh,
fine.
no, we were just talking about,
We're having an internet lag.
Just a little bit of lag, so it's good. At least we're hearing
I just need to
audio.
make sure I can hear it.
So about 4 till.
No more
So start at
stories.
8 o'clock.
Yeah.
That way we can see.
sorry, I didn't know I was on tape.
No, that's okay. You didn't say anything wrong.
I needed your voice anyway. Let's take some.
I'm sorry, Lisa.
No. I needed you to talk. That's good.
You're good.
I
Morning.
don't need you to walk. Talk is good. Walk is not good.
No, it's okay, I'll remember. He's gonna throw something at me. First I get a warning like this, then he's gonna throw something, and then he's gonna take.
Back out here and see if I can see the picture.
Somebody tell me when it's 4 minutes to.
It's 7:52 now, so we got 4 minutes.
Okay, thank you.
We have a bit of doctor came in, he's a twice speaker, and he deals with addiction, I believe. And he got addicted to fentanyl. He just decided that he wanted to see how good it was, so he took some home with him and just did it. He said it was the best thing he ever felt, and he got addicted to it.
Can you still hear me? Was he an anesthesiologist?
No.
You know, fentanyl in the anesthesia world is a real problem. And a lot of that has to do with access. Yeah. I'm going to be going pretty quick, Don,
Faster the better.
because
Always gonna run behind at some point.
I got 83 slides, so I have to do 83 slides in 6 minutes. 60 minutes.
Are you gonna lean off to the side like that?
No.
No, if you will lean there, I just gotta readjust the camera so that you know, I can give you a little bit of room. All right, so what I'm gonna do is I'm readjusting the camera. Don't move any to your right. You got a little bit of leeway to your left. You can kind of move over there, but don't move to your right.
Don't move to the right.
Yeah, if you go off the camera, if you go off behind the podium on the right, you'll go off straight.
Okay, so here or a little to the left.
You can go a little more to the left if you need to. If you
Okay.
If you go comfortable, kind of lean on the edge. You'll be okay.
So we can't just show the slides and not me, huh?
Do them both. At 10 till 9, wait, please.
Thank you.
I'll give you 10 minutes.
I like this thing because it counts for me too. when I have it on the speaker mode, I can see how many slides are left, so I can see how bad a trouble I'm in. Good morning.
See, that's the last, that's the difference, I can, it's all, no, you're fine, it's not even, I just remember some of them doing security watches, just calling them, might be that they're running to check it. Right, put on the red flag, I'll send somebody run stuff up, you see.
I'm coming right back. I appreciate you sharing the story of your grandpa with me. Thank you. Like I said,
Important story to me.
Yeah.
And like I said, I could do it over again. I would
please.
an advocate for a little bit more health relief for
Yeah,
him.
we're going to talk about that.
Yeah.
But you didn't know it at the time. So, yeah, but thanks for sharing. Oh, no problem.
That's how big of a lag it is. I'm just not. Just now. I mean, I went huge lag, I probably 5 minutes on this thing. Time to start. We'll get it. We're gonna start. Ready to go?
I'm ready.
It's all yours.
Okay. Good morning, everybody. Thank you all for coming. I would like to thank St. Vincent's and all of the people that are putting this conference on today, and Don, and everybody that's helping me broadcast across Ascension. I would also like to especially thank Lisa for inviting me back. I've been to Alabama in the past, and people are extremely friendly here and hospitable, and plus it's nice and warm here. My name is Linda Vanny. I am a nurse practitioner. My business is professional pain education and consulting. I spent 30 years at the Detroit Medical Center and another 7 years at Ascension Providence in Detroit. I've started 3 pain services. That was in my younger years. And get an opportunity to travel nationwide and also lecture. So I have a ton of information over the next 2 hours to present to you. And I understand that those of you that are doing this by telecom, if you have questions, please submit them. And Lisa and I will get back to you on Monday with any of the answers to your questions. And then, of course, any of you here in the audience would like to give a question, please feel free. I have nurses here, physicians, social workers, physical therapy, and a bunch of other people, and I'm very glad you all came in today. So thank you very much. My first lecture is going to be on the current state of pain management. I'm used to walking and talking, but since we're videoing it, then I don't think that's a word either, but I cannot walk around. So I will try to behave myself here. So, okay, so the objectives for today are to discuss the historical aspects of the opioid crisis, which everybody's familiar with. I'm going to talk about assessment and some techniques that I have found helpful, and also the current treatment for acute pain. I don't have any conflicts of interest to disclose. And I want to talk about a little bit about the opioid crisis. Now, down south here, it's been very, very difficult. Even up north, all around the United States has suffered from the opioid crisis. There's some really good books out there if you're interested. Dreamland, Fentanyl Inc. just came out. That's a really good book about fentanyl, and I'll show you some of these resources as we go on. But the interesting part about the opioid crisis and diversion of opioids has to do with the state of our mental health across the United States. I know you can see right here that there's an intersection between people that have mental illness and people that have substance abuse disorder. And that's 8.1 million people have substance abuse disorder and mental illness. So, you know, many of us that practice in pain management are very, very concerned about this group of individuals, that they're not getting the help they need for mental illness, and we're using pain medications inappropriately. So let's talk a little bit about what happened. In 1996, the American Pain Society president talked a little bit about how we were not taking care of patients with chronic pain, and basically started to talk about why can't we assess patients with pain the same way we do vital signs. So that translated, everybody picked that up. The Joint Commission really never mandated that. They never mandate anything. They just tell you what they want. And basically, what happened was they started to have people assess pain, self-report, as a fifth vital sign. Well, people associated pain management directly with opioids and nothing else, which was bad, bad news. So there was just too much drug around. Things got out of hand. 76 million opioid scripts were written in 1991 before this even happened. And then as things got out of hand by 2011 and 12, 219 million scripts were written. Now, the amount of opioid scripts has declined, but we'll talk about if that's a good thing or not down the road here. Then there was a jump from legal to illicit use. So basically what happened was, I worked at the Karmanos Cancer Institute. I had cancer patients. I would write a script for, say, OxyContin. Well, the family, at that time, we weren't necessarily assessing safety in the house. And the next thing you know, the OxyContin I wrote for my patient ended up with their grandchildren at a drug party of some type. So although the scripts were written appropriately, many of them, they ended up in the wrong hands. And now, as of 2018, depending on who you talk to and how it's measured, we lose 175 patients per day to opioid overdose. Now, I want to point out here, there's a lot of discussion going around about this whole idea of, is that an accurate figure? Because the post-mortems that are done will show opioids, but they don't report how many of those patients died from a combination of opioids and benzos. And we're going to talk about that quite a bit, okay? I also want to say, I am sure everywhere I go, there's many healthcare providers, and I know nurses, because I'm one. And many of us have stuff at home that's in the medicine chest that's so old and expired that may be a controlled substance. It's got green fuzz on it. But what do? We keep it in the back of the medicine chest just in case there's an emergency over a holiday weekend. Now, I'm sure nobody in here does that, but the idea now is to try to get all drug, any controlled substances that aren't being used in the house, out of the house, okay? All right, so this is a slide done by the National Survey on Drug Abuse and Health, and it talks a little bit about how you have, am I allowed to use a, never mind. Okay, so 40% patients that are on opioid pain medicines often become addicted, and you can see here, and many of them use more than 3 drugs. It's not just one drug that they're working on. So you can see the propensity of having an addiction problem when you have other addictive substances up there, okay? So let's talk about pain by the numbers. There's 83 million adults living in pain. And the one that I want to point out here is this right here. 80% of all physician visits are for chronic pain, and this one right here, 1/4 of nursing home residents are suffering in pain. Now, how many of you work with the elderly? So I'm going to talk quite a bit about safety and using these controlled substances with the elderly, but my mother and mother-in-law both suffered from dementia, and my mother-in-law was in a facility, and I'd walk down the halls and I'd hear people crying. Now, was that pain? Was that mental illness? Was it dementia? What was it? I don't know. But it's very difficult because I don't know that we do as good a job as we could in the nursing home population. $26.5 billion for back pain alone. And I bet if we went through and talked to everybody here, some of you have had back pain in the past. It is not fun. And now we're starting to see a lot of cancer survivors. I put this up because I am like a data person. This is from the SEER data. And basically, the green figures right here are survivors of all cancers after 5 years, 67%. Now, the problem is these patients have pain related to the treatment they got. So they could have post-mastectomy pain. They could have post-radiation pain. They could have neuropathy from chemotherapy. So these patients often develop chronic pain. So this is another group of individuals we need to be concerned about. But in 2019, these are the issues related to chronic pain. The stigma of being on an opioid. These drugs are not benign, and everybody in here knows that. Who's going to be the writer for these medicines? What's the expense? And how big of an issue is addiction from chronic opioid use? And do we have to worry about diversion? Now, this is from the NIH, and you can see here their latest data from 2017. This is the number of deaths involving all drugs. So that's everything. And you can see here in 2017, it was 72,306. That is unbelievable to me. And now you talk about benzodiazepines and opioids together, and they only had stuff from 2016, but you now have a very high risk of an overdose. I swear half the world's on Xanax. When I would do a history on somebody, 9 out of the 10 people were on Xanax. It was amazing to me how many people in the United States take Xanax. Now, this is a very famous photo. You guys, I'm sure, have seen this. It was on the news. And you can see, here's the mom, there's the dad, and look at this. And there's the baby in the back. And I don't know if you can see or not, but there's the policeman's hand. Very, very sad. Now, you know that as parents, some of you that are parents, you would never do this to your child unless you were suffering from addictive disease. Okay. So this is specific related to Alabama, but these are very transferable nationwide. And you can see here, Alabama's in the red, and you can see how many opioid-related deaths there are. This is 2016 data. Okay, and then here's nationwide, 13.3 million. 13.3 opioid-related deaths in the United States. And then there's Alabama at 7.5, so about half. And you can see here that there's any opioids, tops the list. This is per 100,000, 14 per 100,000. And then you can see other synthetic opioids such as fentanyl, you have heroin, then you have the semi-synthetics like oxycodone, and down here methadone. Look at the good news here though. Methadone has gone down in overdoses. It's a good thing, and I'll talk about that in a little bit. But this is the new culprit, and it's fentanyl. And you can see here, since 2016, up since the last 3 years, since 2016, there has been an increase of 540% of overdoses with fentanyl. Fentanyl is not a drug that you can goof around with. Remember, this drug is 100 times stronger than morphine. Here's morphine. Heroin is 2 times stronger than morphine. Fentanyl, regular plain old fentanyl, is 100 times stronger than morphine. And then the carfentanil, which we're starting to see on the streets, is 10,000 times stronger than morphine. Now, carfentanil was only meant to be given to like elephants and big It's a vet drug, okay? But we know that this is coming from China over the internet. And many of these drugs are so strong that when I see the patients coming into the ED and they can't be resuscitated, they still have the syringe in their arm and they've only pushed a little bit and they are dead. It is the next wave, unfortunately. This is the new book that just came out talking about China and how they make fentanyl and how you can get it over the internet. And they talk about these rogue chemists and how they go ahead and make different drugs that we have never seen before. And many of you, if you know, even if you touch fentanyl or inhale it, you can get into serious trouble. The police have had to have Narcan when they didn't know what the white powder was. And that's because of the nature of the drug. Fentanyl is lipophilic. It is the only drug, opioid, that can go right through the skin. Hence the reason we have fentanyl patches, which I'll talk about in a little bit. Okay, so I want to show you this. This is a young girl that came into one of our facilities in Michigan, and she had long sleeves on and long pants on in July. So we knew there was an issue. And I don't know if you could see or not, but there's some big holes here. This hole right here, you can actually visualize the vessel. So she was using that to inject. This is so sad. Anyway, she came to our facility. We triaged her and then sent her to the burn unit in Ann Arbor. And unfortunately, she died of sepsis. You cannot recover from this. And I feel so bad for her family. And we have pregnancy issues that we're dealing with. So basically, all kinds of newborn infants are being born. And this slide is incorrect, and I apologize. Babies, when they are born, are not addicted. They're dependent. They're physically dependent on the drug. Addiction is a disease of the brain. The mother's addicted, but the baby is physically dependent. And unfortunately, you can see there's thousands of these babies born every year. And these are the most common drugs that we see, Vicodin and OxyContin, and they're not being taken for pain. And this I put in to show you, whoops. This is a regular placenta cord. See how beautiful it is? You can see all the vessels. This is a placenta cord from one of the patients that I had that was on maintenance methadone. And I don't know if it's very, very dark. It's all clotted. And when she gave birth, her baby was alive. When she gave birth, the cord clotted and the baby was stillborn. Very, very sad. So we have a lot of issues going on. How long is too long to give somebody opioids for pain? And does everybody on opioids get addicted? We know no, that's not true, right? How long is too long? All these years that we've had using opioids, are they going to come to an end? Will it happen someday that the DEA sends me a letter and says, Linda, in your practice at the Cancer Institute, you're only going to be allowed to give out 200 OxyContin a month. Divvy it up as you see fit. Could happen. It hasn't happened, but it could for those of us that have DEA licenses. So who can have it? What else can we use to control pain? And is there really a magic bullet? We're all searching for that. So my magic bullet would be something that relieves all types of pain. It isn't addictive. It's a non-opioid. Everybody wouldn't mind writing for it. There'd be no side effects. It'd only be once a day dosing and cheap. Easy to swallow, easy to use, plentiful, and not illegal. As everybody in here knows that, there's no such thing. So the CDC came out with guidelines in 2016, and these are very, very controversial. If you don't know about them, I'm going to tell you about them here a little bit. So they had some really good ideas, and some of them were to make sure that obviously you assess the benefit to risk ratio before you start somebody on opioids or continue them on it. You make sure that there's safe use and reassessment, and all practitioners make sure the patient's okay. Well, they also came out and said opioid therapy is not the first line for chronic pain. and you want to use multimodal. You're going to hear multimodal till you're sick of it today. Establish goals for pain, and that includes function, risk and benefits, and if opioids are started, the lowest dose. Well, the interesting thing about this is everybody took this to mean that the CDC, these were not guidelines, these were mandated. And so that's not true. These were guidelines. And so basically what happened was, these are some more of the guidelines, and obviously they were worried about benzodiazepines, making sure your patient had Narcan at home, reassessing in 1 to 4 weeks. But the worst part was they set a limit on the morphine milligram equivalents of 50 in a day. That was what they set it at. And everybody, a lot of people took this as gospel. And so basically people that were on 200 milligrams of morphine equivalent a day and had been on it forever and were functional, working, no diversion, only one doctor prescribing, their PDMP, their prescription maps look good, all of that, they stopped prescribing for them. This caused suicide issues, withdrawal, trips to the emergency room, and nobody, it just wasn't a good thing. So basically what happened was they ended up having a great decline in opioid prescriptions, as you can see here, after the guidelines came out. But the problem was people were dying from withdrawal and dying from suicide. People that were functional on their opioids, because their prescribers decided they were not going to write for them anymore and no one would take them on. So a lot more strategies came, and the new one, HHS, Health and Human Services, came out with this interdisciplinary task force report. And that just came out. This is what it looks like, and if you haven't seen it, you should take a look at it. Now, I printed it off, but I don't suggest doing that. It costs a cartridge. But it's 170 some pages, but it starts in detail about how the CDC guidelines were strictly that, a guideline, and not gospel, and that we're hurting people by stopping their opioids if they're functional and don't have addictive disease. Okay? So here's some more of the standards. You can see them here. And it's very unusual. I'm going to go back. It's very unusual for another government agency to criticize another government agency. And at the very beginning of the NNS new guidelines here, they talk about CMS and how they overshot the mark. And then this shows suicide slide. Very unusual. Okay, but CMS did end up changing patient satisfaction. Now, some of you might remember that when our patients were admitted, they would, before they left or a little time after, they would get a questionnaire that said, was your pain always controlled? That's not realistic. And everybody told CMS that, okay? So this is the new questions. During this hospital stay, do you have any pain, yes or no? How often did the staff talk to you about pain? How often did the staff talk to you about how to treat the pain? And these, as you know, these questions are very important. They are value-based. So all the hospitals and all the settings that use these CMS questions, they buy things based on CMS recommendations of how well they're doing. So these are much more fair. These surveys went into effect on the 18th, but they will not start getting reported online for the public to see till 2020, and the payment thing won't change until 2021. So we have plenty of time to make sure the patients are more comfortable and have their side effects managed. Now, everybody in here knows the Joint Commission also had a big stake in pain management. And one of the things that came up routinely was dosing to numbers. which is extremely dangerous. And I'm going to give you an example of that. And unfortunately, there was a lot of people that were cited for this in the hospital setting, the nurses, because they said that the nurses were practicing out of their scope by picking a specific pain number. So see where it says right here, pain scores, moderate, mild, moderate, severe, they would be linked to actual doses. And so it would be up to the nurse by the patient's self-report to determine what the dose would be. And the Joint Commission didn't like that, of course. So luckily now this is gone, people aren't doing this anymore, and we're looking more at function. That's the idea anyway. But we got a lot of safety issues to deal with. Many times the patients come in and you get a history from them, and I'm not saying all patients, but the history lacks some detail. Like often I'll say, do you drink alcohol during the day? They'll say 2 beers, and I find out later it's 10. You know, that's kind of a big difference. Because then we have to worry if somebody's drinking 10 beers and they're going to be at our place, we have to put them on CWA. We have to worry about them going into alcohol withdrawal, DTs, okay? Just those kinds of things. I often will have patients say to me, well, my next door neighbor gave me a blue pill, and I love that blue pill. Could I have that blue pill? It helped my pain. And I'd say, well, what did you give the next door neighbor to get the blue pill? And they go, oh, one of the pills you gave me, Linda. So I say, oh no, you're supposed to call me if it's not working. You're not supposed to be trading my pills that I gave you for somebody else's blue pill. Okay, that's just not right. Okay, and then there's the whole idea of ethical treatment, especially related to people that have substance abuse disorder. Okay, so now we're having a shifting paradigm in the pain world, and this is not news to any of you. It's all about multimodal now, using acetaminophen, linking pain management to function. Now we have smart pumps for both PCA and epidural, and there's shortages of parenteral opioids. One of the shortages was hydromorphone, and we'll talk about that in a minute too. But we're using much more topicals and much more integrative therapies, and we're trying to keep it safe. Now this is a ladder which you probably have seen in the past. It's based on the World Health Organization, and you can see the foundation of pain management is now integrative therapies, things like topical agents, non-opioids. If the patient's pain gets worse and they have breakthrough, you continue this, you go to here, and you give your first dose. Then you start reassessing and going up the ladder, but you never stop this. And this was the problem that we had in the past. We would stop that and go to opioids only. But now it's all about function, and I know I have a physical therapy person here. And you know, when you do pain management, this isn't a free ride, okay? So the patients often after surgery, if they weren't maybe enlightened by their surgeon, will say to me, well, I know I'm supposed to go home tomorrow, but I'm gonna just stay in this bed for the day, and I would like some pain medicine. No. And you know, I have to be careful, so I say things like, you know, you gotta get up, you gotta get up, you gotta get up, move it, move it, move it. And sometimes it comes out a little harder than I should say it. But this is not a free ride. You don't spend the day in bed post-op. You get your pain medicines, and your idea is to become functional, okay? And you can see here, this is the way we used to assess pain, all self-report. So it's not all self-report anymore. So let's talk about history. The very first thing that should be done, I don't care what setting you're in, is your prescription drug monitoring program. This is vital. This is a gold standard of care. And throughout Ascension, this is what we should be doing. Now, I have to tell you that 50 states are up, but only Missouri's not running. I'll show you that in a minute. But it reports all controlled substances, often in real time. So if you went to the computer and you pulled up your patient you're prescribing for, it'll show you when the last time the medicine that you ordered was gotten, who ordered it, how much they got, and how they paid for it. And you can see different states. So like in Michigan, we have snowbirds that come from Michigan. They leave in November after Thanksgiving sometimes and go down to Florida and spend the whole winter there and then come back in March. Well, how do I know who's giving them what down there? So you can see all the different states. And I'm hoping what's going to happen is that the time will come where we can see all the states, no matter where you are. Like if I was here in Alabama, I could see all the states of my patients. We're not quite there yet. Many of these drug monitoring programs also calculate that morphine milligram equivalent. And it's very interesting because basically what happens, I write a controlled substance, say for morphine. My patient takes it to the pharmacy, hopefully the pharmacy fills it, and then they report back to the state prescription drug monitoring system. And then I can pull it up and see if it was who's been writing for this particular patient. Now, down here, insurance programs, licensing boards, state health department, and law enforcement in some states can also see the information. Last year, in 2018, more than 460 million hits on prescription drug monitoring systems. This is the gold standard. Before anybody writes for any controlled substance, they should be pulling up that patient and taking a look at it. It's very, very interesting. And this is just the one here in Alabama, just to show you. Alabama Prescription Drug Monitoring Program, but these are all around the United States. And this is just some of their information. They have, little brochures and stuff. But I want to show you that all the states are up and running. But the ones that are in gray, you have to access it before you write. And there's Alabama. Where's Alabama? Right here. Okay, all right. So some controlled substances and then all controlled substances, but now Michigan is pink too. And I know here in Alabama it's pink too. And I want to bring up why it's now mandatory to look at this. In 2017, Ohio started to notice that Neurontin, the trade name, or gabapentin, generic, was starting to be abused. Now remember, Ohio is at the intersection of the highway that goes across the country and I-75. So it's kind of ground zero for a lot of drug trafficking that goes on, okay? So they noticed that gabapentin was the 5th most prescribed drug in the nation and that it was causing euphoria and staving off withdrawals. Now the problem is, even if you're on methadone for drug treatment, medication-assisted treatment, if you use gabapentin, which almost all my patients were on for their nerve pain, it will enable them to get high, even though they're on methadone. Oh, yeah. So anyway, 1/5 of all those abusing opioids misuse gabapentin. And as you can see, this is a current Detroit sale. 300 milligram pill only sells for 75 cents. So it's dirt cheap. Very bad. So this is something now that is being reported not only in Ohio, but also Michigan and now in Alabama. So November 18th, 2019, that's right around the corner, you will start to see gabapentin on your prescription drug reports, even though it is not a federally controlled substance. Okay, so who's accountable for pain control? Everybody, all of us, everyone in this room. We're all accountable for it. And there's a ton of position statements, especially related to patients that have addictive disease, okay? They still need to have their pain managed. This is not a get-even event when they get admitted for an abscess in their arm. We're not going to withhold pain medicines from them. But you can see here the International Association for the Study of Pain and the American Society of Pain Management Nurses all have position statements on making sure patients with addictive disease are comfortable. Let's talk about assessment. Everybody's probably familiar with this. This is Margot McCaffrey's 30-year-old definition. Pain is whatever the experiencing person says it is, existing whenever he or she says it does. Now, Sometimes you can see pain. I don't know if you can see this little pup or not, but he got too close to a porcupine and there's a lot of blood here and oh. Anyway, he's hurting. But you can't, many times you can't physically see pain. And pain is really weird because pain encompasses both suffering and pain. Okay? So all these things here combine with physical pain to make the total pain picture. So when we're assessing a patient for pain, the gold standard still is the self-report, but now we're switching more over to how functional is the patient. How many of you have had a patient that you medicate or somebody's medicated them and they tell you at the beginning their pain score's a 10 before they get medicated? They get medicated, they tell you that their pain score is a 9, but they're now able to walk up and down the hall. That's very, very common to see that. And to tell you the truth, I'm not really that worried about a 9. I mean, I am worried, but some chronic pain patients will never tell you they're below a 9. They're afraid. They're afraid that you'll stop their medicines. But if they're walking up and down the hall, this is what we're looking for, is function. This, I put in your handouts, is the definition of an opioid-tolerant patient. So if you have a patient coming in that's receiving at least 60 milligrams of oral morphine or 25 mic patch or 30 milligrams of oxycodone or 8 of Dilaudid, hydromorphone, that patient is opioid tolerant. Does anybody know how long it takes to become opioid tolerant when you're on opioids post-op, if you take it regularly? Anybody want to venture a guess? You know what? That's a very good answer. But believe it or not, it's 7 days. 5 to 7 days. That's all. So when I say, that's not addiction, that's dependency. So when our patients leave the hospital with a script that's for 2 weeks or 5 days or 7 days, you have got to make sure you teach them what physical withdrawal feels like. Because the family will think it's addiction when it isn't. And the patient will end up back in the hospital. Okay? So we have to have realistic goals from the beginning. I'm a surgical nurse, but I got to tell you, sometimes the surgeons, God knows I love them, but sometimes I've heard them say pre-op in a visit, don't worry, you're not going to have any pain when I'm done. Now what they're saying is, yeah, I'm going to replace your knee, and in 6 months, you're not going to have any pain from your knee. Patient hears, oh my God, I'm not going to have any pain after surgery. Now think about that. A family member of yours might think like that, but we all know if you go to the OR, you're going to have pain. So we need to have the surgeons or whoever's teaching pre-op to talk to the patient and say, listen, you're going to the OR, you're going to have pain. We're going to try to keep it manageable so you can move around. Okay, and we're going to use lots of different things. So these are some of the things that we look at when we're assessing the patient. These current medications that they're on at home. If a patient is opioid tolerant, you give them a regular opioid naive dose of pain medicines, you're in for a bad day, let me tell you. You have to start with what they came in on and build up from there. That's the most important thing. It'll make your day, trust me. Okay, and you got to be careful of this sleep apnea thing. Now, I know I'm being broadcast across Ascension, but I do have to show you. Okay, so here's me. If I came into your place and you were assessing me for sleep apnea, trust me. Okay, so first off, do you see a neck, a jaw? The answer is no. No, there's no neck, there's no jaw. So there's nothing here. So I have a very short airway. I'm over the BMI. And I'm not telling you how far over the BMI I am. I'm short in stature, I'm a female, and I snore. So more than likely, I have undiagnosed sleep apnea. So I'm somebody that if you gave me a little bit of morphine post-op with some other stuff, you better keep an eyeball on me because I could stop breathing. Okay, so use your visual skills, okay? There are a lot of differences between chronic pain and acute pain, but I want to bring up this. There is acute pain, there's chronic pain, and then there's acute on chronic. Your patient has chronic back pain and they come in and they fell off their bike and broke their arm. You now have acute pain on top of their chronic pain, So remember, you got to continue to treat the chronic pain, but now you have to treat the broken arm too, until that acute pain goes away. There's a bunch of different types of medicines and things that you do for different types of pain. Again, there's that functional, but each patient's pain is unique. Everybody is different, okay? And we cannot treat chronic pain in the hospital setting. We can treat it, but we can't treat it like it gets treated outpatient. Chronic pain is an outpatient treatment. It is a disease, okay? Acute pain is a symptom. It's not our role to judge, and we have to make sure that the patients are being put on their drug. Now, this is the most important slide of the slide set. Tolerance, dependence, and addictive disease. These definitions you need to know cold, because the patients do not get it. They don't understand it. So tolerance is when a dose of something needs to be a little bit bigger if something happens. As there are days where you've had 1 cup of coffee and maybe you went to a concert the night before and now you need 2. That's an example of tolerance. You need 2 coffees instead of 1, okay? Then physical dependence, okay? If you stop your coffee, what happens? Headache, terrible headache. Who here's tried to give up caffeine multiple times? That'd be me. Anyway, so that's physical dependence. That's not addictive disease, that's physical dependence. So addiction is loss of control and limiting the intake, bad behaviors often, okay? So if you went to Starbucks and you couldn't get a coffee and you slit the brewmaster's throat in the back of the thing and took your own coffee, that would be addictive disease, because you don't care about your welfare or the person behind the counter. But patients, when their loved one becomes dependent on a pain medicine, they think that's addiction. Or if they're taking too many, they say, oh, no, we're stopping that right now. And then that creates all kinds of trouble. These are the types of acute pain. I'm going to show you this. Somatic is bone and muscle. It's pinpoint, you can know right away. What kind of drugs work for that? Oh, I put it up there. Some people probably have already taken those meds today. NSAIDs are the drug of choice for somatic pain. Acetaminophen works, muscle relaxants, ice and heat. Visceral pain is organ pain. It is not localized. The patients with pancreatic will say, oh, Linda, my whole abdomen hurts, my back hurts. That's visceral pain. Pain of the organ pain. And they don't say it's sharp, they usually say it's gnawing, like an aching pain, and that responds to opioids. And then neuropathic pain, which we know opioids do not work on. If you have a patient on opioids for neuropathic pain, wean them off. The only drug that we know of that's an opioid that helps with neuropathic pain is methadone and a little bit of buprenorphine. But those two, that's it. Opioids do not work on neuropathic pain. And neuropathic pain is described as shock-like, stabbing, burning, numbness. Okay, what's good for those? What's good for that kind of pain? Pardon? Cymbalta, absolutely. If you have a patient on Cymbalta and gabapentin, no. If you have a patient on Cymbalta and pregabalin, Lyrica, what's probably wrong with that patient? Fibromyalgia. Those 2 drugs together are FDA approved for fibromyalgia treatment. Gabapentin, pregabalin and Cymbalta. Excellent. Okay, so here's the sites of pain. This is routine stuff for you guys. What is its effect on a history and everything? How do the patients sleep? Where is the pain? And you can see here, we talked a little bit about this already, but I want to show you that when you're dealing with the elderly, it's a whole nother discussion. You have to be very, very careful of these people. Okay, so I'm 64 years old, and I'm considered a senior citizen. My dad is 91. I consider him light years from me, but we're both senior citizens. So we do not clear medicines the way you guys young whippersnappers that are in your 20s, okay? So you got to be careful. And many times there's a lot of issues with these patients. They don't clear the morphine, and they use Benadryl and things like that. And the Beers list is a list by Dr. Beers, and he's a specialist in caring for the elderly. And it is an evidence-based tool. And believe it or not, he does not like NSAIDs. Why doesn't he like NSAIDs? What's wrong with NSAIDs? Kidneys, what else? Stomach, what else? Yeah, cardiac, yeah. So he prefers acetaminophen, and this is exactly what you don't want. How these seniors don't, accidentally kill themselves with all the prescriptions they're on is a miracle to me. But I think when you're dealing with senior citizens, please make sure that you understand that less is more with them. Less is more. All right, so we can also there's a big push for interventional. How many of you have had a patient that has had some interventional therapy done? Like a block or, yeah, okay, good. I wanted to just show you that this is the list, and it doesn't have to only be anesthesia. Internal medicine can do it, and interventional radiology can do it. So there's a lot of different people. But this is one thing that I wanted to show. It is the only intervention that we have right here that gives instant pain relief. So if you have somebody with a collapsed vertebrae, right here, see how it's squished down? It's now leaning on the nerve where it's causing severe pain. And the patient usually can point to right where it's at. If there's enough height, they put in a rod, and the rod fills up a balloon, and the balloon pushes the vertebral body up again, getting it off of the nerve. They then pull the balloon out. There's a cavity there, and they fill it with cement. Instant relief. And if your patient can have a little bit of anesthesia, I've seen this done on 80-year-olds, and then you don't have to give them anything for pain. Also, multiple myeloma. I've seen a lot of patients with films, and you'll see cement, 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 where their vertebral bodies have been had kyphoplasty. Okay? These are integrative therapies, tons of different ones. And I think it's interesting to note that the big push now is to get insurance companies to pay for this because they have not paid in the past. So don't tell us you're going to cut back on people's opioids if you don't give them something else to work with. Okay. So I want to show you a little bit. This is a good schematic showing multimodal. At the periphery, these are the things that work. Local anesthetics, opioid, anti-inflammatory agents, and capsation. As the transmission goes from transduction to transmission, over here to the ascending vertebral body, goes into the gray matter of the dorsal horn right here, switches over. These are the drugs that help to stop the pain from ascending. Local anesthetics, convulsants, anticonvulsants, opioids, ketamine, and clonidine. Up it goes, central, where it is perceived by the patient. So you know that when we do an epidural right here, patients still having pain from birthing, but they just don't know it because it's not going up to the brain, okay? And these are the things that work on the brain, the anticonvulsants, opioids, clonidine, acetaminophen, and then the brain sends a signal down to modulate it, and these are the things that work there, the SNRIs, the tricyclics, but more so our own endogenous system. Who here does long distance running? God knows I don't. Okay, have you guys ever felt this morphine, this endorphin high, our own inherent endorphins? No. Oh, sorry. Have you, sir? At what mile? Do you mind sharing? He says mile 8. Okay, lots of the nurses I talk to say mile 2. And they said it's really a powerful thing. But yeah, it's very interesting that we have our own endorphins. And this is why you very rarely will see an allergy to morphine. Because morphine, a true allergy I'm talking about now, not itching, nothing like that. I'm talking about a swollen airway, swollen lips, that kind of thing. Because we have our own endorphins and they're very morphine-like. Okay? Thank you for sharing. I won't ask you about that dramatic no. Anyway, here's some of the research and support for CAM. And these, and I put that in your handout. You can see all the different agencies, World Health Organization and everybody. And you can also see here this comfort guide. These are just some of the things that we see and we're able to do. 78% of patients so were unaware that there were any non-pharm options available. Yeah, that's weird. And you can see here, natural products are the biggest boom. And then you got all kinds of stuff, guided imagery, yoga. This is my beloved son-in-law, Jordan. He's having acupuncture for removal of his arm, his right arm. Notice the acupuncture's on the left side of his brain there. And I want you to get your mind out of the gutter, but this is massage. Okay, and notice it says Nutty Hudges Health Farm and Spa, but massage is really, really important. And at our place, we have a lot of aromatherapy, and the nurses will do a lavender foot rub to the patient, out, sleeping. It's amazing to watch. This is a patient that I had in the intensive care unit, and he had no family, and we knew he wasn't going to be leaving our facility, so this was his only family member. Now, this was in 1984, so you can imagine what kind of grief I took for doing this and the paperwork that followed to get him in. This is me at my clinic, seeing my patients, and you can see here, this is one of our fur angels that we had at Carmanos, and this is Wilbur. Wilbur retired when I retired. So he is a employee of Providence. We have 3 dogs, 2 or 3 dogs, yeah. And of course, sometimes it takes a bigger animal, and this is a patient that I had at Carmanos that was in hospice, and she loved baseball, and so here's our Tigers mascot, Paws, and he came to see her at the hospital. So I want to shift gears just a little bit and talk to you about genetics. I think the day's going to come, I won't live to see it, but I think the day's going to come where when a baby is born, we do a genetic profile on them. We can't do that now. It's too time-consuming and expensive. But there are drugs that we are doing genetic profiles on now that are very hard to manage drugs. Psych meds. They do it. Psych does it. Anticoagulants, antibiotics, and pain meds. Now, those of you that practice, have you ever had anybody say to you, that stinking hydromorphone doesn't work, which is Dilaudid, the Vicodin works better. Now, that should not happen. Hydromorphone is a much stronger drug, but it could be because of the patient's genetic makeup. Look at this. 18% of Japanese and African Americans, 18%, and 3 to 5% of Caucasians cannot metabolize certain drugs. And here, 7 to 10% and 1 to 4% of African Americans are lacking the chromosome 22, and they cannot convert codeine to morphine. So when patients say this doesn't work, we usually blow them off and think, oh, well, they want something IV. Don't rush to that. Sometimes they're genetic makeup. And I got to tell you how good this works. How many of you have seen a patient in the hospital for 5 days waiting to get their stinking INR up by using anticoagulants, and you can't let them go until their INR's in therapeutic range, only to find out it will never be, and they end up going on one of the newer anticoagulants and their INR goes right up. This goes on all the time. And so hence, the day will come where we'll be doing genetic readouts. And I wanted to show you this for those of you that do peds. Codeine, post-tonsillectomy has been pulled out by the FDA because In 2013, they had 4 children in the United States get the correct dose of codeine after tonsillectomy at night when they got home, only to have the parents go to wake them up and they were dead. And that's because they are ultra metabolizers and we didn't know it. So a correct dose of codeine in those kids proved fatal. So all around the United States, everybody's pulled codeine. Nobody's using it anymore. Now, we are being mandated by law to do patient education. And I think it starts with having a good relationship with the patient. Excellent, thank you. So your pain control is very important to us. However, we need to keep you safe. I think when we tell the patients that we're looking out for their safety, not just being mean and withholding pain medicine, you get a different response from the patient. Sit down if you can and talk to them at the same eye level. You know, I've always worked for education, like, you know, I've always had residents and fellows and stuff, and nothing bugs me more than when they come in with their huge gaggle of people at 6 in the morning, flick on the light, and stand over the patient and say, we're going to change your dressing right now. Drives me crazy. And that's because the poor patient doesn't even know where they are. We haven't had a chance to pre-medicate them for a dressing change. And this whole, what kind of a message does it send to the patient when you're leaning over? It's the I'm in control message. You're not in control, I'm in control. I think sometimes we have to be careful about our body language. Okay? It is your responsibility to keep me informed about your pain. Let me know how you're doing. And remember, we're going to medicate you so you can walk around and do the things you need to do to get better. These are the take-home principles for pain management. Accept and report the patient's pain. Whatever it is, put that down. There was just a nursing study to show that the nurses would hear, patient would say a 9 and they'd put down a 4. Remember, that is illegal charting. Always discuss the goals and plans with the patient related to pain. Use those non-pharmacologics. They will help you to be opioid sparing. Make sure you treat any side effects if you're given opioids. Think about interventions. Use scheduled and non-scheduled. Do not ever give any pain medicines IM, ever. We have a policy for that. Ascension does. And why do you think that is? Does anybody want to help me out here? Okay, IM medications are extremely painful. I will never forget the first time I went to the national conference for the pain nurses, and there was a lady on the board, and she was talking about the loss of her arm from an IM injection of morphine. We do not need to give IM injections. If you have an order for an IM injection for pain medicine, please call the prescriber and tell them you're going to give it sub-Q. Now the only difference, and that's in the policy, the only difference related to that is, I have to give you the exception to the rule, and that is Toradol. So if you lost your IV, you got to give the Toradol IM. I'm sorry, but that's how it works. But hopefully you'll still have an IV. Okay. Everybody should be looking at the prescription report. Go to oral before the patient gets discharged from the hospital. What the crap? I get a call on Friday nights, patients on high-dose PCA, 2 days post-op, they want to discharge the patient. No. Okay, the IV, you have to have them off the IV and on oral. How are we going to transition them home? If you take them off the IV, put them on oral, the oral doesn't work, they come back over the weekend in uncontrolled pain, that's a 30-day readmit, and the hospital loses everything because they did not take the extra day to make sure that patient's pain was controlled. So it's a big money thing. These are the caring behaviors, and I know everybody in here is a very caring individual. I got to tell you, the young girl that I showed you with the terrible addictive disease, many of the patients that come in with addictive disease, they haven't had anybody touch them. It's almost like they're a leper. When you touch them, it's just amazing. I mean, I just touch their arm. I'm talking about if they're comfortable with it. such a hard life they have. Anyway, you guys all have the ability to change somebody's life every single day with the relationship that you have with the patients and their families. So please, take a minute. You know how you would feel if it was you or your family. And I know it's a lot of work. God knows I know it. This is me starting my shift and my poor pain scales everywhere. I'm already tired out. But just remember that it could be you and it could be your family member, okay? I will take questions on this lecture. Anybody have a question for me here in the audience? And anybody out there, I would be happy to answer your question on Monday because I have to fly home tonight, and we'll be happy to do questions. Anybody got a question? Are you still awake? Okay. Oh boy. Yeah. Well, you know, like I'm sorry, I'm going to repeat the question. What is the recommendations for an elderly person with rheumatoid arthritis? I'm sorry, what was the last part of the question? Oh, that's it. Okay. Well, first off, are you maximizing your things like ice or heat? Now, most of the little seniors I know do not like ice. They like to be snug as a bug in a rug. So, like things like a heating pad. Now, if you have generalized pain all over, obviously you can't do that. But scheduled acetaminophen, as long as they're not having 4 martinis a day, and I'm talking about acetaminophen 1 gram, so 2 500s in the morning, 2 500s in the afternoon, and 2 before bed. That's 3,000 milligrams. That's 1,000 milligrams less than the daily average. And the reason I say that is because sometimes they're taking stuff like Tylenol, cold and sinus, and other stuff like that, and they're not keeping track of the amount of acetaminophen, which everybody in here knows is 4 grams, 3,000 in the hospice. So I just automatically do 3,000 for my seniors. But that seems helpful. Now, patients will say, Linda, I can't believe you're giving me that stinking acetaminophen. It doesn't work. It does work, okay? It is the #1 recommended drug on the Beers list for seniors. You got to give it scheduled, though. You can't just take it and expect the pain to go away. And I know this is really hard when patients have pain, but the more they move, the better. Osteoarthritis, rheumatoid arthritis, both. Movement, yeah. That's an excellent question. Any other questions? Okay, now we're going to start talking about meds. Okay, you know what? If you guys have a question at all while I'm going through these medications, please let me know. Okay, just raise your hand. We're cool in the time department. Okay, now the objectives we're talking about, pharmacology here. So do I have any advanced practice nurses here or PAs? Do I have any NPs? NP?
Yeah.
Great, where do you work? Sorry, urology, oh, he's gonna throw something at me. Urology center, oh, near and dear to my heart. Yeah, urology, ortho, urology, I did a lot of, yeah. Okay, great. So you know you get farm credits for this, right? Yeah, I'm sure that's why you're here. Anybody else, PAs, physicians also, get farm credits? Yeah, great. Okay, so we're gonna talk about the shift in pharmacologic agents, what we're using, and safety, safety, safety. All right. Okay, so we're going from a pinprick in the hand, right here, where transduction starts. Transmission then takes place, all heading toward the central spinal region via the nerves. Once it reaches the spine, right here, you can see there's the cord, gray matter, white matter, it's going to the dorsal horn, up to, now you're seeing your clefts and you're automatically having your nerves send the message. There's the enzymes that are going to come out right here that you got picked by a pin and you have pain. and they're going to their appropriate receptors, and there's the nerves, sending the message up the cord into the brain centrally. Okay, so basically it goes from the spinal cord. Come on, you can do it. Okay, and you know the substantia gelatinosa is in the posterior of the gray. That's where the opioids, that's one of the opioid places. Then up here, through the periductal gray area, and then into the hypothalamus, through the thalamus, a singular cortex, and into the cortex where the pain is perceived. Now this all happens like lickety-split, you guys. Let's say Linda slammed her hand in the door. You don't want my hand being in there pulverized till this takes place. So this is really quickly, and then the message goes down, Linda, get your hand out of the door. Okay, so this happens really, really quick. Okay, so when we were in nursing school, we were taught the 5 R's. And it's right agent, right route, right schedule, and right dose. But what's missing from here? Right patient. But we all hoping we're giving it to the right patient. But these are the really important things when you're looking at pharmacologic management of pain. Now, distribution has a really, really important role. And basically, if your patient has an ejection fraction of 20%, we're going to have a lot of trouble with flow issues, okay? You can see, are the drugs going to pass the blood-brain barrier? What is the concentration in the CSF? An example I'll give you on that, Ascension does not have the medication Ofirmef, which is IV acetaminophen. And at our place, we looked at giving oral acetaminophen pre-op in the pre-op area with a sip versus giving a dose of Ofirmef at $30 a dose. And believe it or not, now, did the Ofirmef get to the central spinal region faster? Yeah, it's IV. Didn't have to go through the first pass effect, right? Okay, well, basically, once that happened, the drugs were simultaneously in their area of concentration. So there wasn't a big difference between the analgesic power of Ofirmef IV acetaminophen, and oral dirt cheap acetaminophen. So we have, all of us use acetaminophen oral, okay? That's just an example. How about plasma protein binding? A lot of these drugs are heavy-duty protein binding drugs. One comes to mind is methadone, is highly protein bound. You have a cachectic patient, you got to be really careful with these people. Okay, so drug-drug interaction, you can have an additive effect. That means 2 drugs with similar action produce a sum effect. Synergistic, which means 2 drugs together combined effect greater than alone. Potentiation, 1 drug maximizes the second drug, and the liver enzyme effect, which I talked a little bit about the CYP450 system when I talked about ultrametabolizers. Okay, so here's the pain process I just talked about: transduction, transmission, perception, and modulation. This is pain by the neural mechanism. And you can see here that when you stick your finger with a needle or slam it in the door, these are the substances that get discharged. So wouldn't the idea be to stop these substances from making their way to the spinal cord to transmit the pain? That's the idea, okay? That's the idea of multimodal therapy. So let's talk a little bit about that. So as I said before, we have from the periphery to the central and up. But the thing that transmits are these 2 different types of receptors. An A delta fiber, which is myelinated and sends the lickety-split message, and then C fibers that are unmyelinated. There's an A beta too, but we're going to talk about C fibers, unmyelinated and slow construction. Okay, Linda has slammed her hand in the door. What's the first thing I do when I get my hand out of the door besides swear? What am I doing? I'm doing this, right? What am I doing? I'm using non-painful stimuli to override the pain. Gate control theory. I'm shutting the gate for the pain message and overriding it with non-painful stimuli. Okay, we do it, we just don't even know it. Keep that in mind when we talk about it, okay? So these are the enzymes being released. There's our cut, okay, and you can see the enzymes are being released. Now, there's the cut again. Here are the enzymes that are being released. And they get together and they send the message to the cord. The idea is to stop it right here. Stop it right here. Okay, what is a prostaglandin inhibitor? What kind of drug? Okay, you know, this is kind of like me going to Vic Tanny in my little leotard. It's a no judgment zone. So, you know, just tell me what you think. What kind of drug class is prostaglandin inhibitors? NSAIDs. They're all prostaglandin inhibitors, right? Because prostaglandin protects our stomach. And if you use a lot of prostaglandin inhibitors, that's the beneficial part, the patient can get an ulcer, right, or gastritis. But in this case, we want to block prostaglandins. I know some of you ladies have had cramps. That's all prostaglandins. That's why the ibuprofens work so good in the uterus. It's a prostaglandin-enriched environment. Okay? All right. So the idea is to block all these. Okay, I already showed you this, of which thing works in which area. But I want to show you this paper from the American Pain Society. And it had multiple inputs from different types of agencies and, of course, the docs. This, if you do post-op pain or you're a surgeon, this is a document you need to have. It's called Guidelines on the Management of Post-Op Pain. It is all evidence-based. There's 32 recommendations, and they're graded. And a panel did it, and they were almost unanimous in their consensus on all of them. This is a relatively new document. Okay. So we talked about the different types of pain before, but they're all treated differently. So somatic pain is going to be treated with an NSAID, which are the prostaglandin inhibitors and acetaminophen. Visceral gets treated with opioids. Neuropathic pain gets treated with things like local anesthetic, tricyclic antidepressants, and SNRIs. And by the way, you can have more than one of these types of pain. That's why your assessment's so important. So these are the ones I'm going to talk about today. I want to show you this. This is a cross-section of skin. And you can see at the very bottom, the deeper tissue, that's where the NSAIDs work. All right? In the tissue a little bit further up, the system antidepressants and opioids work in the bloodstream. And of course, at the very tippy top is where the local anesthetics work. So let's talk about NSAIDs. There's two classes of NSAIDs, COX-1 and COX-2. Now, ibuprofen is a COX-1. And they all have analgesic, antipyretic, and anti-inflammatory properties. They work in about an hour. The anti-inflammatory effects are maximum for about 2 weeks. This is the treatment that you use it on. You got to be careful with these drugs, though. If the patient does not have a good creatinine, and that's nursing's responsibility before they administer the drug. Nurses often say to me, well, I wasn't the writer. It doesn't matter. You'll go down too if you give the drug and it's inappropriate. So if your patient's got a creatinine of 3, you're not going to give them an NSAID. No way. Okay? And the responses are very individualized. Okay, so important facts. The NSAIDs bind to the platelets for the life of the NSAIDs, which is only 4 to 6 hours. So I'll talk about that in a minute, but this is what we worry about when the patient goes to the OR. No aspirin. And there is a black box warning related to cardiac. This is a patient I saw that had a total knee replacement. And I often shake the patient's hands or touch them, and she pulled back right away. I said, oh, look at those hands. She goes, yeah, they made me stop my NSAIDs 2 weeks ago. So you do not need to stop them that far back. She had more pain in her hands than her knee that was replaced. So yeah, Okay, so the NSAIDs and cardiovascular risks. This is a relatively new article by Dr. Paw. Basically, the longer acting the NSAIDs, the bigger the risk for heart failure. So I'll talk about the longer acting ones in a minute. And you got to be careful because these drugs, you retain sodium and water, and that's probably the reason. We have seen quite a few patients that were on NSAIDs and that were in really good shape, doing this jogging kind of thing that comes to mind, or doing a half of a marathon, have a heart attack related to NSAIDs. So you got to weigh the risk-benefit ratio, and it does have a black box warning on all the NSAIDs. This is ketorolac, otherwise known as Toradol. I love this drug. This drug works great. There are many patients now that don't even need an opioid post-op because they're getting this. And if you get it short term, it's good. It's very good. Okay? So these are just the dosing. I put all this, by the way, in your handout. Okay. So, all right. Do I have any neurosurgeons in here? I'm sure I do on the Ascension thing, though. Okay. So it's long been thought for 25 years that you can never give an NSAID on a patient that has a fusion. And why? Because they want inflammation to take place so the bone heals. The fusion heals together. Well, we went back and took a look at the original article, which nobody can find. And this is one of those things that is like almost folklore, like everybody's passed it down through the generations. Well, I retired before I got a chance to be on this article, unfortunately, but the neurosurgeons I work with are doing a study on the effect of ketorolac and post-thoracic lumbar spinal fusions. And they have one side that's a placebo side and one side gets the ketorolac. And there's no conclusions yet. They're still working on it. They need 200 patients, 100 in each group. But basically what they're doing is, in the group that gets the Toradol, they scan them to see how their fusion is and if it's melting together. Melting's not the right word, but that it's fusing together, okay? And so this is a really, really good article. It was in the British Journal, if you get a chance. And I put on here what the groups look like, what they each got, so you could see. Okay, topicals are the best thing since sliced bread. The problem, they're expensive, okay? So we're going to talk about that. But this is diclofenac patch, which I absolutely love. This is a patient who had her knee removed because of infection. So there's no knee in here, okay, yet. So you don't, that's not a normal incision for a knee replacement. But this lady was on dialysis, and so this is diclofenac, and I picture framed the incision to diminish the inflammation to be able to get her up. And it worked really, really well. And I'm not advocating any specific brand. I'm just saying that it works really good. We have it on formulary in Michigan. I don't know about the rest of the United States. Anyway, we just covered it up here, and then on she went. So the maximum amount of systemic NSAID, diclofenac, you would get from that patch, the maximum is 10%. That's it. But it's more like around 3 to 6%. Now, there's tons of creams that you can do, and you got to do a prior auth usually to get the patch. But I like the patch because the patient, unlike lidocaine patch, which I'll show you in a second, it gets changed every 12 hours. So it's 12 hours change and 12 hours back on again, where lidocaine is 12 hours on and 12 hours off. I'll show you that. Okay, so local anesthetics are great. They're great, great, great. Okay, and what do they do and how do they work? They decrease the permeability of the sodium coming in. Okay, so that's the idea. So here's lidocaine patch, and it was originally 5%. Well, guess what? Now it's over the counter at 4%, and we switched our formulary in Michigan, Southeast Michigan, to 4%, so that we know if it works before the patient goes home. Because our problem was we would put on a 5% patch, it would work, then the patient would go home and get the 4%, and it differed a little. So now we just use the 4%, we saved the hospital a boatload of money, and we could never get the prior auth anyway. Trying to get a prior auth for lidocaine was very, very difficult. And you can see here, there's the angry nerves, you put the patch on, the nerves calms down. And of course, the only I gotta back up and tell you that the only FDA approval for Lidoderm is post-hepatic, is shingles. And you can't put it on open skin like this. Okay, it's gotta go on the other stuff. And here it is again. This is like 4 dermatomes here. Shingles going back down the back of the arm. We used it for that. Also, lidocaine cream. Those of you that work in oncology, please, please, please put some local cream over the ports you access, or if you're sticking those patients. My son-in-law had cancer, and he said, I just couldn't take how many times they stuck me. So, you know, think about that when you're sticking these people. This is available usually on the units. Now, I know there's supposed to be a body attached to this leg, but don't just ignore that part, okay? So this is them looking, you can have multiple blocks done and or catheters inserted. We used to do a femoral for our knees, and we found that the patient's new knee would buckle. So we now do a lower block and have it run in, and it works much better. This is just somebody's leg. Okay, and of course we put in a device, and again, I'm not touting this, but we put in a device where local anesthetic can run all the time. Okay, acetaminophen. As I said before, we really didn't know how acetaminophen worked, but now we think it works centrally on the brain. We're pretty sure it does. So let's talk a little bit about it. It is well tolerated, used to treat osteoarthritis. Maximum dose, I told you, is 4,000 milligrams unless you're taking it with a martini. And you can see it centrally acts. And it inhibits the prostaglandin synthetase in the CNS. But it is not the same class of drugs as NSAIDs. So you can give them both. I had a discussion with the Joint Commission surveyor. Yeah. He felt that we were doing duplication therapy by giving both acetaminophen and NSAIDs. And that's not true, but I lost. Yeah. So anyway, be careful if the patient's got some history of liver issues, and of course, be careful of the patient's creatinine. All right, there's the antidote, Mucomyst, just in case somebody's overdosed with that. And I already talked about that. Okay, so here's the evidence related to acetaminophen for mild to moderate acute pain. And you can see the evidence there. Talking about NSAIDs being a second line to mild to moderate pain. All these kinds of things, very, very important to take a look at the evidence. What does the evidence show us? All right, now there's been a lot of discussion about ketamine use. Ketamine, you know, normally is in the anesthesia realm. But a lot of people now, a lot of anesthesia providers are using ketamine intra-op, and some of our facilities are using ketamine up on the nursing unit. And it can be given IV. And so I just put a little bit of information in here on ketamine, not a lot. It is an NMDA receptor, very similar in the same category as methadone, but not the same. And the idea is it doesn't cause wind-up, which is the constant repetitive pain signal going no matter what you do to treat it. And again, I just put this in here. This is from the American Society of Regional Anesthesia, and this is their sub-anesthetic ketamine in acute pain. I put this in your handout so you would have it if you need it. And this is how the nurse administers it, either by IV or a push, but you got to be careful your state nursing boards as to what you can do and what you can't. But it's really good for like wound care, like wound vacs and stuff like that. Okay, central acting muscle relaxants, there they are. We do not have Soma. Soma was taken off formulary for, I bet, 10 years maybe. High street value, very high street value. And so that is no longer, no. Be careful of these drugs like Flexeril on your little seniors because they'll be, trying to get away. Some of the drugs that I have found very helpful is Robaxin, especially on my neurosurgery residents. That's what the neurosurgery patients, that's what the docs like to use. And I like Baclofen, just a very little bit of Baclofen. And the nice thing about Baclofen is it does also help with neuropathic pain, just a little bit. All right, here's our tricyclics, and everybody in this room knows these. Elavil, puny little dose to start. We often will do 12.5 milligrams on our seniors, but lots of times we'll start at 25 just at HS. Just be careful, okay? These are the SNRIs. There's Effexor, there's Zymbalta, and thank you, sir. If you see your patient coming in on Zymbalta and Lyrica, those two drugs together, you have to continue those and then work on any acute pain above that. That is FDA approved for fibromyalgia. Okay, here are the second generation anticonvulsants. There's your Neurontin, there's your Lyrica. Remember, pregabalin is a Schedule 5 federal drug. And you can quote me here. I think in the next 2 years, gabapentin, the original drug, will be there also as a Schedule 5. Okay, these are not for pain. These are for anxiety. Well, I shouldn't say that. I mean, you could technically use Klonopin for pain, but you got to be careful, and these drugs cannot be abruptly stopped. My dad has terrible, terrible central itching. He has Parkinson's. And of course, there's no rash. It's just centralized itching. It was driving him out of his mind. So we decided to try a little bit of Klonopin. I already told you he was 91. I gave him 0.5 milligrams. Looked great, no problem. I gave him 1 milligram the next night, and he turned into Cruella. He threw his undershirt at me. He tried to escape. Can't escape, he can't walk. But he was like calling me every name in the book, and I could tell by the look on his face that was not my dad. So that's the end of that drug at that dose. Okay. But a lot of people combine these, and it's our responsibility to make sure that we tell them that this is a big safety problem. Big, big, big. All right, let's talk about opium. Everybody in here knows you got to have a DEA license if you're going to prescribe Schedule 2 medications and Schedule 5s. Okay, so as long as you are are doing it for a legitimate medical purpose, and it's done by an individual practitioner, not multiple people, and you're acting in the course of professional practice, it is safe for you to do this. I've had some surgeons stop me in the hall and say, well, Linda, I'm going to consult you on every one of my patients because I'm not going to write for any opioids anymore. No. Don't even try that trick. No. You're going to write. You are getting paid in your DRG for pain management, sir. And so you're going to write for the opioid if the patient needs one when they get discharged. Many, many people are afraid. I have nurse practitioners come up to me, PAs all the time saying, I think somebody's watching me. I don't want to write for any more opioids. Well, unfortunately, you have a DEA license. You take care of patients in pain. You're going to have to come to grips with that and do it safely. Never, never opioids alone. Never. So let's go through the classes. Number 1, Schedule 1, abuse potential so high that it's unacceptable according to the federal government. LSD and heroin are on there, and so is marijuana. I know you're getting a lecture next after me on marijuana, but I do have to give you a couple of things about marijuana I have to talk to you about. Michigan just voted in recreational marijuana to go with medical marijuana. God help me, is all I have to say about that. But anyway, this marijuana is a Schedule 1 drug, and federal law always trumps state law. Always. Should I say that again? So patients that say, oh, in Michigan, recreational, it's fine. I have a medical marijuana card. I'm bringing my marijuana into the hospital. Absolutely not. And why can't we do that? There's a couple of reasons. Shout it out. Somebody? Okay, number one, federal law, the government is who pays us, right? Medicare pays us. At Ascension I worked, that was the bulk of our reimbursement. Do we want to jeopardize that by giving a Schedule I, allowing a patient to take a Schedule I drug on the premises? Absolutely not. I don't care what state law is. Okay? That's number one. Number two, many, just since we're up and running, we don't know what's in that stuff. We don't know what's in those little gummy bears. We don't know what's in those chocolate chip cookies. I had a patient, ortho patient, and the nurses called me and said, Linda, he just came up from the PACU. He had a total knee done, and he wants to talk to you about his medical marijuana card. I said, okay, no problem. So I go up there, and he's got his medical marijuana card, and him and his wife are eating chocolate chip cookies off a paper plate. Okay? And I said, hi, how's it going? I get a chair, I sit down. He goes, cookie? I said, no, thank you. I said, sir, we got to talk. He said, well, I have my card here, and these chocolate chip cookies have THC and CBD in them. And I said, sir, you just got out of the recovery room. You still have anesthesia circulating, and unfortunately, I'm going to have your wife take these home. He was so mad. Now, we have a policy for marijuana and other illicit substances. Cocaine comes to mind, and it's not. Believe it or not, it's a Schedule II. We don't have many people doing LSD, but we got a lot of people doing heroin. So we have to be really careful of midnight visitors. But the whole idea here is until the government changes marijuana, THC, to Schedule II, which I don't think will ever happen in my lifetime because the DEA considers marijuana a gateway drug. I know. So like I said, I know you're getting ready to have a lecture on this, so I'm not going to spend a lot of time on it, but I just wanted to introduce you to what the policies are. There is also a policy on herbals. So if they're bringing in CBD oil, they can't have that either, just while they're in the hospital. It wasn't that long ago that many pain clinics, at least the ones I were associated with, that if the patient's drug screen came up positive for cannabis, they would discharge them from the clinic. But luckily, we're not seeing that much now. Okay, we do know that there is a synergistic effect between cannabinoids and opioids because their two systems converge in the brain, and we have CB1 and CB2 receptors. So, and remember, opioids are much less effective for neuropathic pain. They're not at all. So, let's talk a little bit more about the opioids that are legal. What's too long? Who can have it? Are we going to get to the point where it's the haves and have-nots, you think? The people that can afford their medicines will get it, and those that can't won't? For pain? Already seeing it. These are Schedule IIs. And notice the cocaine right here is a Schedule II. We have it in the hospital, in the operating room's pharmacy, and it is used in the head and neck patients for bleeding. It's a vasodilator. Vasoconstrictor to help with bleeding. But you can see there's all the other Schedule IIs. Okay. This is kind of like common knowledge in the operating room and in the anesthesia world that I worked in for 30 years. Morphine equivalents, oral, 300 milligrams equal 100 IV equal 10 epidural equal 1 intrathecal. So the closer you get to the spinal cord, the less drug you need. Now, why is it 3 times from here to here? What happens when you give 300 of morphine orally? What happens to the drug? First pass effect, right? So we're going to lose 75% of it, all right? And that's the reason that when you give it IV, you're not going through the first pass in the liver. This you are. All right? So just an FYI, you cannot give the same dose, 100 milligrams you're not going to give, but you can't give the same dose IV oral to oral. It doesn't work that way of any drug. Okay? Here's methadone. It is a synthetic opioid. It came about in World War II when morphine was at a shortage, so they used it on the soldiers. It's unique. Its structure is very unique, unlike morphine and Demerol. Here is how it's metabolized in the liver, and it may interact differently with mu receptors. It's interesting because it is dirt cheap. So in the cancer population in Detroit, we used it quite a bit. But this is a drug that you have to know what you're doing to give it. This is not a drug that residents give because, you only titrate it every 3 to 5 days. You got to titrate really slowly. It has an inverse relationship to morphine, okay? So if you're given all this morphine up here, like greater than 200 milligrams, you would think you would give a high dose of methadone, right? No. There's an inverse relationship, a very small dose. I'll show you. The good news is less people are dying from methadone overdoses in 2016, and you can start to see in 2015, 9.1% less overdoses, but you can see, there, look at that, 100% more synthetics. That's your stinking fentanyl in there. All right, so short-acting opioids, I put this in your handout. There they are, morphine, hydromorphone, oxycodone, and then these drugs down here are rapid-release opioids, and they require a REMS certificate to order them. Does anybody in here have a REMS certificate? I do. Okay, and basically you have to renew it every year and a half, I think it is, to be able to write for these meds, and they give you a test, which a 2-year-old could pass. Do you continue to give fentanyl to somebody that's not breathing? Yes or no? Come on. All right, I think they could make it a little harder, but anyway. So these are some of the issues related to opioids and chronic use of them. It's interesting because we very often do not talk about sex. The anesthesiologists I work with used to often say at Carmanos, yeah, this is Linda. She has a master's degree in sexual positioning and constipation. They thought I had a master's degree in constipation. I said, stop saying that, you guys. Anyway, this isn't something most of the men in the clinic would talk about, but I did write for quite a few scripts for Viagra. And the residents who had to rotate with me, because I was part of the faculty, would say, oh, Linda, these people are too sick for sex. Yeah, you keep thinking that. But anyway, and then we have addiction and diversion. So I want to talk about symptoms of opioid withdrawal. Who wants to give me the very first symptom that the patient feels if opioids have been withdrawn? Shout it out. Vomiting. You're on the right track. Stomach cramps is number 1. Who said that? Excellent. Yes, stomach cramps. It starts in the stomach. They think they have the flu. So they're starting to get crampy. Vomiting does come in. Then they're like, oh, something's wrong, something's wrong. They get agitated, they don't know why. And then it's just downhill from there. Diaphoretic, runny nose, vomiting, diarrhea. What's the treatment? Back on the drug. Hello? Yeah. Okay, so that's very important for you to know. So let's talk about buprenorphine. Again, it is a drug that we're seeing quite a bit of now. The laws are going to change related to who can write for it. That should probably happen within the next 6 months or so. But you have to be careful. Let's say somebody's in a car crash, he ends up in the hospital, and they're on buprenorphine. Okay? The buprenorphine sticks so hard to the mu receptors that is very difficult to give them anything else for pain. So there's been a huge discussion in the pain world. When you have something scheduled, a surgical event for a patient, do you stop the buprenorphine? Or do you continue it? If you stop the buprenorphine 5 days before, like many anesthesiologists would like you to do, then what do you do in the meantime? Is the patient going to go back to heroin? Do you know what I mean? You got all these different things that you have to worry about. So when the patient's on buprenorphine, you have to be careful giving other IV medicines, opioids, because there's no place for them to land. And so you have a huge potential for opioid overdose. And no one knows when exactly the buprenorphine is going to wear off. Okay, so be careful, because if it wears off and you got all this drug circulating, you could still have another overdose. So this is huge discussion in the pain world. If when a patient is scheduled for surgery, do you stop it? So this is an article by Dr. Lemke, and she talks a lot about continuing. She's an anesthesiologist, continuing the buprenorphine. So I know this is hard for you guys to see, but I put this is from her article, in the handouts, and it is an algorithm talking about what to do if you leave your patient on buprenorphine and they get admitted, keeping them on. That's the idea. All right, so you can use oral, you can use transdermal patches, or buccal. And I want to point out something else to you, because this has stung me a couple of times. There are implanted buprenorphine tablets that you won't know about if your patient comes in and they're not awake to tell you. Okay, so I get a phone call from the emergency room saying, hey, Linda, this guy's got like a little bubble in his abdomen. And I said, oh, you mean like a pump? Like an intrathecal pump? No, Linda, not that big. Come down here and take it out. Well, what the crap? I'm not taking it out. I said, call surgery. So I go down there, and what do they have? But this dosing mechanism here that was tunneled underneath the skin in the abdomen of buprenorphine. So the guy was like berserko. They're trying to give him something for pain, and of course they couldn't. They ended up tubing him, this and that. We did end up getting this out. But I just want to give you a heads up that it can be inside an arm, it can be there, it can be right here. It all depends where the physician put it. And if you're in the ED area and you're getting patients that are in car crashes that are on buprenorphine and it's implanted, it's something you really got to know. And it should show up on a MAPS, on a prescription drug system. Okay? Tricks of the trade. How many of you have a pain management they're called app from the App Store? Anybody? Oh, these are great. How do you like yours? What do you have? Which one do you have? Do you know? Oh, it's okay. Global Health. I just put Global Health up here because they have an advanced one too now. But Global RPH, and it's free, and they update it all the time. It's really kind of cool if you're interested into pain management. Now, tricks of the trade. As I said before, it's all about multimodal and function, but you got to use the correct pain medicine for the type of pain that you think your patient's exhibiting. If your patient says it's numbness, burning, you are not going to use an opioid first line. You're just not, okay? So don't forget the topicals and the integrative therapy, especially ice. Ice is our friend post-op. We use it on the shoulder patients. We send them home with these cooling things. And many of the patients tell me that their ice was more effective than their pain medicine, and so they didn't take the pain meds. Okay? Keep the expectations realistic. Think about preemptive analgesia. And there isn't anybody I know that doesn't like a nice warm blanket. We forget about these things. Okay, so it's post-op day 0, and it's coming up to midnight to go into post-op day 1, and the patient's on clear liquids. If the patient's like me, what are you going to get them? They don't think to ask for it. Ice, they think, how about coffee? A lot of people say, oh, can I have coffee? We have a Starbucks in the hospital. And so, of course, we get a coffee for them. And between the coffee and the nice warm blankets, we don't have puppies. But those things, it's really interesting to see the patients. They do really well. And there is a opioid withdrawal scale that I want you guys to take a look at. It's called the COWS, believe it or not, COWS. I think we're going to take a look at this Ascension-wide as time goes on if you don't have it now. So some more tricks of the trade. Remember, you cannot fix somebody's chronic pain when they're in the hospital. It just doesn't work out like that. You have to communicate with the person that's taking care of the patient's chronic pain. We already talked about buprenorphine and Suboxone. Methadone, I found out lately that patients that are on methadone do not have their EKG monitored while they're in the methadone clinic, that they expect the patient's PCP to do that. I've had patients coming in, I do a baseline EKG on anybody that's on methadone only to find their QTC interval 500. Hello? If you have too long of a QTC interval and we start giving you some more meds that lengthen the QTC, the patient could have torsades. And if you get them, if they go into torsades, you will have a very difficult time getting them out. So be careful of those EKGs. How about the patient arriving at the ED and say, I want IV only and that's it? That's a constant thing we're dealing with. Now, sickle cell patients often come in and say, I need 2 milligrams IV push when they're in crisis, and I need it again in another half an hour. Now, these are regular customers. We know them. If it's safe for them to have that, you pull up the record, they've gotten it in the past, they don't have anything else circulating that we know of, give it to them. I don't know why we aggravate people if it's something that they normally need when they're in crisis, okay? So here's my other favorite is IV Benadryl. They want it closest to the port and pushed as fast as possible for speed check. Okay, we're not doing that. So my standard is we have a policy and the IV push medicines have to be given slow and a little bit further back from the port. Okay, all medications brought in from home should be taken back immediately. And I already talked about cannabis oil and marijuana. So you got to have an exit strategy when your patient gets admitted. And again, the most important thing is to check your prescription drug monitoring system. You would be surprised. Patients say to me all the time, oh no, I'm not on anything. I pull up my MAPS, which is the Michigan one, and it says they just got 60 milligrams of OxyContin 80s from their PCP. Oh. So I take the MAPS, I put it on my lap, I sit down next to them, they can't see it, and they go, yep, nope, I'm not on anything. And I say, oh, okay. I say, do you know a doctor so-and-so? And they go, and I go, well, see, I don't know if you're aware of this or not, but we have this brand new tool where I can see everything that you've been prescribed that's a controlled substance, who gave it to you, and how you paid for it. Usually the discussion takes a big turn. Okay, so we know that opioids, the biggest problem we worry about is sedation. These are all Ascension approved scales for sedation from opioids, okay? And you can hear this is the Pacero opioid-induced sedation scale known as PAS. This is what we do not want. Frequently drowsy. You've had a patient, you're talking to them and they're going like this. I don't understand why I can't keep my eyes open. Yeah, that's that. No, that's not what we want. Okay, we also, at St. John Providence, put into effect a polysedative alert. Now this is for a teaching facility. So basically what happens is, we used to have like somebody in the hospital at night. He didn't know all the patients. The nurse would call and say, can I have a sleeper for patient so-and-so? They'd go, yeah, give them this, okay? Do they know the patient? No. So they're depending on the nurse not to give something that's not unsafe. So what does the patient get at 2200? They get a sleeper, they get something for pain, they might get some gabapentin, they might get a tricyclic, and at 2 o'clock in the morning you're coding the patient, okay? So we came up with this idea of the resident and the nurse both get a copy of this showing what the patient's current sedation score is and what was given last. So they can see what was given last and know what they can and cannot give. This is going to be in your Cerner or your computer system as time goes on. It has saved lives. I'm not kidding. It really has. Okay, these are, this is a PCA pump, as you know, and these are end-tidaled. You can always put your patient that's having opioid sedation on N-Titled. It is much more efficient and accurate than pulse oximetry. Okay, so it's really important to order that. These are the reversal agents, and I got to show you this one right here. I can't tell you how many times I've seen somebody given straight up Narcan, which is exactly what we should not be doing. You always have time to dilute it and give a couple of mils of 0.04 milligrams per mil. And the nurses know that. It's in the Pyxis. But they're given Narcan. The patient's not coming around. Make sure they didn't get something, a benzodiazepine. Here's the reversal agent. It's in your crash cart. You got both of these in your crash cart. Okay? And I also want to bring up, since I already brought up implantable devices, sometimes, believe it or not, patients make it into the hospital, get admitted, and they have an intrathecal pump inside of them. And then they code. Okay? And guess what? The pump's still running, and they're coding the patient. Okay? Nobody thinks to stop the pump. So in Michigan, we implemented this. These are $5. These are magnets. And they're in the crash cart, and it says, for emergency, place the magnet over the pump and tape it down, and the pump will stop. As soon as you remove the magnet, voila, the pump restarts. Okay? Anybody had this issue before, where their patient's been admitted with an implantable device and no one stopped it? And it just... She coded? Oh, Lord. Okay. $5. You don't need the rep. $5. I think I bought 100 of them. Okay, I got to repeat the question. The question, well, she was, one of the physicians here was saying that her patient coded and they had to call the rep. I would imagine probably a Medtronic rep to stop the pump. In this case, though, $5. Put this little label on here on the crash cart, and voila, you know right where it is. All it is a plain old magnet. Okay, you'll love this. This happened at one of the facilities. There is our Hospira PCA pump on eBay for $25. The pumps are $2,500 when we buy them. And here's the best part, and this is how we found out. You too could buy 50 keys to open this pump for $550. How we find out? A patient showed up at a facility in the state of Michigan with a PCA key. Opened his pump, gave himself everything, and walked out. Could not figure out how come the pump got open. Well, his crime, he went to a couple other Ascension facilities and did the same thing until security caught him with the key. Only to find out he bought the keys on eBay. And I want it noted that the baggie with all the keys in it says MICU, which means he lifted it from somewhere, from a medical ICU. So, the moral of the story is, watch those infusion devices. All right. I talked a little bit about our current practice of pain management being trial and error because of genetics. But I want to bring it up again. And I said that the codeine is no longer indicated for post-op tonsillectomies for children because of the ultra-rapid metabolism. And you can see here, the FDA did a MedWatch on April 20th of 2017, and this one has to do with breast milk. I have mothers, I get called for consults, and the mother says to me, she has no home, she's actively using heroin, she's going to go back to using heroin, and she delivered a baby and wants to breastfeed. Now, we are all wanting people to breastfeed, but this is a whole different discussion. You know, how much of that heroin or whatever else she's taking is going to be transmitted to her baby. And there was another incident where a mother with chronic pain had a fentanyl patch on and was breastfeeding the baby, and the patch ended up on the baby, and the baby died. So these are things we need to teach people about. Anyway, I have this book now called Hale's Medications and Mother's Milk. Come to find out, is a Bible of lactation, okay? And I mean, did I know any of this? Now, I know I said I was 64 years old, but I never even heard of pump and dump. So what they do is they have the mother pump and then dump the milk until they're off of the medicines or whatever it is they were using outside the hospital. And then, you're shaking your head, yes, you've heard of it. Don't throw anything at me, Don. Anyway, this pump and dump, and then comes to find out you can buy breast milk. It's for sale. And it's nice and clean. Yeah, I think it's expensive though. But just this whole, never underestimate the far-reaching issues related to the opioid crisis. Okay, patient education. 10 minutes. Oh, I'm doing. Patient education. Like I said before, I think it's really important for us to tell the patients that their pain control is important to us. I got to tell you that patients can pick up in 1 hot minute who really cares about them and who doesn't give a you-know-what. If you come in and you got a grumpy face and you're not having a good day and you're not present in the room when you're talking to the patient, they will pick it up right away. Now, am I saying you have to be totally upbeat and all that? But patients know when people care about them and they don't. This is by law, our new tool. This is the state of Michigan, but I'm pretty sure it's all around the U.S. Has to be put in the patient's record. It is a opioid start talking thing, and the patient has to sign it, and it goes in the record. It's not exactly a contract per se. Well, it kind of is short term for post-op care. But, they have to sign it and it goes in the chart and you have to do all this teaching stuff. And the one really good thing about it, they get this paper here along with the 50,000 other papers they get. But right here, we talk a lot about safe disposal of the meds because now we're starting to see fentanyl in the Great Lakes. So we're trying to figure out how to do something about that. All right, now, I love this slide. This, believe it or not, is not a joke. This is the Bristol bowel syndrome form. And these are different pieces of stool. And so I often will have the patient describe to me what their stool looks like. Now, everybody in this room knows that senior citizens, if they don't have a bowel movement every day and they're used to doing it, God help you, is all I have to say. I know I have a nurse here and an NP, so they know. Okay? So it's really, really important. And so when you're given opioids, you got to make very, very sure that they're on both a stool softener and a laxative. And if you haven't seen this, this is called subcutaneous methyl naltrexone. And if I would have thought of this, I'd be a millionaire. All they did was add a methyl component onto naltrexone, and it throws off all the opioids off of the colon for a little bit of time. It does not reverse the patient's analgesia. And they have a bowel movement, and then all the opioids go right back on when the drug wears off. This should be a stay in the EDs, man, for all those patients coming in. Now, the caveat is the patient cannot be obstructed. So you got to do a flat plate of the abdomen to make sure the patient's not obstructed, okay? But it does not interfere with pain, which is a good thing. So, that being said, I want to try again to open if anybody has any questions for me. Yes, ma'am.
I want to know, are massages still something for college patients?
Yes. Yes, I'm sorry. The question was, are massages still available for oncology? Oh, no. Absolutely. Sorry.
Increase the circulation in the
Yes.
area?
Yep. I'm sorry, I didn't hear part of your question. The question was, are massages still contraindicated for cancer patients, probably with bone mets and things like that? Absolutely not. They are not contraindicated, and believe it or not, there are massage therapists that specialize in massage in cancer patients that have bone mets and are very have the potential for a fracture. So they're very, very careful with those folks. We had them at the Karmanos Cancer Institute in Michigan. That's a really good question. Yes, ma'am.
Another one. Years ago, you should see it more often. If you had somebody that came in and
Okay,
Yeah.
Mr. Jones, after therapy at 4 o'clock, you could have a beer or
Right.
a shot of
Right.
liquor or whatever, and that was fine.
Right.
You really didn't have to use all of the pain medicines that they're giving people now. And that just brought to mind a man I had yesterday. At the end of the day, he's used to take 5 or 6 glasses of wine a day, and the doctor said it was okay for him to have, for his wife to bring 1 glass, the little bottles of wine for him in the evenings to
My face is twitching.
prevent DT.
Yeah.
And it's been working fine as far as I know.
Please don't say where you work. Please do not say where you work. Okay, the question was a while ago, and it was a while, probably 20 years now, we would be able to use alcohol on patients coming in that we knew were alcoholics and were going to continue to drink when they left, versus putting them on a CWA protocol, which blasts them into oblivion sometimes with benzodiazepines and things like Ativan or Ativan drip. And she's saying that she had a patient yesterday at an unnamed facility where the doctor ordered, told the wife she could bring in little bottles of wine because he was used to having wine during the day, and that we used to stock vodka, that I'm of that era, vodka, beer. We used to have beer in the refrigerator and stuff like that. That is an absolute no-no now. It is against policy to do that, and I don't care if the CEO physician at the tippy top writes for it. It's an inappropriate order. And unfortunately, if you carry out the order, you would go down with them. So don't give anything. If the wife's given it, that's another story. That should be confiscated, okay, because we don't know what's in it. That should be taken. There could be an interaction. If I had my pharmacist buddies here, they would like go berserko, okay, because you can't do that. And unfortunately, with all the different issues, and I know where you're going with this, because he's going to continue to do that when he leaves, so why put him on all the other stuff? And you're right. He'd probably be more functional, but we have policies against having alcohol in the hospital for treatment of alcoholic disease. Yes, sir.
We had a patient once who liked vodka, and her friend brought her a rose in a bud vase every afternoon. But the liquid in it was the vodka.
Okay, well, that bears repeating. One of the physicians here said he had a patient who liked vodka, and her friend brought her a rose in a bud vase full of vodka every day. Yeah, that's a good one. I like that. That's a good one. But no, unfortunately, we're trying to use evidence-based protocol such as the CWA protocol that we have throughout Ascension, grading the patient and how they're doing. The optimum would be to get them out of there as soon as possible. That's really the way to go. I do have to say that I did see about 5 years ago a trauma physician in his scrubs with his advanced practice provider walk and get a bottle of vodka for a patient and bring it into the hospital. No, can't do that. It's like, no. And again, what if something happened to that patient? There's interactions. Yeah, no, we can't. No. But I do remember having beers in the refrigerator and whiskey. We'd buy the cheap stuff. Yeah, not that good stuff. Yeah. So, thank you for sharing. Any other questions? Okay, thank you guys. You're done with me. Thank you very much.
Well, we'll wait.
Live now.
Yeah, I'm live? Okay.
We're live, we're up.
I think we're going to get started again because evidently we're streaming. So I'm just going to say hello to everybody in God knows how many hospitals for Ascension that's looking and watching. So everyone's gotten their coffee break after hearing about Relistor. Everyone's hit the bathroom, right? Good, excellent. Anyway, so I'm Dr. Andy Kaufman. It's my pleasure. This is my 4th time coming down, and I have my sound man, my friend Don here. We always talk barbecue when I come down because I'm from up in New Jersey. So I'm a professor of anesthesiology, but I haven't done clinical anesthesia in over 16 years. I do what's called pain medicine. I'm sure hopefully you're all familiar with that. And I'm the director of the pain division up at Rutgers, New Jersey Medical School. I'm the director of the fellowship program as well. I have no disclaimers. So what are we going to talk about today? We're talking about marijuana, or better yet, cannabis for medical purposes. So what we want to do is understand the historical context of marijuana, because it's been around a long time. This is nothing new, people. We'll talk about THC versus CBD. There are very important differences. We're going to get into the weeds a little bit about mechanism of action, because you really have to understand that to say, why does this really work? Why is this a viable treatment option? And then what are the medical roles for cannabinoids, which is a little bit different. Okay, some historical. Again, this is nothing new. This is something that's been around a long time. In 2900 BC, there was the first modern reference in the literature. Emperor Fu Sui mentions it as a popular medicine due to its yin, sorry guys, negative feminine, and yang, positive masculine. So it said it's to create balance within the body. And then in 1500 BC, it was actually written into the Chinese pharmacopoeia as one of their medications. The Chinese really far exceeded everyone in terms of creating medical bases. So this was listed as a actual medication for treatments. In 70 AD, the Roman texts cited cannabis, and they used it to treat earache and to suppress sexual longing in their legionnaires who were going out and marauding and rampaging throughout Europe. So they actually encouraged the use of this for their soldiers. Now let's jump ahead into 1850. Let's turn to the United States, and this was actually listed in the U.S. Pharmacopoeia Standards in 1850. So all these people saying, oh, it's this new medicine, 1850 was originally listed down in the standards. Now what about some of the first publications when we think of our modern journals? Well, The Lancet was probably the preeminent journal of the time coming out of Britain, and it was actually published in 1889. There was an article published on opioid withdrawal and treatment with the use of cannabis, or they called it Indian hemp. And I actually found the article, pulled it out. It was fascinating to read. So it was the use of Indian hemp in the treatment of chronic chloral and chronic opium poisoning. And this was in the wife of the Viceroy of India. I guess she wasn't real happy about being there, and she was addicted to opium. And so they used this to treat and to get her off of it. So it was by Edward Birch, MD, honorary member of the Calcutta Medical Society. So if you're so inclined, I know my slides are in your booklet, you can look it up. It's actually a fascinating read. Let's look about legal marijuana just in the United States, again, for our own context. In the 1600s to 1890s, there was an American production of hemp encouraged by the government. Remember, hemp is where we're getting our CBD oils right now. So it was required and encouraged to get rope, sails, cloth. Hemp was where we made things in the United States earlier. In 1619, believe it or not, the Virginia Assembly passed a legislation saying every farmer must grow hemp. It was a requirement. Where they were growing tobacco or corn, they had to grow hemp as well. In the late 19th century, the use of marijuana became as a popular ingredient in many medical products, sold openly in pharmacies. Remember, this is before the FDA, this is before regulation, so this was required. So in 1890s, smoking of hashish became a fad. We blame the French. It came over into the United States. And in 1906, the Pure Food Act required labeling of cannabis-containing products. So before that, it was in it, but no one knew what was in it. It was kind of the snake oil salesman. They come into town and say, here's the bottle of elixir. What's in it? Who the hell knows? But in 1906, this is the precursor to the FDA and all the other things we have, saying that, look, you got to label it. So let's look at a label. This is fascinating. Let's look at this one here. Cannabis indica. All right, and so you could just buy a pure bottle of cannabis indica. as opposed to cannabis sativa. But this was great. This was marketed as a cough syrup for children. So let's look what's in this, guys. Alcohol, about 4.5%. Cannabis, chloroform, and morphia. Right? Great cough medicine. Right? No coughing, sleeping, whatever. And this was, directions. Use 1/2 teaspoon up to 3 times a day. So, people walking around with it. This was sold openly in pharmacies. It was one-night cough syrup. Right? Not the day, because you take this during the day, you're not functional. Right? But look what's in this. Let's see, controlled substance. Chloroform, that was an anesthetic that was used early on, right? Cannabis and alcohol, that's a great mix. People do that now and we go, oh my God, you need to go to detox and you're an addict. So this was sold openly. But at least it was labeled. You knew what you were getting at this point. So let's look at marijuana and pain control itself, because that's a hot topic. All right, THC versus CBD. There are differences in this. Now, when we look at the 3 major lines of when we talk about the cannabis plant, the first is sativa. Think of that as kind of the party drug. Greater THC than CBD content. So when people want to go get high, hey, it's Saturday night, I want to get high, this is what they really want, right? They want the bang for the buck. Now, indica, reason it's here is generally referenced as into bed. Indica, very mellowing, very down, and it's a greater CBD content than THC. Then what about our ruderalis plant? Well, that's a marijuana plant, but that's where we get our hemp from. Now it's the vogue thing. It's, hemp shoes, hemp jackets, not just, sailcloth or what it was made for. Also, ruderalis is where all of the over-the-counter CBD products come from. That's why when one of my patients came to me and said, ooh, I got CBD oil, I go, okay, that's not so bad. You can buy it anywhere. Why? Because there's no THC, or the THC content is so minimal, like 0.000 whatever percent, because there's a tiny bit of THC in it, that you don't have to worry about. You can buy it over the counter because it's not a controlled substance. What makes it controlled is the THC, not the CBD. But the CBD is made from the ruderalis plant, from the hemp. Okay, so let's look at the plants themselves, the phyto, as opposed to something that's going to be synthetic. There are over 483 known components, of which the main psychoactive is delta tetrahydroxycannabinol. Let's just call it THC, it's easier. There are another 150 other cannabinoids present. And so the phytocannabinoids make up to 40% of the active agents. So when you take a plant and light it up, there's a lot of stuff going on. It's not just, oh, I'm getting THC or a little bit of cannabinoids. There's a huge amount of things that are going on when you actually light up this plant. Let's take a step back and let's talk about some terpenes. Does anyone ever hear of terpenes? Anybody? Terpenes? Well, you like the way flowers smell, right? That's from a terpene. Pine, that's a terpene. All these things that we have, those are all terpenes. They're oily compounds. Well, they're secreted in marijuana plants, and they're from the glandular trichomes. They're volatile, they're aromatic. If you have ever smelled marijuana recently, that's that very distinctive smell, that's terpenes. And they're endogenous throughout the plant world. They're ubiquitous in the natural world. 20,000 have been identified in the plant world alone. Marijuana is found to have over 200 different subtypes of terpenes. They're very similar to cannabinoids, except they have what's called a repeating aromatic 5-carbon ring. It's called an isoprene. And so that's what makes it a little different than cannabinoids. Kind of a busy slide, but again, this should be in your booklets. I listed down some of the more common ones and things that you're probably familiar with. Let's look at alpha-pinene, essential pine oil. It's the most common terpene in the plant world, and it's most found in cannabis. What are its natural uses of this? Everything that we use in pharmacopoeia now comes from a plant, right? Someone had to find it first and say, gee, the shamans, the medicine men, they just knew the plant world. They knew the things around them, and by using them, it would afford changes, right? So what do we see here? It's a potent bronchodilator. It's actually very helpful in asthmatics. It also promotes alertness, memory retention, because it stops the breakdown of acetylcholinesterase. All right, real things going on. Myrcene, it's another terpene present. It's a bit of a sedative, muscle relaxant, hypnotic, and maybe even a analgesic. So this is where you get the couch lock experience, where you're kind of like on the couch. Limonene, it's a major terpene in citrus as well as in cannabinoids. It's used to dissolve gallstones. That's where they found that in ancient treatments for gallstones, improve mood, relieve heartburn, and GI reflux. It's also known to destroy breast cancer cells in lab experiments. There's a lot of research going on in Israel using subterpene types to treat cancer directly versus using what we think of classic cancer chemotherapy treatments. It's very, very interesting work going on. Linalool, it's what you find in lavender, right? With aromatherapy, everyone likes their lavender candles. They go for a massage. They want to be massaged with lavender. It's an anxiolytic compound. There's a reason lavender is used in spa settings, right? Counters anxiety, mediates stress, and it's also a strong anticonvulsant. And the last one I wanted to mention is the beta-caryophyllene, and it's the oils of black pepper, oregano, and other edible herbs. It's gastroprotective. It's good for treating ulcers and maybe for anti-inflammatories. So there's a lot of stuff going on. These are all present in the marijuana plant that someone's going on and lighting up. So why is this important? Because we're going to get a combination effect. We call it the entourage effect. In other words, let's bring everybody to the party. Bring your whole entourage coming in. It's not just THC, it's not just CBD, it's the terpenes that are also affecting how this works in a pain control setting. So we know terpenes and CBDs are known to temper the psychoactive effects and anxiety effects of THC. Pure THC, and I know we have this problem in the Northeast, I don't know if you have it down here, where they're using what do they call it? K something, I'm blanking on the name. It's pure synthetic THC that we can buy in bodegas. Kids buy it in bodegas and they smoke it, and they have psychoactive breaks. And that's where people end up overdosing. You don't really hear people overdosing on just smoking a plant, right? But when they have the pure THC, they have these psychoactive breaks because there's no cannabinoids, there's no terpenes that blunt that effect at all. So when it's pure THC like that, it's actually very dangerous. But when you get the entourage effect, it's bringing all these other pieces that we talked about to the party to help with the anxiolytic effect, with the pain control. So that's why the plant is still better than something being created synthetically. Okay, let's look at when we think of classic marijuana itself. It's a very highly lipid soluble. So when you smoke something or ingest it by edibles or by oils, in the state of New Jersey, you can get that from medical marijuana, you get rapid CNS levels, and also it's a very long half-life in the body. So when we do urine drug screens, we're not screening for CBD. I had a patient come in and go, oh my God, I said, I need a random screen today. Why today? Well, that's why it's random, because he's on an opioid, functioning very well, but we do random screens. And he says, Doc, I can't do it. I go, why? You can't pee for me? Come on. He goes, I've been taking CBD oils. I said, don't worry, it's fine. As a matter of fact, I encourage that because you're not looking for CBD. We test for THC when we're testing for urine tests. But you can see it for up to 30 days in the urine. So what happens here, let's say patient comes in and says, I had one patient that wanted to do medical marijuana, went to do it, but it was too expensive for them to do it. The medical marijuana card in the state of New Jersey now is about $80. It used to be over $200 with the former governor who said he's legalizing it but put a lot of roadblocks up. But when they went to the medical dispensary, it was very expensive. And they couldn't afford it because it's not covered by insurance. Why isn't it covered by insurance? Because it's still a Schedule I in the federal system. Right? We're all used to scheduling drugs. Everyone know what I'm talking about, right? Schedule 1, 2, 3, 4, 5, right? So Schedule I drug means that there's no medical utilization and it's highly addictive. Schedule 2, there is medical utilization and still highly addictive. What's 2 are morphines, are oxycodones, Dilaudid, even cocaine because there are medical applicability. But as long as it's a Schedule I drug, none of the insurance carriers will cover it, even though it's legal for medical use in New Jersey, where I practice. So it's that weird juxtaposition right now. So they couldn't afford it, so he was getting it elsewhere and smoking it. And he said to me, look, it's going to be positive for marijuana. And I said, all right, I know I wanted you to do it, but you're buying it illegally, so you're now doing something illegal in the way you're getting it. So I said, I'm going to see it, and I'm going to have you come back in 3 weeks, and we're going to test you again. And that level better be down, because it's going to be there and coming down. I felt badly for him, but I can't write a controlled substance while he's taking marijuana illegally. If he was an end-of-life patient, I'm not going to care, but he wasn't. So I have to still go through the legal system with that, doing it the correct way. Okay, let's look at some definitions. Cannabinoid compounds act at cannabinoid receptors. Kind of makes sense. The main receptors are called CB1 and CB2. There are a bunch of secondary receptors, and we'll talk about a few of those. And the main ones are TRPV1, GPR55, GPR3, and GPR19. Now, what are these receptors? Technically, they're what's called a G-coupled protein. All right? When activated, they decrease adenyl cyclase in a dose-dependent way, thus they alter signaling. Well, sounds very familiar, right? I remember giving a talk here about 2 years ago about opioids and how they work. G-coupled proteins, kind of the same way. Opioid receptors are also G-reactive. But when they're activated centrally, they'll increase dopamine release, and that's how you get the psychotropic effect, which you don't necessarily get from the opioid. This is where we get our psychotropic effect. So let's look at CB1 in and of themselves. They're highly expressed in the nervous system, especially in the hippocampus, the amygdala, basal ganglia, cerebellum, nucleus accumbens, and the cortex. CB2 we find more in the spleen, intestines, thymus, testes, leukocytes, macrophages. It's kind of a very big difference, right? Then there's a CB2A, which we also find in the brain, spinal cord, and in the glial cells. So CB1 upregulates at GABAergic, which is inhibitory, right? GABA is inhibitory neurotransmitter, kind of a basic thing, and downregulates at glutaminergic. Glutamine is an excitatory neurotransmitter. Those are the two transmitters we're always kind of playing with. CB2 is a primary immune function. So here we're finding when you think about thymus, we talk about leukocytes, macrophages, that's an immune function. So that's what CB2 really regulates. So just kind of putting it on a graph here, and we can see, so CB1 activation, maybe improve depression, anxiety, will affect memory, maybe decrease pain. CB1 can also cause increased appetite, sleep. Now we're going out of the brain here. Now we think about, could there be decrease in neuroinflammation? We said they affect glial cells. Glial cells were thought to be helper cells initially. Now we know when glial cells are damaged, they cause an outpouring of inflammatory markers. And that may be where you get some chronic brain damage, but they're also looking at glial cells now for things like dementia, maybe even Alzheimer's. Is this a decreased function of glial cells? Kind of really interesting research going on now. So, what are some of the effects on the cannabinoid receptors then? We talk about how they work, all right? I know we were saying, wow, we thought it was just going to be pain control. It decreases IgM, IgG, macrophage activity, cytokine killer cells. It can cause decrease in total immune function when you're taking a lot of this. It can inhibit proliferation of delta, TNF alpha, and T cells. Those are kind of important T cells, right? So we'll get back to implications of that. But how do we think these really work? Let's look at the endocannabinoid system. We got receptors. They must be receptive to something in our body, right? We don't just have random receptors doing nothing. So let's look at the endogenous endocannabinoid, kind of like our endogenous endorphins, right? We talked about that previously. So we have a amantadine, and we'll call it 2-AG. It's too difficult to pronounce, my tongue twister. So amantadine is a CB1 agonist and a CB2 partial agonist, and 2-AG is a CB1 as well as potentially a CB2 agonist. So amantadine binds to TRPV1 receptors. Remember we talked about that's a secondary receptor, not a CB1 and CB2, but a TRPV1 receptor, and activates channels in the CNS and the peripheral nerves. It's a partial direct agonist to CB1 and CB2. And it's inactivated by something called FAAH, so fatty acid amine hydrolase. So what's the deal with this TRPV1 receptor? So transient receptor potential vanillinoid 1, which I still get confused at. So you find very, very high levels of this in the CNS, and they tend to be presynaptic, not postsynaptic receptors. And that's important because when you're going to activate them, you're going to decrease the release of neurochemicals. So the activation will actually lead to a burning sensation, meaning an increased kind of activity. And it's also very involved in temperature regulation. So let's look at capsaicin, right? Product in hot chili peppers. We use topically now, capsaicin, right? There's an indication for it for postherpetic neuralgia, but how does it work? Capsaicin is an agonist. Prolonged use causes a desensitization of the receptor. And capsaicin's like what's in hot food. So if you take a diet that you use a lot of spicy foods and then stick them in the Midwest somewhere and they have a very bland, non-spicy diet, and then bring them back 3 months later and say, eat whatever the hell you want, their head will blow up if they go back to that because they're not used to having that high level because they've been desensitized over time. So amantadine, as well as THC, CBD, activates the receptor partially. So you have that chronic activation. So that's where we talk about the use of these medicines are not an immediate. So when someone has their CBD tea, that's the hot thing now, or CBD in their muffin, or they give it to their dogs and dog biscuits, and they go, oh, I have one dose, I feel so much better. That's a great placebo effect, isn't it? That's not doing anything. You need to use it chronically. So when my patients even use CBD oils, I say, it's going to take 2 to 3 weeks, right? It's that constant buildup, that desensitization where it's going to work, not immediately. If it works immediately, well, that's great. And we like that, but it's not real. So prolonged activity leads to decreased signaling over time and thus decreased release of inflammatory markers, prostaglandins, bradykinin. So we're actually causing a decrease in the inflammatory markers. So thus the use of cannabinoids would affect pain relief, right? Desensitization over time. All right. Now, let's look at 2-AG. That's a full agonist at CB1, partially CB2. It's a calcium-dependent channels, which is more presynaptic, and it's inactivated by something called MAGL, M-A-G-L. How do we know about this? Well, there's really good animal studies, actually. You know, whenever we look at something, we want to look back and say, are there good animal models that we can look at to say, how does it really work? So if you take FAA knockout mice, meaning that they don't have the enzyme that's going to break down amantadine, they have increased levels of amantadine and show decreased pain sensation to classic kind of animal tests, which are hot plate tests, formalin, or tail flick tests. They just don't care. So if you give local administration of MAGL then into a hind paw of a rat, you're going to have increased amounts of AG2 locally, and you're going to have attenuation of formalin, meaning that they do this, they raise the 2-AG, then they inject formalin, which is an irritant, and the rats don't gnaw at it. That's kind of a classic test as well. So the FAAH inhibitor decreases allodynia, meaning pain to a stimulus that's not painful, and hyperalgesia in neuropathic rat models also. So that's really a very strong mechanism as to why when we use these products are they working on chronic pain control. Now, take a step back. Now we talked about some mechanisms. I'm glad I didn't do that talk right after lunch. I would have lost you all. You'd be like nodding down with into the weeds like that, but obviously I find that interesting. So THC, you can have it phyto, meaning from the plant, or purely synthetic. It's the primary psychoactive cannabinoid in cannabis. And that's, as we said, are the metabolites are the ones that we assay in drug tests. So it binds equally to CB1 and CB2, but the majority of the effects are CB1 within the brain itself, not peripherally. Now let's look at CBD. It's not psychoactive. That's why it's legal, right? You can buy CBD anywhere. You can go to the pharmacy here in Birmingham and get CBD. You can order it on the internet and it's fine. Because it's not illegal, it doesn't have psychoactive effects. It's not affecting our dopaminergic system. Now it's thought to protect against the psychoactive effects of THC, as I mentioned earlier. It also has a very low affinity to 5-HT receptors. Well, what's that? That's serotonin, right? That's our depression, anxiety. So if you can actually bind to those and increase that, you're going to have improved depression, anxiety. There's a very low affinity to CB1 and CB2, but it can act as an antagonist, believe it or not, at times, to CB1 and CB2 and to GPR55. Okay, there's evidence that CBD alters the absorption of amantadine. Right? We talked about that as our endogenous endocannabinoid. So is this now affecting it so that we're not having a breakdown? So that's why CBD is said, hey, 2 to 3 weeks to work, because you need to have a slow buildup to increase the amantadine in the body. But it also binds to glial cells. And by binding to glial cells, you have deep reproduction of cytokines, which are inflammatory markers centrally. And this is where we're going to see about neuropathic pain, why it may work really well. Glial cells, especially microglia, upregulations are seen in brain injury. So is this something that someone literally has a brain injury? Should we be giving them CBD immediately, which is going to have an essential effect to reduce inflammatory markers, right? Kind of interesting when you think about that. Okay. CBD is very extensively metabolized by the CYP3A4 system. It's only 6% bioavailable. It's kind of a crappy bioavailability, right? And its half-life is 1 to 2 days, not like THC where we talk about you can see it for 30 days. So you have to use it chronically. Again, not for acute pain. I know I'm driving this point home, but it's really, really important. But it's also a very potent inhibitor of something called the CYP2D6 system. Why is that important? Well, let's look at this, Coumadin. Right? A lot of our patients are on Coumadin. And they say, okay, we don't want to take NSAIDs, right? We know about that, right? Because we don't want them bleeding. You tell them not to take excessive acetaminophen. And we just I had a patient come in the other day. They know that they shouldn't take NSAIDs, and they were coming in for a procedure. I told them they need to be off their Coumadin for 5 days. They're off their Coumadin 5 days. The INR is still 2. And I'm like, what the hell's going on here? And I'm going through the list of medicines they're taking. They know not to eat grapefruit, other things. And they go, well, had a bad cold, and his wife was giving him 3,000 milligrams of acetaminophen a day. Why is that an issue? Well, you say it's acetaminophen. But what does acetaminophen do? It wants to bind to the alpha-1 glycoprotein that Coumadin binds to, even more so, and it kicks off the Coumadin, and you increase your free fraction. So again, you got to know the drugs. You got to know what's going on with that. So you can have a potent inhibitor, but it's also a potent inhibitor to affect tramadol metabolism. Why would that be important? Well, tramadol is a prodrug, as we talked about 2 years ago. Tramadol has to be metabolized to its M1 metabolite to actually be a pain drug. Otherwise, it actually acts like a SNRI. It increases norepinephrine and serotonin. So you're taking tramadol, patients are like, I'm taking tramadol, nothing's happening, and they're right. Because it's not getting metabolized to M1, but they're having this huge buildup of serotonin and norepinephrine. Let's say they're on an SNRI, you're putting them at risk for a serotonin syndrome. So you have to be aware of all the drug interactions. All right, now let's look at some commercially available. I didn't say necessarily the United States, but these are commercially available. Sativex is one of the most common ones, and this is vegetal, meaning it is made from the plant. So you do have that bit of the entourage effect. It's not a pure synthetic. It's an extract of the sativa plant, and it's an oral mucosal spray. It's a 1-to-1 ratio, and this is kind of important too. Why? Because we don't know the exact ratios. I was in a meeting recently, and there's no good meetings in the United States about medical cannabis because there's no research, so I was forced to go to Barcelona. It was horrible, and I figured, why not? Let's go for a week, and my wife came with me. But the meeting was fantastic because it was researchers from all over the world. And the few Americans that were there were like hungry for this information. And I kept saying to him, okay, tell me what's the optimal ratio? 1-to-1, 2-to-1, 5-to-1, 10-to-1 of CBD, meaning high ratios of CBD. And that's what they all said, that's what they're trying to research right now. We don't know the optimal dosing. We don't know, like when we give a pill, we say we're giving 100 milligrams of Lyrica. We know what we're giving. We know kind of where it works. We don't have that when we're prescribing medical cannabis right now. And that's where all the research really needs to go into, is what are the proper ratios and milligram dosing that's going to work the best. But this is a 1-to-1 ratio. This actually has an indication in the US, very specific, narrowed spasticity due to MS. So you can't really, you can try to prescribe it off label, but ain't no one going to pay for it. So let's look at a pure synthetic that we're very familiar with, right? Marinol. It's been around for a long time, right? It's been around since 1985. This is a synthetic, 98%. It's an oral agent, right? CB1 and CB2 receptor agonist, been around as an antiemetic chemotherapy and an appetite stimulant. Look at the bioavailability, 10%. It's really poor bioavailability. We looked at that when I was a fellow, as I say, back in the dark ages in 1992, and we said, oh, cool, Marinol, it's an adjuvant, let's add it for pain control. Did nothing. 0 for pain control. And then there was some experiments about adding it into intrathecal infusions, and they did this in animal models, thank goodness, and it was found to have significant central nervous system toxicity. So you can't distill it down to a liquid and shove it in someone's spine like we put pumps in, and it's like a garbage can, we put everything there. So it's a really poor bioavailability. It's only 10% bioavailable. So does it really work with an appetite stimulant? You know, I've had patients on it. It's a plus or minus. All right, now let's look at Sesamet. This is also a pure synthetic. It's a synthetic analog of THC, a CB1, CB2 receptor agonist. This is approved as an antiemetic, as a last-line antiemetic for chemotherapy patients. It is FDA approved. It's unapproved use where there's some research going into, which good research, for spasticity-related pain or Parkinson's. So there is some really good literature about that. So what are the potential benefits of cannabinoids? We've kind of talked about everything, how they work, where they're going. What are the benefits here? Well, we talked about antiemetic. We talked about Marinol already. It is a Scheduled III drug, Marinol. Anorexia, again, Marinol is approved. Antispasticity. Anticonvulsant. It's focused more on the CBD effects. You heard of the Lorenzo oil, right? They have made a big movie out of that. And for kids with spasticity. And actually, there was just a recent approval, very narrow approval, and I'm going to brain fart on the name of the very specific pediatric disease that's been approved for. It's a very narrow window, but it's for spasticity seizure. It's also being looked at neuroprotective, and we talked about the reduction in beta amyloids. That could be from glial and microglial cells, and also looking at traumatic brain injury. So this is where some of the potential benefits of that. And the anti-tumor effects. This is all the research that's coming out of Israel where they look at specific subtypes and are matching it to cells. And some fascinating research because it's not as, clearly it'll work, but it's not as poisonous as our current chemotherapeutic agents. So, where's the best evidence so far that we're seeing? It's in the treatment of central or neuropathic pain. And that kind of makes sense, right? After what I've set up in terms of how it's working and what it's doing, that it would work best in central and neuropathic pain. There's very little evidence that it works in nociceptive pain. Everyone remembers that, right? Nociceptive, you break your leg, that's nociceptive. You have a meniscal tear, that's nociceptive, versus neuropathic, which is from the nervous system itself. Right? Somatic pain means that something occurred, activated a pathway, travels to the nervous system, ascends to the brain. Neuropathic pain means the process starts within the nervous system itself. There's no starting information coming in. Remember, pain is a mechanical to a chemical to an electrical stimulus. So when you have neuropathic pain or central pain, you bypass the mechanical and the chemical, and you're just starting with the electrical. So cannabinoids can exert the anti-analgesic effects in the periphery. Well, we talked about CB2, right? All the different receptors there, and in the CNS. So, sounds great, doesn't it? And you have all the people from NORML saying, this is great, we should be giving this. There's no problems with it. It's perfectly safe. Never give an opioid again. That's evil. Everyone should be, doing cannabis, and the world would be great. But there are side effects. People can get addicted to cannabis. There is something called a cannabis use disorder, CUD. This is a psychiatric disorder. It's in whatever number psychiatric manifest it is now. 2 to 5% of the world's population uses cannabis every day in general. So look at the World Drug Report of 2017. That's the most recent one. So of those people in the world who sought treatment for addiction, 39% were for cannabis addiction, outpacing opioids at 33%. And all we talk about here in the United States is the opioid crisis. Everyone's getting addicted, people are dying, blah, blah, blah. Yes, there was a problem with that, but we can't just shove everybody into the cannabis pile right now because of the fact that there is a cannabis use disorder. And look, cocaine, lagging behind at 10%. These are the two major ones here. So 9% of all the cannabis users, remember we talked about 2 to 5% of the world's population uses it on a daily basis, not just on the weekend, but a daily basis. And of that 2 to 5%, 9% will fit into cannabis use disorder. Tends to be greater in males than females, younger age. There's a very high remission rate. It's actually higher than opioids for people relapsing once they've been treated for cannabis use disorder. It's almost 17 or 18%. What about some other side effects? Again, we don't want to say all is good. Acute side effects. For anyone in college who may have dabbled a little bit, tachycardia, right? Vasodilatation, increased heart rate, primarily in the elderly who use it. So an elderly patient who's in a medical marijuana program, taking it the correct way, and they're still maybe vaping it or not vaping like the vape pens, but vaporizing it, you can have increased myocardial O2 demand. They could have a heart attack in someone who has an underlying cardiac disorder. Arrhythmias. There's reports of sudden cardiac death with the use of marijuana. Sleepiness, fatigue, weakness, dizziness, dry mouth, the usual thing. Low blood sugar, which obviously leads to increased appetite. What about some other issues that people are using it chronically? That's the acute phase. Now what about chronic use? You hear these people, I've been smoking 30 years, I'm fine, there ain't nothing wrong with me. Well, increased risk of respiratory issues, just like smoking cigarettes. We're putting crap into your lungs and it's going to affect it. Look what's going on with vaping right now. Oh, it's supposed to be perfectly safe, it's fine. All of a sudden, all over the country, people are dying from vaping, right? We see that, it's, other than oxygen being brought into our lungs, we weren't designed to have other things being brought into our lungs, right? That's a bad thing. In men, significant increased risk in testicular cancer. Significant increased risk. Now, we talked about before, remember immune, it works on the CB2, decreases immune function. Well, guess what? We like giving it in cancer patients, right? We say this is a good treatment for them to help them with pain. But look what can happen. If you're on an immune therapy, not a classic chemotherapy, but let's say you're on one of the new immune therapies, you could actually have a decreased response in your cancer treatment because of the fact that chronic use of marijuana will affect your immune function. Remember, we talked about it decreases immune function by activating CB2 receptors. So look at this, 38% response to 16% response in cancer treatment. That's gigantic. That's 50% of the people using it there are not going to respond. Long-term use can cause structural changes in the amygdala and hippocampus. Memory. I don't remember crap anymore, right? Not just because I'm 57, right? So changes in volume, shape, gray matter density. This can affect chronically how the brain is actually functioning. So let's look at societal. This is I went to a great talk when I was there. Eva Hawk, who's at the Ludwig Maximilian University. It sounds better than UAB, right? Ludwig Maximilian has like a real ring to it. And she's a PhD sociologist, and she's looking at societal effects of this. And it's really she had a great talk. In teens, so she looked at teens throughout Germany, and because their health system there, remember, it's one payer, one everything, so they can really track everybody. It's really a nice way of doing it. So regular cannabis use led to lower education, significant association with high school dropout, decreased higher degrees, greater welfare dependence, increased risk of depression, bipolar. Now the question I actually asked her was this self-selecting? Did people who tended to have this problem already self-select for marijuana, or did the marijuana use bring it out? And there was no good answer to that, right? So it's, people who have bipolar disease, do they seek out this? Do they end up doing this versus the marijuana itself bringing out a bipolar disease, right? Kind of an interesting question. And it was dose dependent. The more you use, the greater the risk of all these problems. So let's look at some of the things that have been published in the US. The National Academy's Press, this came out. They talked about the health effects of cannabis and cannabinoids. It was 486 pages. It's a huge paperback. I've distilled it down for you. Just go to page 90. All right? Page 90 just said, after everything, that they concluded that there's substantial evidence that cannabis is effective treatment for chronic pain. Kind of a weird blanket statement, right? It didn't say what kind of pain, how it should be used. It was a very generic statement. All right, so let's look at some papers. We don't go back all that far because the research is not really going back all that far. One of the things I want you to look at with the studies that I'm quoting, look at the N. What does the N mean? The number of patients. If I submitted to a journal an N of 20 in a regular study, they'd laugh at me. They go, that's nice. Bring it back when it's an adult. Bring it back when you have 100 or 150 or 200 in N. But these were getting published because there was no other literature. There was nothing going on. So this was in Clinical Pharmacology and Therapeutics, Abrams, and this was cannabinoid-opioid interaction. So there's 21 patients, chronic pain. It was a myriad of problems, arthritis, neuropathy, cancer, MS, and they were using morphine or oxycodone. These are the average doses. They were on a long-acting agent. And you can see it's all over the place. And they gave them cannabis for all of 5 days, not 5 weeks or 5 months, 5 days. And what they showed was that they said that there was a significant decrease in overall pain by 27%. But the important thing to me was that there was no change in the area under the curve, meaning that there was no change in morphine use or oxycodone use. It stayed exactly the same over those 5 days, but they said with the addition of cannabis, pain went down. well, everything that we're hearing about now is, well, you give cannabis instead. But this was, again, very limited study, 5 days. All right, now, cannabidiol, this was published in 2014 looking at pure CBD oils. And you like the title, Promise and Pitfalls. And again, this is in your piece, but the synopsis basically said that there's a growing body that said it really works, but we must ask if we're getting ahead of ourselves. And I love that it's an emotional and politically charged issue, right? A lot of our politicians are saying, we're going to use this because, but do you really understand any of the science behind it? They're just looking to get reelected. They have a platform, the TV gets put in front of them or the camera gets put in front of them. They said that, look, they need to get well-controlled studies. There's some promising preliminary data. So they were taking a more of a wait and see, saying, look, we think it's out there, but we need better research to really quantify it. So what I did, and again, I always update this before I do a talk. So on Monday, I did another literature search. I went through PubMed, which is the best probably search engine for papers. I liked it when it was called Grateful Med instead. Before PubMed, I like that better. But so I did a full PubMed search, and the strongest studies in humans were for epilepsy and in Parkinson's disease. And this is in the Annals of Palliative Medicine. This is from December of 2017, Selective Review of Medical Cannabis and Cancer Pain Management, specifically cancer pain. What they looked at was cancer pain, and they looked at the literature from 1975 to 2017. Pretty long time. They found 5 clinical studies, 5, over that entire time of THC or CBD on cancer pain. And the treatments were all over the place. You can see there were THC oil or THC CBD oral mucosal spray that we mentioned earlier, or THC pure oral mucosal spray. So there was no real standardization. The doses varied all over the place from 2.4 to 43.2 milligrams a day of THC and from none to 40 milligrams a day of CBD. One study reported some improved relief with the combination, but both at lower doses. So there was no standardization here. So the authors felt that, okay, there's evidence that suggests, the key word suggests again, that medical cannabis reduces chronic or neuropathic pain in advanced cancer patients. So advanced cancer. Now, early stages, if they're on immune therapy, do you really want to put them on it and have the risk of having the immune therapy not work? I wouldn't. To me, that literature that we showed, that 38% to 16% is too strong. But if it's advanced cancer, maybe end of life, different story. All right, Journal of Drug and Alcohol Dependency. Evidence, I found all these journals I never knew existed, by the way. There's a journal for everything. Evidence of adjunctive cannabis use for chronic non-cancer pain, findings from the POINT study. Everyone has to have a great acronym. Pain and Opioids in Treatment Study. All right, and again, I know this is very busy, and I apologize for that, but I wanted to put this up there again because I knew you were going to be getting this so you can read through that. The bottom line, it was that cannabis use for pain relief appears common among people living with chronic non-cancer pain, and users reported greater pain relief in combination with opioids than when opioids are used alone. They didn't reduce their doses, but they said they felt better by adding that versus increasing their opioid dose. So it's almost like an adjuvant therapy when we're adding gabapentin or something like that. All right, marijuana and pain control. Let's look at Whiting from 2015. This was published in JAMA. They found moderate quality. They did a whole search and moderate quality evidence to support use of cannabinoids for chronic pain spasticity due to MS. And I apologize, I didn't put my phone on silent. I love spam calls. Low quality evidence for nausea, vomiting due to chemotherapy, weight gain in HIV patients, sleep disorders, or even Tourette's. So they found very low evidence for that. Medical cannabis for the treatment of chronic pain and other disorders, misconceptions of facts. This was published in October of 2017. And I like this paper a lot because they really took a good critical look and saying, okay, chronic and neuropathic pain, moderate to high evidence. So we talk about neuropathic central pain syndromes, and when I've had patients use it, this is where we have the greatest success also anecdotally than when I see patients. Spasticity with MS, I don't really treat spasticity patients, but that's also moderate to high, and seizure disorders moderate to high. GI disorders, there was a moderate literature, and in Barcelona, there was a leading gastroenterologist, he's from Germany, and they just concluded a gigantic study looking at patients with Crohn's, which is an immune disease. And they said, okay, it's a CB2 receptor antagonist. If we use chronic marijuana, it was a really well done study, big N, and unfortunately they found no effect at all in Crohn's disease. So he had gone to San Diego to present at a big GI conference, then flew home, stopped in Barcelona to present this material. So it's fascinating because everyone's saying, oh, let's use it, but they had the kind of a seminal study saying it really didn't affect the underlying disease process. We said, oh, it's an immune effect. If they block it, didn't do anything, unfortunately. HIV, in terms of pain, moderate. Glaucoma, which was always, when I was in medical school, and if anyone's of my age, we were always talked about narrow angle glaucoma, right? That was a great treatment for it. They actually looked at the literature and said, it's kind of low evidence for it. But that was the one approved use in the United States, and you would get it from where it was grown. I think there's a federal farm in Mississippi where they grow it, and there's one on the West Coast, and that's how you would be able to get it for that. PTSD, this is a big thing now with all of our wounded warriors coming back, that they're getting placed on medical marijuana for PTSD in lieu of psychotropics, but there's still low evidence, and Parkinson's disease. Olson and Wall, cannabis use and risk of prescription opioid disorder, right? And this is in American psychiatry. What the authors concluded here was that cannabis use appears to increase rather than decrease the risk of developing non-medical prescription opioid use and opioid use disorders. This was in September of 2017. Why do I say that? Because this paper, which came out in 2019 in Harm Reduction, this was a Canadian publication. They basically said that medical and recreational cannabis can result in a reduction in the use and subsequent harms associated with opioid, alcohol, tobacco, and other substances. So the one in 2017 said, no, it's making it worse. This paper came out and this said, no, maybe it's going to reduce the harm. So I'm a little conflicted with that too, because the literature's a little bit debated with that. So I thank you so much for your time. I always like to leave at least 8 to 10 minutes for questions. So please don't be shy. No questions whatsoever. Wow. I don't think I'm that good.
It looks like they'd have no trouble getting studies done since the incidence of marijuana is so high.
Well, there actually is a big problem with getting studies done in the United States because, again, remember, it is a Class 1 drug in the federal system. So it's not like we want to do a study on, drug X that's legal here. The biggest hurdle we have is who's going to pay for it, right? If the pharma company doesn't want to sponsor it because they're not looking for another indication, but we want to look at it, we have to get a grant to be able to get the study drug paid for, but it's not a big deal, right? But here, it is a very big deal to get the medication. And so you just can't say, I want to do a marijuana study and call the government and say, hey, can you send me some marijuana? That doesn't work that way. It's a huge hurdle. That's why the studies that we're looking at are being done in Canada, Germany, the Netherlands, and in Israel. Because in those countries, they allow the use of it for research. Now in Israel, cannabis is illegal recreationally. There's medical marijuana, but it's illegal recreationally. So it's still that, but they're allowing research. They understand that. In New Jersey right now, because we are a medical marijuana state, the new governor wanted to open up more dispensaries because the old governor, even though they had dispensaries, they were like 4 in the state. It was ridiculous. And it was very restricted. So they're putting out, and people want to get into it because it's big business, but part of the issue now is that if you want to bid to become a dispensary, you must then sponsor research, which means that whatever you're growing, and they want it to be linear, that they want it to be a grower who processes and then sells it. They don't want to get buying from someone else. They want it to be a closed system. And so I'm on the board of 2 different companies that are trying to get dispensary licenses. Why? Because I'm at a research institute and we'd like to do research on it. So if it comes through, what will happen is these companies will have to supply the product to us for research. Now, the problem is that how do we do that in the federal system where it's still illegal? I mean, so I think the way I foresee it getting around is that we would enroll patients in studies. They would have to get a special dispensation or card from the state that they're in a controlled study, go to the one dispensary, and then be issued the study drug. In other words, not going in and saying, oh, I have this, but be issued study drug. And the good thing is I'd be blinded to it, right? It would be a double-blind study. So the only people that would know what they're getting, because we look at a specific strain, the way I like to do the studies, I want to look at a very specific strain of it, so it's standardized. And then within the strain, what are the ratios of CBD to THC? 5 to 1, 2 to 1, 1 to 1. And then we'd have patients who would then cross over, right? So we'd have patients, because we don't even know where to start. And so we'd have a cadre of patients, and let's say we have 15 patients. I want them going in and getting study drug A or B, and they'd be randomized to that. In other words, we'd have 30 patients or 40 patients. They'd be completely randomized, and you'd have to have them use it for like 3 months. The study drug, right? It takes a while doing, and we do quality of life. You're going to do all these different separate measures of that, and then have a washout period where they don't do anything, use anything for about 2-3 weeks, and then cross over. And then see what are their pain scores, quality of life scores, functionality scores, and at the very end break the code and say, okay, was there a difference between the two? And if we saw a great difference in one or the other, we could say, look, this is where we need to start. It needs to be making it a 5 to 1 ratio, because 2 to 1 is just not adequate. So we're trying to quantify it, but hopefully that's where, I don't see it for starting in the next 6 months, hopefully in the next maybe year or two that we can get this.
One other question.
Sure.
You mentioned the growing of hemp in the early colony days.
I'm sorry, the what?
The growing of hemp.
Oh yeah, the hemp.
Marijuana in the early colony days.
Right.
That was not for psychedelics.
Oh no, that was for sailcloth, that was for clothing, that was for shoes. No, they weren't, they weren't smoking it. Remember, hemp has no, but the point is that they require doing that. I'll be done. I know, Lisa, we've got to cut it off. But they were required to do that because of, and now then hemp became illegal to grow for a long time. So that's what I'm saying, the irony of that. All right, I'm being cut off because I know this is being broadcast elsewhere. I'm going to hang out for a while. Please, 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 if you have other questions, find me outside. Thank you so much again. I really enjoy coming down here. It's well worth the trip. Thank you again.
Okay. We'll get started with the next talk. So I'm Peter Nagy. I'm one of the pain docs just down the street at UAB. I've been there 13 years now, and I practice both in the ambulatory setting at a pain clinic there and also on the inpatient pain service, and I still do anesthesia as well. Is the mic not working? All right, well, let me, is there a volume button here for this mic? How about now? Can you, anything now? Okay. Is there a volume here? It sounds like the sound is not working.
You're fine, it's working.
Can you hear me? They can't hear here in
I
the,
have overhead mics in here.
okay.
It's just for live, right?
Okay.
There's no PA system.
All right, well, I'll try to speak up a little bit to make sure, usually my voice carries, at least that's what my wife tells me to try to keep it down a little. So I'll just try to project my voice a little bit. So I've got no disclosures except for the support for giving the talk today and getting the day off today, which was very nice. And I saw from some of the other talks, you guys are getting a good bit of the background information, and we hear that in the news as well. So I'll try to move through the background information a little bit quickly, and then we'll go into some of the outcome studies linked to opioid prescribing and future directions. And I know my talk was titled Legal Issues, and there's a lot of the legal and kind of the medical rules that we follow here in Alabama that we'll talk about, but I'm not an attorney, and I certainly don't want to misguide anyone from that regard. But I also think it's great that we have so many different speakers from different perspectives, and I think as this opioid crisis has so many different, affects so many different people in different ways, it's great to hear from all different sides of the spectrum here. So, of course, you guys have all seen a lot of these statistics. The United States uses, we're 4.5% of the population of the world, and yet we use 80% of the opioids in the world, which to me is a pretty startling statistic. And when you look at the United States, Alabama is the #1 prescriber in the U.S. When you look at the number of prescriptions that are issued per 100 people, we are the highest. So that's something that I don't know that we can take as much pride in as we do the other thing that we are certainly #1 and have a dynasty in our football. And you see, this Alabama dynasty that we have for quite some time here, for at least the past decade or more. We've had a significantly higher rate of opioid prescribing than other states in the U.S. We're almost double the national average as far as the opioid prescribing. So it's certainly something cultural here. And they have also looked at, it's not about that we have sicker patients in Alabama. It's a cultural phenomenon. It's something that we have, and there's a lot of things that go along with it. And we're still twice the national average despite decreasing our opioid prescribing by 25% since 2013. You can see here, there's a pretty dramatic reduction. And this is a national trend as well. You can see here that overall the opioid prescribing across the U.S. has gone down, and that includes the high dose opioid prescribing has decreased. This high dose is over 90 MMEs. So that's also going down as well. But unfortunately, what we're seeing along with that is an increase in deaths from opioid overdose and the opioid related deaths. And that's something we know there's a connection here, and this is something that's been pretty well established, that the prescription opioid use is something that frequently transitions into more dangerous opioid use like heroin abuse and fentanyl abuse. 86% of urban and injection drug addicts started with non-medical opioids, started using opioids non-medically. So they've got pharmaceutical grade opioids from either their own personal prescriptions, family, or friends. And that's different than what we saw 50 years ago when people that were using heroin, they started off using heroin, whether they were exposed to it in Vietnam or other places. But now it is much more common to start with prescription opioids, develop an opioid use disorder, and then transition over to whether it's because of economics, transition over to heroin and even fentanyl. And of course, that's what we see in some of the other statistics as well, the increase in synthetic opioids, including fentanyl. And I think I've seen this slide in some of the other handouts, so I won't spend too much time. But needless to say, we see this increase in the synthetics and fentanyl, and an increase in heroin that's contributing to those deaths. And when we look at Alabama specifically, we are trending upward along with the national average as far as the opioid deaths. This is our opioid deaths have increased by 11% from 16 to 2017. And it's a concern. And you can look at this even more specifically in our county here. If you go to the Jefferson County coroners They release a report every year that's available online, and it's really interesting and eye-opening to go through some of these statistics. You can see where some of the deaths are and find where you live and see where the overdose deaths that are in those areas are. Overdose death is the most common cause of accidental death. It was in Jefferson County, it accounted for 59% of accidental deaths, which was more than twice the number of deaths from motor vehicle accidents. So that, again, is alarming. We take a lot of precautions in driving and wearing seatbelts and those things, and yet we don't talk much about opioids and those risks. Now, opioid overdose deaths in Jefferson County trended downward slightly this past year. You can see this big jump in the past 5 years, but they are down this year, 17 to 2018. That's most likely because of the decrease in fentanyl deaths. There's been a lot of law enforcement efforts focused specifically on fentanyl and disrupting supply routes, and you can't order it as easily through the mail as you used to. Heroin deaths are still pretty stable here, up by 5%, but that's, again, that's something that we've known about for a while. And when you look at where the opioid epidemic has hit us the hardest, you can see Walker County, and probably a lot of us that know there's a lot of referrals that come through Walker County, or people that know Walker County is one of the hardest hits, and you can see the number of prescriptions in Walker County is significantly higher even than other parts of Alabama. And that's how a lot of the law enforcement and a lot of the people that are trying to cut down on some of the unnecessary prescribing that leads to problems, that's how they're targeting. And you can find this, available online. CMS is looking at trying to reduce unnecessary prescribing, and there's an online tool where you can go to this website and just enter any provider. There's this is my name. You can pull it up and look at my prescribing, whether it's generics and the cost of what I'm prescribing, or brand name specific, and certainly controlled substances as well. CMS contracts out with some outside companies, and they are also looking at outliers for prescribing, and they send prescribers letters so you can get something in the mail that will tell you how you are, what your prescribing patterns are relative to similar practitioners in your field, and in particular, if you're an outlier, you'll get one of these letters. The PDMP is also, or Alabama's PDMP has been really progressive, and they've been also giving every practitioner who's registered with the PDMP will get these emailed every quarter. And this is your own report that will tell you about your controlled substance prescribing patterns, and you can see here it's by daily OME. It's broken down in a lot of different ways. It looks at how many prescriptions you have, under 50, between 50 and 90 MMEs, 90 to 200, and then over 200, and then how that compares with, and that's the different colors here, how that compares to you, a similar provider, and then others within your specialty. And then also treatment duration, how long are you prescribing? Are these short prescriptions for just a few days, or 7 to 28 days, or 29 to 90 days, or even longer than that, and then your prescription volumes. And also other controlled substances, not just opioids, but anxiolytics. And then another one that's certainly an important consideration, dangerous combination. So if you're prescribing opioids and benzodiazepines, or if you're just prescribing an opioid, but another prescriber is providing a benzodiazepine, then it alerts you to those. And those are important considerations, and that's when it's a really challenging part of our practice is trying to talk to patients about this, letting them recognize or letting them know about the risk inherent in that, and we'll talk about some of that as well. And this is just one more site. This is a watchdog site, ProPublica, where you can go in and look at different prescribers, look at prescribing patterns, and you can also look at prescribers that are getting money from industry, whether they're on speakers bureaus or other things like that. So it's interesting information as well, but you can look at there's a lot of different filters that you can apply to look at overall prescribing patterns. And this is interesting if you look at the state of Alabama. Hydrocodone is the #1 prescribed medication in the entire state of Alabama, more than omeprazole and some blood pressure medications and thyroid, but hydrocodone is #1. And you can also break down who's prescribing the most. There's a couple of guys in Huntsville that are they're top of the list. This guy was actually #1 nationally and this guy in his practice was number 3 nationally. So those are some things that stand out as red flags if your prescribing patterns are that far outside of the norm. That's something that you might end up getting some publicity for. And these are some of the practitioners. We see this stuff in the news every couple of months. Different doctors that have been accused of pill mills and really bad practice. They're getting blamed for a lot of the opioid crisis. Some of this is just, obviously they're dealing drugs, they're out there prescribing without any medical basis, and that's who's gotten a lot of the blame for it, but for our opioid crisis as it currently stands. But also, it's going beyond that now as we are also starting to see headlines. Jefferson County recently added their name to a lawsuit against opioid suppliers who should recognize some of these patterns where certain areas are getting just inordinate amounts of opioids into pharmacies with very small, in small population settings. Kentucky actually is suing Walgreens for its role, and Walgreens, they're accused of having a dual role as both as a distributor and as a pharmacy, and they failed to monitor their own operations in dispensing large amounts of opioids. And even more recently, this is a podcast on NPR that is looking at the hospital's responsibility. So even health systems and hospitals, what is their role and what's their culpability in patients who are getting large prescriptions, who end up, whether they're overdosing or becoming addicted and having problems. So it's certainly something that we're seeing across the board. But it's not just these big, big institutions. Sometimes you can even practitioners who seem to be doing the right thing. This I came across, and it's pretty disturbing when you see this is a doctor. The headline says she prescribed 3,600 pain pills to a woman who died, and that sounds like a lot, but when you read the article, it's 3,600 pills over 4 years. So that's really only 2.4 pills per day, which is less than, even if they're 10 milligram pills, that's less than 50 MME. So it's really not even a high dose yet. The problem was that in combination that Dr. Turnley was also prescribing a benzodiazepine, and so with that combination, there's certainly risk. She was accused of failing to properly recognize and treat addiction. The clinic where she worked was also accused of failing to properly train and supervise its employees. The lawsuit also included 3 different pharmacies that the patient was using, and all these defendants were accused of negligently, wantonly, and recklessly or willfully causing the patient's death by either prescribing or filling these prescriptions. So it's something that there's a lot of focus in this arena. So it's something that everybody is concerned about. What's the right thing to do? And fortunately, we do have some guidelines here. And again, the pendulum, we've talked about that a little bit already. I know in some of the earlier talks, the pendulum swings quickly in both directions. But we started in our practice really even before the guidelines came out with similar practice. I'm going to go through all these details, but I would contend that these guidelines, even though it was set for, these are voluntary guidelines, they're not prescriptive standards, and it's for patients with chronic pain. However, if you follow these guidelines for all opioid prescribing, I certainly think that there's a case to be made for that is a standard of care. They've really become representative of that standard of care, and legally, a medical expert witness, a medical licensing board, a judge, or a court of law could interpret these guidelines as a standard of what a reasonably prudent practitioner would do under similar circumstances. So I think there's something to be said here. Now again, the pendulum can overswing, and this was recently published in the New England Journal, the CDC. This was just in April. They advised against misapplication of the guidelines for prescribing opioids, because this was not intended for populations outside of the guideline scope. So active cancer treatment, certainly that's not, in palliative care, that these should not be applied. Acute sickle cell crises, and they also said post-surgical pain, but I'll contend, and we'll go into some of those studies, that surgical pain may be one that should be included here. The guidelines also do not support hard limits or cutting off of opioids. Clinicians should avoid increasing doses over 90 or carefully justify a decision to titrate above 90. So just taking a lot of caution, knowing that there's significant risk involved. And then They do not support abrupt tapering or discontinuation of the opioids. And just this week, the HHS came out with some guidelines about opioid weaning and put together some, just more information about that. But certainly we know that abrupt tapering or abrupt withdrawal can cause severe opioid withdrawal symptoms and psychological pain and psychological distress. And this does not apply to dosage recommendations for patients receiving MAT. The guidelines, so to go through them in a little bit more detail, they're broken down into 3 categories: when to initiate or continue opioids, opioid selection, dosage, and duration, and then assessing the risks and harms of opioids. So as we get into the details of this, and I'll put a little bit more information with them, opioids should not be the first-line therapy for pain, and I think we're starting to recognize that. The risk involved non-opioid pharmacologic therapy, NSAIDs, acetaminophen, counseling, PT, and blocks. That we really should look for other alternatives because, certainly, especially with mild pain, opioids should not be our first line. And here's some of the evidence and risk associated with these. Even gabapentinoids and tricyclics are something we should consider initiating first before opioids are started. Establishing goals for pain and function, and there's good evidence for this as well. Making sure that we are using, we're setting goals. We're not just using the pain scores and the numerical pain ratings, but you also want to include some realistic goals for function. And this is what they recommend in the CDC guidelines. At least this is a minimal 3-question PEG scale to look at how pain is affecting the rest of other aspects of life. So not just the pain score, but also the enjoyment of life and general activity. And if you start a patient on opioids and you're not making any progress in these other variables, you should reconsider, are you really helping your patients? And that's something that I think is important as well. Discussing the risks and benefits and using these patient treatment agreements. These used to be called opioid contracts. We don't call them that anymore, but discussing risks and benefits. We do that with surgical procedures and with other things. Now that we know and are aware of more of the risks of opioids, that should be a discussion up front. This is our old opioid contract that we used to have, including, this was mostly to keep patients from calling after hours and asking for refills, and even this said the risk of dependence, which I understand is very rare, and that's something that we put in our contract. Well, when you look at it, that actually is not accurate. There are some pretty significant risks, and this is a study that was published in 2014 looking at the role of an opioid prescription and the development of dependence. And so, again, this was my era when I went through my residency and fellowship. In the late 90s, we were all told that there was almost no chance of addiction if you're treating someone for legitimate pain. And this study looked at that claim, and they looked at 500,000 patients with a new chronic non-cancer pain diagnosis and no opioid therapy prior to the study and no opioid use disorder. And what they found was that a single prescription for an opioid increased the patient's risk of developing an opioid use disorder by 3 times. Low-dose chronic opioid therapy increased their risk by 15 times, and chronic high-dose opioid therapy increased their risk of an opioid use disorder by 122 times. So there certainly is risk associated with opioids, and the longer term that you're on these, so that was their conclusion. Opioid exposure is a risk factor for OUD, and the duration of therapy was even more important than the daily dose. So the longer you're on it, the more likely you're going to develop a dependence and ultimately put you at risk for an opioid use disorder. So that's where this short-term treatment for acute pain, I think that's something that's also important, and that's why in the post-surgical patient population, we really should be looking at the shortest duration possible. And long-term opioid use often begins with the treatment of acute pain, so really 3 days or less will often be sufficient. Rarely will you need to write a prescription for an acute pain episode for more than 7 days. This is a study that was published in the CDC's journal in 2017, and it looked at the rate or the probability of continued opioid use in patients that were previously opioid naive. And what they found was that The rate of opioid use after 1 year and at 3 years increased significantly. It was a pretty direct correlation here depending on the initial prescription, how much they were given. So you can see here if they were given a 5-day supply, the probability of continued use at 1 year was less, but the longer the prescription, the more days in that first prescription, the more likely they were to continue at 1 year and even at 3 years. So it's pretty concerning information when you start looking at it that way. And this was in all patients that they looked at, but if you look at specifically surgical patients, this study was published in the Archives of Internal Medicine in 2012, and there's actually several more that are like this. I just will present this one because this was a low-risk surgery. So these patients that had a low-risk surgery, they were not previously on anesthetics. They looked at 390,000 patients. These were all older patients because it was a Medicare database that they used, getting cataract surgery, lap choles, TURPs or varicose vein stripping, and they assessed them at 1 year to see if they were, how many were continuing to be on opioids. And what they found was that 7.7% of opioid naive patients that were given opioids after surgery were taking opioids at 1 year. That's a 44% higher than a matched cohort that did not receive opioids. And so you can see even some patients that were getting opioids after cataract surgery, you see the increased risk associated with that. So there certainly is opioids after surgery, including low-risk surgery, is associated with long-term use. And there's other studies. This is not just because these patients are older and have arthritis and other things that lead to that, because these numbers bear out in other populations as well. And it's not related to how much pain they were having after surgery. This I thought was a really interesting article published in JAMA Surgery looking at, this is 18,000 patients, and they compared the amount of pain that they reported in the 24 hours prior to being discharged from the hospital and compared that to what the prescription that they got going home, how many opioids and what kind of prescription. And what you see here is this big blob. There was no correlation between their 24-hour pre-discharge opioid use and how much they were given. Matter of fact, this is zero. These patients used no opioids for 24 hours prior to discharge, and you can see, and this is a logarithmic scale, so you can see here how much opioids these patients got, even though they did not use any before discharge. So there's no correlation. A lot of this is just a habit. We've given patients opioids. We always have. We thought it's the right thing to do and told them if you don't need them, just don't take them. But there's risk associated with that as well. So using immediate release opioids when you start it, and that again seems intuitive that you would not use long actings, but there's really no evidence that the long actings are any more efficacious than the short actings. And even though OxyContin initially got the FDA approval that it was safer because of its delayed release formulation, we know that information was not accurate, and there's a lot of lawsuits that are currently against the Purdue company because of that. So you can see here really between pain, function, even side effects, there's really no evidence that long actings are better than short actings. There's no evidence that it reduces the risk of opioid use disorder or addiction as well. Number 6 here, using the lowest effective dose. Certainly developing, and that's what there's been a lot of pushback on these dosage thresholds and these numbers, the greater than 50. They recommend using caution over 50 and avoid increases over 90 for non-cancer pain. And where that comes from, again, this is one study, but there's a few others that looked at dosage, opioid dose and drug-related mortality in patients with non-malignant pain. And so when you look at this, certainly you can see this is a dose-dependent relationship. The risk is much higher at greater than 200, 100 to 199, and 50 to 99. Now, once you get below 50, the deviation here becomes almost back to baseline, but there's certainly risk associated. The other thing, and this is an interesting study that I actually used to present some of these, the older studies here in other talks. Opioid-centric analgesia or opioid-based analgesia doesn't really work well. This was a study where they called patients after surgery to ask them about their pain. a very simple questionnaire, and it was really more asking about how well we treat pain. And you know, over the past 20 years, the amount of opioids we've prescribed has really soared. Well, in that time frame, these numbers have not changed at all. So this is a study that was done in 2014, the dark black. 2003, really the numbers have not changed, and 1995, Carol Warfield and their group did this study. So they called patients to ask them how their pain was after surgery, and this number has really been pretty stable despite our greatly increasing the amount of opioids that we prescribe. So let's see, evaluating the benefits and harms frequently, and that's also in a chronic pain setting. If you're starting patients on opioids, you should follow them frequently, certainly reevaluating after initiation within 1 to 4 weeks, and then at long term, at least every 3 months, to make sure that your the benefits and the benefits are exceeding the harm. Because again, this is back to that study. The more refills you prescribe, the likelihood of patients remaining on opioids at 1 year and 3 years continues to go up. That's again that direct correlation there. Using strategies to mitigate risk. So there's many risk factors when we talk about overdose deaths, and some of these are medical risk factors, sleep apnea, renal insufficiency, mental health conditions, but other medication related, higher doses of opioids, concurrent benzodiazepine use, and history of overdose. So patients that have higher risk, getting a prescription for naloxone along with that prescription. And what I've found in our practice as well, many patients don't fill the naloxone. It's expensive at the pharmacy. There's a lot of issues, unfortunately, but what it does is opens up a conversation. A lot of times patients hadn't even thought about the risk associated with it. They're hurting and they want something for it, but once you tell them, I'm going to recommend naloxone because of the risk of overdose death, and it really it strikes a chord, and in many patients that's the first time they might have recognized that there's a risk of combined opioids and benzos or a risk of death. And we've started doing this in our preoperative clinic, even the patients that are coming in that are having surgery, and we recognize that they're going to get opioids after surgery, but they're already on a benzodiazepine, or they have a history of substance abuse, or they're already on higher dose opiates. We know they're going to be at higher risk, and so we give them that prescription. We send it to their pharmacy, and many times we've even noticed some patients won't fill their opioid if they had a minor surgery, and we talk to them about the risk of combining a benzo with an opioid. They won't fill it. So it is definitely a conversation starter. It lets patients recognize, if they hadn't thought about it before, that there is a risk. Other risk tools, and this is something that's been around for a while, the opioid risk, if you're in a chronic pain setting or a chronic pain clinic in an ambulatory clinic setting, making sure that you're using some type of risk assessment and looking at family history of drug or alcohol use, personal history of drug, alcohol use, and then psychological comorbidities. Those are risk factors as well. And then reviewing the PDMP. This is something that certainly every time you, at least periodically, every time you write a high dose opioid, or periodically, at least every 3 months, you should do this. Urine drug testing is also recommended on a regular basis, and this is again from the CDC guidelines, and this is good practice for sure. Avoiding, this is the recommendation about concurrent opioid and benzodiazepine use. So if you can avoid it, you should. There's, again, a couple of studies on this. This is one that was in VA patients, and they looked at patients who received opioids who died from a drug overdose. They had 2,400 patients, and they compared them to a random sample of 400,000 that received opioids. And what they found was that 49% of the deaths occurred in veterans that had concurrent prescriptions for benzodiazepines and opioids. And that risk of death was 2.3 times higher when they had when they had a history of benzo prescription, and 3.8 times higher when they had an active prescription for a benzo. And you can see here this went up with dosage. This was again a dosage related phenomenon. So there was certainly an increased risk of death. Opioid use disorder is again part of our considerations. Many patients that may develop an opioid use disorder over time. It's a challenging thing to diagnose in someone in particular if they have a chronic pain disorder, but it's an important thing to be looking for consideration of medication assisted treatment with buprenorphine, methadone, or Vivitrol, and of course you need to combine this with psychological counseling, a 12-step program, or other adjuvants. It's going to be more effective in those settings as well. So, future directions. As we recognize, that the risk associated with opioids, we've initiated, a lot of institutions have initiated stewardship programs, which became popularized about a decade ago with the antibiotic stewardship. Once you start recognizing the risk of overusing antibiotics and drug-resistant strains, and the importance, and a lot of hospitals embrace these antibiotic stewardship. Well, in the same vein, opioid stewardship is a concept that a lot of hospitals and health systems and providers are embracing, and it's really just the concept that the system, the clinicians, pharmacists, and patients must take a shared approach to the use of opioids that recognizes their potential for harm and looks for non-opioid options whenever possible. And we've developed an opioid stewardship committee at UAB, and there's a lot of different models for how you can do that, but it's in ours, it's headed by the CMO's office. And we've got a full-time pharmacy lead and a full-time administrative support with a project manager, but informatics is really important, and there's a lot of people that sit on that committee that help out and look at this issue in our system from different angles. We've created some information for patients that are coming through surgery that we can let them know about what are some of the options they have. And it directs them to a website with video information about, again, reiterating some of the risk associated with it and what alternatives are available. And there's a lot of resources for both providers and patients. But that's within our system, but anybody can have access to the Alabama's mental health Department of Mental Health has done a really good job about opioid stewardship, and they also have a website with some of the same type information. They've got video links with information. They have a provider toolbox and also printable information that can help with some of the issues and some of the resources that are needed. What we've done in our system is utilized our electronic medical record. It can be a very powerful tool, and we're just starting with a few of the CDC guidelines and looking at prescription, the length of prescriptions. This is one of the metrics we're starting to track, and we haven't done anything with it, but just tracking the metrics and allowing people access to these dashboards. A lot of times we'll let people know where they are in reference to their peers, but looking at prescriptions greater than 7 days, we're looking at opioid use as a first line, so patients with a pain score of less than 4 if they're getting opioids, and that's prompted us to also revise some of our order sets so that we have lower default settings and non-opioid options are coming up, so it's a little bit easier to prescribe. We've got an opioid calculator that will tell us, and PDMP has that as well, but within the Cerner system there's an opioid calculator, and it has some high risk alerts built in so that if there are whether they're medical comorbidities or drug-drug interactions. And e-prescribing is something we've just, I think by the end of this year, everyone will be mandated to use e-prescribing, which is a really, many of these EMR tools have created more work in the past when we've gone to an electronic version, but this e-prescribing has been a wonderful kind of a change for us. It's much easier when you need to change a prescription or send something directly instead of patient having to come to the office and pick up a physical script. Now you can send it directly, and there's a two-factor authentication that's required. So there's an app for your phone, and then there's a fingerprint. So you just put the order in, and it pings your app, and you hit accept and do it, and then it goes directly to the pharmacy. So it's a really nice system, and it also allows tracking, so everybody's prescriptions, it's much easier to keep up with and really look at prescribing patterns. But again, that's our Cerner system. The PDMP is available to everybody, and that's everyone should be accessing that's prescribing already. And that's one more link that they did in our EMR. Now there's a direct link, and a lot of health systems are going to that as well, where you can click from your EMR directly into the PDMP instead of having to open a separate window and log in and then enter all the patient's information. It's pretty cumbersome. It's hard to use, but now there's actually some grant funding available from the state so that health systems can incorporate this directly. So now in ours, you just do one click and it's got the patient already pulled up, you're logged in already, and so it's much nicer. And this is the kind of information you can get from the PDMP. They've just upgraded to include this NARC-X score, which is very helpful. It actually looks at some of these risk factors, the number of prescribers, the number of pharmacies, the amount of MMEs, which is the morphine equivalents, and also LMEs, which is lorazepam milligram equivalents, which is a pretty new metric to track, but and then overlapping prescriptions, and it'll use those to generate a NARC-X score, and you can see here the odds of unintentional overdose death increase as your NARC-X score goes up. So I think that's also a useful tool to use. So all these precautions, these are, I think it's good medical practice, but it's not just that. Much of this has become mandated by the Board of Medical Examiners in our state. We started in 2014. There was this was the first requirement for the use of controlled substances in the treatment of pain. So this was the first bill that required physicians who were advertising for pain to register with the state, and that was along with anybody who was dispensing controlled substance or the top 3% of prescribers of controlled substances. So along with that, you had to register with the state and go get fingerprinted and all that, but they're really trying to identify who were the outliers back then, and that was, again, 5 years ago, and I think some of those things have gotten really addressed very early on. But within that, there was also some specifics about what was required of treating pain patients. You had to, there must be an H&P to document the presence of a medical indication for use of controlled substances. There had to be a plan, and which included a goal of reducing pain and improving function. Alternative non-opioid treatment modalities should be considered, and then informed consent for the treatment, including drug screening, prescription refill policy, reasons which the drug should be discontinued, and patients receiving prescriptions should only receive prescriptions from one physician and one pharmacy, and periodic review. So again, this was in 14, our state passed this, and which included a lot of the same parameters that were in the CDC guidelines. So physicians should monitor compliance regularly in treatment plans. In 17, they added some mandated risk mitigation strategies. So these, you don't have to follow all of these, but certainly documenting and that you are using some risk mitigation, including either urine drug screens, a PDMP check specifically are required, but having other validated risk assessment tools, co-prescribing naloxone in patients that are deemed high risk. So these are all things that the state has now put in the medical board's requirements. The PDMP requirements are very specific for OMEs, greater than, so less than 30, it's at the physician or provider's discretion. Greater than 30, you must query the PDMP at least 2 times a year, and over 90, the query should be on the same date of the prescription. And then some opioid-specific continuing medical education. 2 hours of CME and controlled prescribing is required every few years, and of course this counts. So you got one, or I guess probably all your hours with being here today. So in even more recently, September 2018, they added that physicians should, that the risk of benzodiazepine use is being recognized, and it's really increasing. So this was added about physicians should reconsider co-prescribing benzodiazepines or decline to add one when you're prescribing. And not just our state, our medical board, a lot of industry has jumped on board and are looking at ways that they can reduce risk and their own risk, and also for patients' risk. So Caremark is limiting for new prescriptions. They will limit it to 7 days supply, along with some max quantities. Walmart will not prescribe more than provide more than 7 days for some prescriptions, and Walmart will only fill e-prescriptions as of January 2020. So you'll have to use an e-prescription for patients getting their prescriptions filled at Walmart. Medicaid also put in the 7-day limit, and even more recently in July. Narcotics for opioids, yeah. And just in July, they put a hard limit on dosage, which has been controversial because of there are always exceptions, and when you just blanket put in some of these hard limits, there unfortunately is some unintended consequences. But this is one of the rare things that there has been bipartisan support in Congress for. So federally, this bill passed, let's see, this was October of 2018, this support bill for patients and communities. And this was addressing the opioid epidemic and some of the treatment opportunities and improving our health system. So the HCAP scores most of us are familiar with, and I believe earlier there was a discussion of the HCAP scores and how that has affected prescribing patterns. Well, those will be removed as of this year. They will not have those same HCAP scores for patients discharged. They're also going to CMS will review its payment policies for certain non-opioid pain treatments, because that's been certainly an obstacle for a lot of patients that they can't get reimbursed. This bill also established a technical expert panel to review the quality metrics related to opioids and opioid use disorders. So they're going to review existing measures related to opioids. They're going to make recommendations regarding the existing measures, new measures, and make recommendations for value-based payment programs, including best practices for pain management in surgical settings. Within 1 year, they'll make recommendations for broad implementation of pain management protocols that limit the use of opioids in the perioperative setting. And what I think is very interesting, this was an article that came out a little bit before that. This was a summit where they had a lot of healthcare leaders looking at the rate of opioid dependence after surgery. So now surgical site infections, of course, which in every institution is a big deal, post-op infections, what you can do to lower them. And many very expensive protocols have been put in place to try to reduce infection, because the rates are down to 1.9%. Well, persistent post-op opioid use can range from anywhere to 6 to 8%, and even higher in certain subsets. I presented that one study looking at low-risk surgery with a rate of 7.7%, but certainly the risk of post-op opioid dependence is high, in particular in comparison to surgical infection rates. And when you look at it, it meets the CMS criteria for a hospital-acquired condition. It arises during the hospitalization. It's a high cost and high volume condition, and it could have been reasonably prevented through the application of evidence-based guidelines. So I think we'll start seeing more about post-operative opioid dependence and the hospital's responsibility for that. Future directions. So what can you do? And I'm an anesthesiologist, so that's certainly, in the operative setting, is something that, in the perioperative period, is what many times can be the first exposure to opioids. But what we've tried to do in our settings is look at how you can optimize patients even beforehand. So there's a rationale here. This is a study looking at patients that are on opioids that are coming in for surgery, and what they found was preoperative opioid use would worsen their postoperative pain, worsen their surgical outcomes, lengthen their length of stay, and increase costs. And you can see here this range as the MMEs, or the morphine equivalents, increases. You see an increase in non-hospital discharges. So long-term care facilities and non-home discharges, so discharges to other rehab facilities or long-term care facilities, is directly related to or can be increased with increasing morphine equivalent dose. 30-day readmission is increased. Surgical infection rates are increased, and surgical revisions are also increased. So there's a lot of risk factors there. And conversely, there is evidence that preoperative opioid reduction may improve their outcomes. And so there's a lot of push towards surgical prehabilitation. So patients that have risk factors, and it's not just opioid use, but some other factors that are modifiable risk factors prior to surgery. I think that's a great opportunity for us in healthcare to improve our outcomes. Look at smoking cessation prior to surgery or during that perioperative period, looking at opioid weaning prior to surgery, looking at some of the decatastrophization and expectation management, because certainly there's a lot of fear, anxiety, and other psychological factors that can affect outcomes as well. Nutrition, and in particular with our elderly population, making sure if it's on elective surgery and patients can be optimized from a nutritional standpoint, you'll get better outcomes, and sleep and conditioning. So there's a lot of opportunities there, and these may promise a good return on investment for patients willing to exert that effort beforehand. So we've started some of these programs, weaning off pain medications, and not off, weaning down. Certainly, it's great if patients are able to come off of their medications, but weaning down to lower levels can be really helpful. Lifestyle modification, certainly if there's ways to get patients engaged and quitting smoking, and even providing prescriptions, nicotine patches, other things in that perioperative period so that they can stop smoking. Intraoperatively, so that's preoperatively, some of the interventions and opportunities to impact our outcomes. Intraoperatively, there's also a lot of literature looking at opportunities using non-opioid adjunct medications and combining non-opioids along with opioids that can help modulate these pathways and improve your analgesia, decrease your opioid requirements, which will decrease your opioid-related adverse drug events. So, of course, acetaminophen, non-steroidals are commonly used, but there's some others that are not as common. Ketamine has certainly been an effective adjuvant we use intraoperatively. Gabapentinoids, almost all of our patients that don't have contraindications will get preoperative doses of gabapentin along with acetaminophen. Lidocaine infusions can be helpful as well, and blocks, of course, regional nerve blocks. If you can provide a regional nerve block for certain types of surgery, your outcomes are significantly improved, and not just local anesthetic, but there's things, and this is something we've just started using using buprenorphine in the nerve blocks can extend those blocks, and we've seen 12, 15 hours worth of increase. So you're already getting 8 to 12 hours from your long-acting local anesthetic, but you can extend that even further by adding some of these adjuvants, and we use dexamethasone as well. Ultimately, what we're looking for is trying to tailor your individual analgesic plan based on the patient's particular surgery and their risk factors in a way that you can optimize their pain relief, recovery, and function. So it's not, even though there are some standards, but every patient individually looking at what are your opportunities, what things can you do to really personalize that patient's analgesic and post-operative plan so that they optimize their chance for recovery. And post-operatively, I mentioned ketamine already. That's something that we've just started using a little bit more frequently, using ketamine even through we use it in the operating room, we use it in PACU and some of the ICUs, but now taking it out to the floors in patients that have a high likelihood of requiring high opioid requirements. So if we expect them to have or to require a lot of opioids post-op, particularly multi-level spine surgery, some of the thoracotomies, and open laparotomies, and even, we haven't started doing this with our joints yet, but other places are doing that, and they've had good outcomes, a lot of opioid sparing there. But what's interesting, this was a study published in 2017, and these are ERAS protocols, and I think everyone, and I know there are ERAS protocols being used here. ERAS protocols, again, enhanced recovery after surgery. There are combinations, not just about pain, but there's goal-directed fluid therapy. There's lung protective ventilation, so there's strategies to minimize other complications post-operatively, post-op nausea, vomiting. So this was a study looking at one hospital that had a really well developed ERAS protocol for all these patients. You can see here Celebrex, they're getting pre-op, they're getting blocks when appropriate intraoperatively, and they're getting all these adjuvants. But and they compared, in these patients, they compared their opioid use before and after implementation of these ERAS strategies. And what they found was, as you would hope, there's a huge decrease in their intra and their hospital IV morphine usage. So it drops substantially from their in-hospital opioid usage. But unfortunately, their discharge opioid prescribing did not change at all. That was not part of their ERAS protocol. The patients did great post-operatively and were still getting the same prescriptions on discharge. So even the patients with no preoperative opioid use, low discharge pain scores, and no morphine consumption before surgery, 72% of them still went home with an opioid. So even these ERAS protocols, which are great and wonderful, it led to a decrease in opioid use during the hospitalization, but we have to combine those with the follow-up afterwards, revising order sets, decision support tools, things that will also carry that forward. Unfortunately, there is more information that's coming out as far as what are the recommendations on discharge. The group in Michigan has done a really good job and has pioneered them along with another group in Vermont. They've done a lot of the early studies on looking at opioid prescribing patterns post-operatively. And this is one that I thought was really interesting. It's a very simple study. They called patients after laparoscopic cholecystectomy. They called them and asked them about how many pills that they took. And I know everybody here is themselves or has a family member that says, okay, I had surgery and they gave me this many pills and I still have them left over, or only took 1 or 2 of them. And that's such a common thing that they decided to quantify it. And so they called patients to ask them how many pills that they took. And they used that to develop some guidelines. They didn't change anything else. There wasn't any new ERAS protocols or anything. But then they used those guidelines to guide discharge prescriptions and then called patients after that and asked them the same questions afterwards about how many pills. And what they found was that initially they were giving patients 250 oral morphine equivalent. The total prescription, 250 OMEs, was about their average of what they were giving patients. While the patients were only taking 30 milligrams. So they would only, whether they're hydrocodone 5 milligram pills or Oxy 5s, that they would only take a few of them. And so they were obviously getting way more pills than was necessary. They put in these guidelines, and what they found was, they started, the new guideline was that they gave them only 75. So they didn't go all the way down. The average use was 30. They still gave 75 milligrams on discharge. And on discharge, they noted with their follow-up, only 5 patients of the 200 requested refill, which was actually lower than the 7 patients that requested refills with a higher dose. So that really did not change. There wasn't more patients calling for refills when they decreased the prescription. But what they even found, what was more unexpected, was that they found when they gave a lower prescription, a lower number of pills, the patients took even lower than before. So they decreased what the patients were taking down to 20 milligrams from 30 before. So after that guideline, there was a decrease, and they attributed that to this anchoring and adjustment phenomena, where their initial size of their prescription served as a mental reference point. So the expectation of, is this going to hurt? If you get a big bottle of pills, that the expectation was set differently by giving them less pills, and they took less. And so with this, in this short time frame, they decreased their prescription size by 63% without increasing the need for refills. And you can see here there was no other, but they asked about other pain scores, and here's their pain score. It was really no different at all. So there was no other adverse side effects. And in that short period of time, 7,000 excess pills were taken off of their community in just that 5-month period. And they've gone on to do this same, use this same tool to set guidelines for multiple different types of surgeries, and this website, opioidprescribing.info, you can go there. They've continued to add to this. So there are now some guidelines, and if there was previously everyone just in the habit of writing 30 or 60 pills after every surgery, well, they've catered it and said this is what they've found for oxycodone 5 after a lap cholecystectomy 10 should be adequate, and lap appendectomy 10. So previously there wasn't much information out there, and there wasn't much to go by, and they're really trying to address that. And with that reduction in leftover pills, what the hope is that, and this is a study that was looking at, it's a predictive model looking at interventions and where there are opportunities. And if you decrease the leftover pills, because there's certainly a risk, as we said earlier, leftover pills are where many people recreationally will get started, and so making sure that we're not leaving pills left over, and we're giving patients proper counseling about disposal. So a 50% reduction in leftover medications can have a 46%, they predicted it would have a 40% decrease in recreational users, and its potential a 19% decrease in projected deaths. So it can have an impact in that community if we just do a better job of prescribing based on need. Let's see, how am I doing? That's pretty good. We got 5 minutes left for questions.
The tracking system by computer of opioid prescriptions in Alabama that's available to pharmacists and doctors and so forth, is that tied in with the national program?
So the PDMP is our state database, and we're tied into multiple states. Not every state, there's still a few holdouts, but our state, you can, when you go in there and you're doing a query, you can query surrounding states, and there are now, I think every month they'll add more states that have been, that are now in collaboration. So I think it has to do with a couple of things. With some of them are IT consideration, but others are just exchange of information, agreements between states. But I know all of our surrounding states are now partners with us, so you can do queries in Georgia, in Tennessee, and all that along just with that one click.
Do you have to have more information than the patient's name, which may be false?
Well, you enter their name and their date of birth, and if there are more than one, if there's more than one person with that name and date of birth, they give you addresses, and that's one of those things that can be, sometimes there'll be multiple addresses, but yeah, there's probably ways to get around that as well. I'm sure people are crafty, and if they want to falsify information, but as far as generally, it's been a very useful tool, and depending on what patients are using, and I know there are restrictions on getting cash for a prescription, so that we're trying to avoid some of that. Some of those things where we're getting prescriptions traded for cash, and instead it's all being registered through the PDMP.
Suspicion that the person is using their drugs incorrectly.
Yeah, I would think so. Yeah, it's tough, and people are smart, and they think ways around it. But I think we always try to give people the benefit of the doubt, and I think as we're doing some of this more judiciously as providers, I think it gets harder and harder. What unfortunately that means is people that want to abuse drugs go use stuff that's even more dangerous, and that's why unfortunately we're seeing some of the increase in deaths. But
I have a daughter who's a pharmacist with Walgreens, and one of the things she talks about is when someone else comes in for a person's prescription,
yeah,
that sort of alerts her that it may be a scam. And
Yeah.
she uses that database
that's interesting. Yeah,
and then calls the police.
yeah. Do you have a question? Yes.
The use of the lorazepam really equivalent, how is that supposed to be used?
So that is just that is something new, quantifying, because previously we haven't had a way to compare different benzodiazepines. So I thought that was interesting. There's a little bit of literature on the PDMP's website that will link to how those numbers were derived. But it's a way to compare relative strengths and potencies of Xanax compared to Ativan, compared to Valium, and different things. And so they have started to set some standards for what is a safe dose, or what higher than a certain amount of LMEs, just like they've done for MMEs. But yeah, so I think it's an interesting thing. I have not seen that before we put it in our PDMP. So I think I'm about out of time. Are we going on lunch break?
No, there's going to be one more speaker, and at
Okay.
12:20, you can get your lunch and then come back in here for the next speaker.
Okay. All right. Thank you all.
Hello, everyone. Can you hear me? I'm Christy Falligan, and I'm one of the social workers at St. Vincent's Hospice. So I understand I have until 12:20 to tell you a little bit about hospice and how hospice helps patients and families cope. And then at 12:20, you'll go out and get your lunch. So this is a speed course on hospice. So I'm going to talk just briefly about what hospice is and then how that service helps families cope. We don't have a PowerPoint presentation because I'm figuring 20 minutes I'll just talk, right? So there won't be anything to look at. The reality is I usually lose listeners when I say the word hospice. Hospice may be one of the most misunderstood things in the American healthcare system. For a lot of people, just the mere mention of hospice just crosses a line. For many people, hospice is synonymous with death or with giving up hope. And while hospice isn't related at all to things like euthanasia or assisted suicide, we tend to get lumped into that category anyway. The problem with that is when we misunderstand or mistrust that hospice benefit, which by the way I think is just one of the best kept secrets there is, that misunderstanding and mistrust really can lead to unnecessary patient suffering. It can lead to quicker and uglier medical deterioration. It can lead to some missed opportunities for better lives for those patients and families. Okay, so what is hospice? We can think of hospice as on that continuum of healthcare and it's accessed by people at the end stage of their disease. So essentially, it's a group of services that are made available to that patient wherever that patient is at their end stage of their illness. All this extra stuff is delivered by a team of visiting nurses, visiting social workers, visiting chaplains, visiting personal care aides, physicians, visiting volunteers, wherever that patient is. Hospice is generally oriented toward comfort care and controlling people's symptoms, controlling patients' pain, and helping those patients and families who choose not to pursue any aggressive intervention or certainly not to pursue futile interventions. One of the huge concrete benefits of hospice is the hospice benefit provides all the medications, all the supplies, all the equipment, everything that's related to that terminal diagnosis. Everything. That's a huge benefit. If you know a family who's ever had to pay for those cases of adult diapers for a patient with dementia, you know how expensive that can be. Hospice can happen in a patient's home. It can happen in a facility like a skilled nursing home. It can even happen in a hospital setting. So let me just tell you briefly sort of those 4 levels of care that hospice provides. And I probably need to stop and say most insurances certainly provide for hospice care. The majority of hospice in this country is covered by the Medicare benefit, but certainly it can be provided by Medicaid or private insurances. I tend to use that word Medicare just because that's sort of the population that I'm used to. Okay, so here's kind of the basics. There are 4 levels of care in hospice. The level of care that 99% of the people are on 99% of the time is called routine home care, which is kind of confusing if you're used to home health because that's what it sounds like, but it's not. Routine home care is when patients are pretty stable and they're receiving care, those intermittent visits from the nurse or the chaplain or the social worker or aide, they're receiving those intermittent visits. And all their symptoms are managed in that way. If a patient has a symptom that can't be controlled by those intermittent visits, then another level of care is called continuous care or crisis care. So if a patient's having, say, uncontrolled nausea and vomiting or uncontrolled pain, and we just can't seem to get a handle on that with whatever the current family caregiver is, we may put a nurse at the bedside around the clock for 24 hours to sort of get on top of that, see what's going on, and get a good plan in place. So unlike what people used to think about hospice, is once the nurse was there at the bedside, they're there for 3 weeks until the patient dies. That's just kind of not how it goes anymore. That nurse is evaluated the nurse evaluates the situation every 24 hours, but that's what that continuous level of care is to have a nurse at the bedside roughly every 24 hours till we can get that symptom under control. And then it goes back to that routine care. If patients have symptoms that can't be managed that way, let's say a patient has uncontrolled bleeding, then another level of care is called general inpatient care. You may hear it called GIP. So that's where we might place a patient in the hospital to get that symptom under control. It's a short-term hospital stay. We want to get that symptom under control, and then that patient returns home. The final level of care for hospice, which I think is just a wonderful benefit, is called respite care. So respite care isn't really a benefit for the patient, but it's designed to be a benefit for the caregiver. Because we know, and Medicare realizes, caregivers need that break. You know, sometimes I walk into a house and I can't tell who's the patient and who's the caregiver because the caregiver's so worn down, they look like they're in worse shape than the patient is. So the respite benefit under hospice provides for that patient to go to a facility like a nursing home or a hospital if we have a contract there for 5 days and nights, free for that caregiver. Ambulance, if that's what's needed, transportation is provided to take that patient there and take that patient home. And that gives that caregiver a 5-day-a-night break to take care of herself, clean her house, go get her knees replaced, go visit her grandchildren. It doesn't matter. And that happens roughly every 60 days. So I am telling you, we have patients in our hospice service that never take care, the caregivers never take advantage of that respite situation. And we have other caregivers, I'm telling you, they have day 61 marked on their calendar. They know when their next 5-day period is, and that's okay. That's what it's there for. So that's a wonderful benefit from hospice. And then finally, after the patient dies, hospice still remains with that family for 13 months after the patient death to provide continued support and bereavement support and grief support to that family. Now, when we're talking with patients or families about hospice, those conversations often get shut down or stopped because one of the criteria to be eligible for this benefit is patients have to have a terminal diagnosis with the expectation that death is 6 months or less. A disease is considered end stage is if the disease progresses the way it typically does for a person in this situation, then the expectation is death in 6 months or less. But nobody really knows that, right? Like only God or some higher power knows that. So we have patients who are on our service for 2 hours, and we have patients who are on our service for a year. The other real conversation stopper when you're talking with patients or your families is because the stated goal of hospice is that we're about comfort care, not about cure, oftentimes families misinterpret that. They think that it's a decision between fighting on or giving up hope. It's a black and white thing. So to both of those things, there's no requirement for hospices if their patients don't die within 6 months. Hospices aren't penalized if patients don't die in 6 months. We routinely see patients that are on hospice care that live longer than patients typically with that disease process, not in small part because they're receiving more acute care, lots of loving care. They're having their medications looked at and managed on a regular basis. And the other part of that conversation is, even though patients and families may turn to hospice because a doctor will say there's no cure available, if something comes up, if patients and families change their mind, if a treatment becomes appropriate, patients can always disenroll from hospice at any time, for any reason. But hospice is more than just about managing physical pain. There's emotional pain, there's spiritual pain. That's why we have a whole team of social workers and chaplains to provide support for those patients and families. Y'all remember Maslow's hierarchy of needs? You have to take care of all those concrete needs before you can begin to address all those social and emotional issues. We have to take care of all those physical pain issues before patients feel like talking about those emotional and spiritual issues. So in hospice, our question is, how can we be of service to this patient and family in this vulnerable time for them? Because it's not just about helping patients prepare for their death, but it's also about helping families cope with this time. Because, when all is said and done, we want families to be able to look back on this experience and feel good about what they did, good about the decisions they made, good about the care that they provided. So, in terms of bereavement, when someone that we love dies, there's typically that shock and denial. Y'all know that from those Kubler-Ross stages of grief, that initial experience of grief. And then there's this long period, often, of a sense of loss after that patient dies. It may be months, it may be years. And it's not just a one-time loss. When someone that we love dies, we lose that person over and over and over again. When our wife dies and we climb into bed and the sheets are cold, we lose her every night. If my husband's the one who's done all the finances, every time I have to go to the bank and deal with that, I lose him over and over and over again. So it's not just one loss, it's loss after loss. And that's why that bereavement benefit for 13 months after that patient dies is just crucial to support those families. But then, at some point, there's this kind of loosening. Well, our patients who are terminally ill have similar grieving experiences. Initially, when they're given a terminal diagnosis, there may be that shock and denial. And then there's this long process of loss after loss after loss. Maybe it's those role changes. Maybe the patient loses their ability to work. Or I had a patient just yesterday who was really grieving that he's no longer able to drive, and he's been a long distance truck driver. So for that patient, that's a huge loss. Patients lose their ability to dress themselves or maybe to feed themselves. And then there's this kind of loosening and acceptance. And it may be weeks or days before the death. It may be minutes before the death. So, hospice support and certainly the bereavement support, begins before the patient death to promote good coping. And our intention isn't just to manage physical symptoms. You know, if we give a drug to manage a patient's anxiety and the drug wears off and the anxiety's still there, we need to help people deal with that. So to cope with that anxiety so it doesn't have such a stranglehold on them through this process. And then finally, in hospice, you know, we really work hard to be mindful of, you know, what is it that we're trying to be in service of? What is that patient and family's goals for care? Not our goal. What's the patient and the family's goal? Because, you know, if our job is just to snow that patient through the dying process, just to keep that patient sedated, which might be appropriate for some patients, but if our job is just to snow that patient, well, that would be pretty easy to do, but I don't think that's our job. You know, our job is to help patients through their dying, manage their symptoms so that they can be with their family as much as they want, to say or do the things they want to say or do before they die. When I first meet a patient or a family, I usually almost always ask, what has the doctor told you about your illness? And almost every time they'll say, well, the doctor said there's nothing more can be done. Time to go on hospice. Nothing more can be done. There's always something that can be done. We never want to tell anyone nothing more can be done. There's a million things that hospice can do to help that patient and family. Would it be helpful for you if we had your medications delivered so you didn't have to drive to the pharmacy to pick those up? We can do that. Would it help if we had somebody come out here 3 times a week to help you with the bath? We can do that. Would it help the wife if we accompanied her to the funeral home so she can go ahead and make those pre-arrangements and have someone? We can do that. So we never want to tell anybody there's nothing more can be done. There's always something that can be done. Okay, so finally, so if you or anybody that you know has an advanced illness that just isn't meaningfully getting better, or certainly if it's getting worse, in spite of all those treatments and all those hospital stays and doctor visits, then I think we owe it to ourselves to learn about hospice, learn about the hospice benefit, so that you can make some good informed decisions. And if you're thinking about it for one of your patients or your families, we want to get in there as early as we can. One, so it's kind of we want to be in there on a good day so we can begin to develop that relationship with that patient. And because too many people elect that hospice benefit so late in the course of their illness that they really don't get to take advantage of all the benefits. We know that more care and more services help people with serious illness and their families live better lives with whatever time they have left. So again, hospice is a practical, tangible way to help people to continue to live alone, to live in their community, live at home, wherever they are. We take the service there to them and hopefully help them live their kind of life with quality as they define it. 18 minutes, done, the end. Any questions about any of that? All right, thank y'all, and you can go get your lunch and then come back in, I think.
Yeah, that happens, you know.
You know to stay behind the podium.
Stay behind the podium?
Yeah, just don't ribs off, you'll go fine.
I got something to look at right here, so I'm probably not going far.
Okay, you're live whenever you're ready to go.
Okay. I think I'm going to wait for a couple more people to trickle back in, but I'll get started in just a minute.
They have smokers and teachers and they do all this time, those smokers. And the non-smoker didn't.
Go ahead and get started. Okay. Good afternoon. My name's Carolyn Keyser. Thanks so much for having me this afternoon. I'm currently practicing as a palliative care provider at the Birmingham VA. I trained at UAB, and prior to that was doing internal medicine here in Birmingham. I'm really pleased to be following Christy after her discussion of hospice. That's a good introduction to a lot of the work that I do, and some of the content that's going to be in my talk today is going to translate well with that. Most folks are not super familiar with the specialty of palliative care. We're a pretty new medical field. We're sponsored by several boards, but we are now a board certified specialty. But the overall philosophy in what we do is to help take care of patients with serious illness, any number of serious illnesses.
Give me 1 second, I'm sorry. Your microphone's flipped off to the side.
Okay.
Yeah, there you go.
All right.
Thank you.
So taking care of patients with serious illness anywhere along the disease course, be that from early in diagnosis to later in disease. And so our focus is really on quality of life, improving symptom management, and then also assisting with some of those complicated conversations that happen with patients. We approach patient care from a very multidisciplinary structure. And we think about suffering in several different formats, usually being spiritual, physical, psychological, and emotional. And so not only is pain management for patients related to physical suffering, there's a lot of suffering and pain that comes along with emotional, spiritual, and psychological experience in the setting of advanced illness. And so I'm going to talk about today some of the common signs and symptoms encountered in patients with a dying illness, and then as well as to help prognosticate and help provide anticipatory guidance for families as death approaches, and then also to discuss what our role as healthcare providers is in the dying process and caring for these patients. For most patients and families, knowing what to look for or what to expect helps them cope. We take care of patients with any number of illnesses in the in medicine. And so each patient experiences that differently. It's common to us, but it may not be common to them. And so giving them some guidance and letting them know what to expect is very important. I've learned that every family approaches this differently. And some patients want this information and some patients don't. Some family members want more information and some families don't. And so I always like to ask what would be helpful to the patient. Would it be helpful to talk about what it might look like as your disease progresses? And I think that helping patients have an idea about what their prognosis is critical in helping them determine what are their goals for their care moving forward. In order to make appropriate medical decisions. As time changes, the importance of certain aspects of care change. And so what do families and patients prioritize? We need to give them the opportunity to make those decisions. There is a lot of communication skill that goes into talking with patients and families about serious illness. There's, and that can be a whole nother talk in and of itself. So first I want to talk about kind of physiologic changes of diseases and dying and what to expect at each of these stages. As I cover each of these stages, I'll talk more specifically about symptoms and how do we manage suffering at that place. So in general, these are some models that I have found very helpful for talking about disease progression. This is pulled from June Lunny and colleagues from Medicare decedents. And they described these 4 trajectories. The first being sudden death, and that somebody was high functioning, doing well. This is you or me going about our lives and encountering a sudden car wreck and ending in death. The next image to the right, is terminal illness. And this is an example of something like oncology and cancer, where somebody has been doing well and then has a diagnosis and a pretty clear decline following that. We often take care of patients with diseases such as COPD or CHF, and that follows a different trajectory. And that falls into the organ failure model down on the corner. And when we see these patients, we think of they're doing all right, they have an acute illness, they have a pneumonia, they have a CHF exacerbation, they come into the hospital or they're treated acutely, and then they return but not quite to their baseline. And they have a series of these illnesses as they approach the end of their life. It's difficult with these diseases to know exactly which hospitalization is going to be the one in which we can't help them recover or get back to the baseline or return home. And so talking with these patients earlier in the disease to say this is what we expect, and helping them come up with a plan for their care and knowing who their decision makers are earlier is helpful, because we're not sure when something is going to change suddenly. Then I expect you're familiar also with caring for somebody elderly, advanced dementia or frailty. And this is a different disease to prognosticate for because they are not functioning at a high level. It's been a slow course that they reach kind of this low ongoing disease. And it's difficult in those patients also to prognosticate. Specifically, when are they going to encounter a pneumonia? When are they going to encounter a skin wound that we can't heal? When are they going to encounter a urinary infection that becomes complicated and resistant to antibiotics? But it's important to have a framework as you talk with patients about where are we now and where do you think this is going to go, so that they have the opportunity to know what to expect. So I'd like to talk about a couple of symptoms that are prevalent in many serious illnesses before going into physiologic changes that are more associated with the dying process. Two of the most common symptoms that I'm asked to help manage are pain and dyspnea. And so I'll talk a little bit about the prevalence of these, and then as well as some consideration in the management of them. So pain is very common in advanced illness, and in pretty much any advanced illness. It's something as a medical community we're pretty good at screening for this, and as providers usually have a framework to practice within for management. So I'll talk about this some, but then I'm going to talk more about some of the other physical, psychological stressors moving forward. So 75% of dying patients will experience pain requiring opioids at the end of life. 70% of patients with advanced cancer experience moderate to severe pain. And I think a statistic that's pretty surprising is that 75% of patients with heart failure, not cancer, experience pain at the end of life. I think we're pretty comfortable with malignant pain, but thinking about pain in some of these other diseases as they progress is a little more difficult. So where are these patients, what's their etiology of pain? Often it's the pre-existing pain, the chronic low back pain that they've had for many years from an injury they sustained in the past, or osteoarthritis, they've got degenerative joint disease. But it's not uncommon that patients have a new pain that's related to their disease process. So in patients that we are thinking of with cancer, we're thinking about bone metastasis or liver metastasis that are causing pain. In our heart failure patients, and also in cancer patients and COPD patients, we don't as often think about it, but the immobility that comes with those diseases is a significant cause of pain. The being in a position for a long time and being more fatigued or weaker and not able to move themselves in bed as they were able previously. When you and I lay in bed at night, we turn in our sleep. We don't even wake up to think about it, and we move our arms and legs and we don't even think about it because they're uncomfortable or because of pressure. And as patients with any severe disease progress, that becomes more difficult and may be a source of pain for them. Things like development of sacral wounds or decuviti. And then also with some of the malnutrition that occurs with advanced disease, the edema is often also a cause of pain. And so how are we assessing pain? I think, again, medically we're generally pretty comfortable with talking with patients who can tell us about their pain. But a lot of what I do is looking at patients who have nonverbal pain cues. So looking for grimacing, looking for moaning or signs of distress when you turn them or move their extremities, or some of the things that we have to use to help identify pain, as well as really careful physical exam. And again, looking for some of those nonverbal pain cues, doing physical exams and palpating the abdomen. Looking for things like urinary retention, constipation, oral thrush, that patients may not be able to tell us about, but can cause significant discomfort. So how do we approach the management of pain in patients with serious illness? It really depends on the etiology of pain. Is this pain from a bone metastasis? Do we need to try steroids? Do we need to try radiation therapy? Do we need bisphosphonates? Or is this from position? Do we need to work towards repositioning, having tools to help with comfort, having a bed that inflates? What kind of props can we use there? Is massage something that could be helpful in relieving lymphedema? Is there a role for heat or cold in managing pain? But trying to come up with a good number of tools. We use a lot of opioids, but we don't want it to be the only medicine that we're using to help manage pain if we're able to. Sometimes we're limited based on comorbidities, renal disease, liver disease, ability to take medicines, that we can't use some of those adjuvant therapies for pain, and so we do come to using opioids. Primarily we use oral opioids, especially in our patients that are up and walking and talking. But as patients lose that ability to swallow in progressive diseases, we do use other routes for administration. Sublingual, buccal, so having medicine put in the mouth and then absorbed by the cheek. Per rectum, compounding pharmacies can compound some of these agents to be given rectally in patients that aren't able to swallow. And then transdermally is also an option. In hospice and in our hospitalized patients on our palliative care unit, we do use subcutaneous rather than IV, just because maintaining an IV is sometimes more difficult. If we already have IV access, we can use that, but in some of these advanced diseases, getting IV access and maintaining it can be difficult. But I think it's always helpful to know that subcutaneous can be an option even at home through hospice. And so what are the agents that we use? We primarily do not use combination products in my practice based on the difficulty of titrating medication and having to take the Tylenol component into account. And so we usually will use oxycodone or hydromorphone, morphine, fentanyl, and methadone. So the other symptom that is quite common that we help manage in seriously ill patients is dyspnea. Dyspnea is the subjective sensation of breathlessness. I'd like to be clear and make a distinction that dyspnea and hypoxia are not the same. They can coexist, but they don't always. And so you can have patients who are hypoxic and have low oxygen sats and feel fine. It does not bother them. They may live there chronically. And then you may have patients who have profound dyspnea but are not hypoxic. And so I think that's an important distinction in how we approach these symptoms and how we manage it. As opposed to pain where we're really comfortable in asking patients about it, dyspnea is not a symptom that we routinely ask patients about, and we don't have great tools for measuring it. There's some research tools that are very difficult to use in clinical practice. So often what I find myself doing is asking patients to use that same 1 to 10 scale, how severe is your dyspnea? And most folks know that scale from pain and can relate it over to dyspnea, and then are able to judge their own symptoms for us. Dyspnea is a very common severe symptom as death approaches. I think 75% of patients at rest and 53% with exertion with end-stage heart failure. That's not surprising. I think the 20 to 60% of patients with advanced cancer, not just lung cancer, experience dyspnea. And I think that population is where we often miss this symptom. So what are some of the causes of dyspnea? Existing disease, so do they have COPD or CHF? Is it an acute superimposed illness? Do they have a PE or a pneumonia? Is it a cancer-related complication, be that pleural effusions, abdominal ascites, compressing the lungs? Do they have bronchial obstruction? And then is it an effect from their cancer therapy, if they've gotten radiation or chemotherapy-induced pulmonary fibrosis? And then other causes that kind of are sometimes forgotten are anemia, uremia, even anxiety kind of fall into that other category. And this is a significant morbidity in these patients that we try and manage. It is more difficult than some other symptoms at times, but really using non-pharmacologic tools is where we start. Oxygen, if a patient's hypoxic and it's helpful, is a great tool. We use it a lot in the hospital. Then fans and cool air blowing on the face. If you can think back to being in elementary school and putting your face in the fan after you've been running around outside, there's mechanoreceptors in your face and your trigeminal nerve that get activated with that wind blowing on your face and help with that sensation of dyspnea. Beyond anything else, it's just the mechanoreceptors. And so this is something we use a lot. It's a great tool in patients with COPD and anxiety of giving them something to do and focus on as you wait for some of their other medicines to kick in and work through that acute episode. Using humidified air, if we have patients on oxygen, is helpful. And then positioning and repositioning, particularly if there's abdominal ascites or if they have a pleural effusion on one side, trying to make sure that we have them rotated to the other side to let their good lung really do some breathing if they're having episodes of dyspnea. And then some patients, there's a role of having a paracentesis or a thoracentesis to remove that fluid. And depending on where the patient is with their prognosis, it may be placing a Pleurex catheter or something that could be drained routinely at home, be that in the abdomen or in the lung. That's something that can also be done while on hospice. So the pharmacologic management of dyspnea, opioids are used very routinely. These are supported through Cochrane reviews, and they are also included in guidelines and recommendations as a preferred drug by the American College of Physicians, American Thoracic Society, and American College of Chest Physicians and COPD. And so usually we start out with something low dose. We start with oxycodone 2.5, something low, and dose it pretty similarly to how we would dose opioids in the pain setting every 4 hours based on kind of the mechanism of action, and have great symptomatic relief with that. There has been some research about using inhaled opioids for dyspnea, but the evidence really has not played out at this point and doesn't support that routinely. So usually I use oxycodone 2.5 because that's really the lowest OME that you can start at for someone. And when I'm treating dyspnea, I start lower than if I'm treating pain. Benzodiazepines can also be used for dyspnea depending on the etiology. They would likely be more helpful in patients with anxiety rather than having a lung pathology. Combining opioids and benzodiazepines is obviously high-risk medication use. And so we find that the opioids are plenty effective without the benzodiazepine, and so really focus on using opioids. I worry with anxiolytics about kind of unwanted side effects or having adverse reactions to it. I will use buspirone, so a non-benzodiazepine anxiolytic. It has some serotonin activity as well, but that can be helpful in someone who has anxiety and is benzo naive. If they've been routinely on a benzodiazepine, then that medication is much less effective for them. Steroids are something that we're pretty comfortable using for COPD exacerbations. Sometimes they can be helpful, particularly if patients have a malignant obstruction in the lung or pneumonitis or SVC syndrome. So we will often give it a trial if it's something that may be helpful, but it's not always indicated. And so despite the many serious illness a person can face, as time grows shorter, the path becomes more similar. And ultimately, we find that in the final days, the path is very similar. And so I know we've talked some about disease progression. And so that's something that patients and families find helpful to know what to expect. As humans, we fear the unknown, and surprises can cause a fair amount of panic. And so I think as clinicians, if we can give patients and families a little bit of knowledge ahead of time, can really allay a lot of fears that may occur suddenly. Especially for things that we know to anticipate or things that we know to expect. So as we discuss the dying process, I have to start by emphasizing that every individual is unique, and their process will be unique. I'm going to talk about signs and symptoms that are common for these stages. This is based on data, primarily 2 studies in patients with malignancy. Where most of this is pulled from. And so as Christy was talking before in her hospice talk, there is an early phase that is, I think of as 1 to 3 months, and that's what's been described in the literature. But Christy in the talk before me was talking about some of the social withdrawal that occurs at this time. Excuse me. And this we often see as the patient becoming less interactive with the world around them, in the sense that they may become less interested in the newspaper, TV, or current events. They may still have some interest in friends and neighbors, but slowly that's going to close down and really be immediate family or the people that are important to them. I'm not completely familiar with all of the literature, but from what I've learned, this does represent some anticipatory grief and the grieving of their own dying process, and how they interact with the world. Another symptom that is commonly seen is that patients become more tired and spend more time sleeping. It's difficult for them to be awake, and that this is changes in the body's metabolism related to their disease. And so encouraging the family to interact with them when they're awake and they're able to, but not pushing the patient outside of what they're able or comfortable to do. And I think that talking with the families that this is the disease that this person is suffering from. It's not the person not wanting to be with their family or not wanting to interact with them, but part of this grieving and dying. One of the most distressing symptoms that develops is anorexia, this gradual loss of interest in food and drink. This is most distressing for the families of patients that I take care of, particularly when they lose interest in their favorite foods, and when they have cravings that come and go. The family is head over heels to help them get this, and then by the time they get at the bedside, the patient's like, you know, that sounded good 10 minutes ago, but right now that chocolate pudding is more than I can bear. I can't do it. And families have a tendency to take that personally. And a phrase I hear not infrequently is, but I can't let her starve. We can't let her starve. In our culture, bringing someone food and drink is nurturing and helping, and so we naturally want to do that. And so culturally, we have this emotional response. And so a lot of what I try to do is talk with patients and families about how hard it is to see their loved one this way, and knowing that they love them so much and they're trying to support them by bringing them food and drink. And so I always encourage comfort feeding. really anywhere in the disease process, in that letting them have what they're interested in, what sounds good to them, what tastes good to them. Let's get them those things. And trying to help the family understand that it's not the person who doesn't love their chicken noodle soup anymore, but it's the disease progressing. We also encourage using the sponges. It's helpful for the family to have something to do, and it's also a way, even with patients who have a limited ability to swallow, to enjoy some of the things they loved in life. If they love Dr. Pepper, get them some Dr. Pepper on their sponge and let them suck on it and just have that taste to enjoy. Okay. So next I'm going to talk about what the progression phase. So the last couple weeks is where we start seeing things like incontinence and functional loss of sphincter control, and then physiologic changes in blood pressure and pulse changes, temperature changes, and increasing disorientation. As opposed to previously where people were more withdrawn and within themselves, we start to see signs of delirium and restlessness. And so this restlessness at end of life could be due to any number of causes. It may represent delirium, which is this acute reversible disorder of arousal and cognition and a global brain dysfunction. And we think of delirium as being multifactorial. There are multiple things contributing. Could that be infection? Could that be urinary retention? Could that be constipation or nausea, medication withdrawal, or a medication effect? So we try and treat and make sure we're managing all of those things that we can reverse to help people recover their cognition in the setting of delirium. However, we also see some disorientation that is not easily identifiable with a cause. And so sometimes patients become more confused about time and place and identity of the people around them. Sometimes they see people who aren't there. And so there's some literature talking about this near-death awareness. I think in the pop culture we see that as people seeing the light, or people seeing relatives that have passed previously. I hear from patients about kind of traveling and changes that are going on, particularly in people who are approaching the end of life. I don't think medically we have a good explanation for some of that, but it's something that comes up pretty frequently in my patient care. Excuse me. So for the non-pharmacologic management of delirium is something that I think most folks are familiar with in the medical community. So comforting presence of family, having a well-lit room, familiar sounds or music, things that can provide comfort and peace to this person, and then frequently reminding them of where they are and that they're safe and that they're comfortable. However, there is a role for pharmacologic measures in patients who we can't redirect and who are greatly distressed. I know this week some more literature came out, I think in JAMA, about the roles of particularly Haldol in the setting of delirium. In my clinical experience, if patients are severely distressed or at risk of harming themselves or those around them, then if we can't direct them, then trying to provide a calming medication to help them at that place is very important. And so we often reach to neuroleptics rather than benzodiazepines because of the risk of adverse or kind of alternative response to the benzodiazepines. So now I'm going to talk about the active dying process. And I think of this as the last minutes to days of life, with breathing changes, respiratory secretions, skin changes, loss of peripheral pulses, decreased urine output, and then progressive unresponsiveness. As I counsel families, when the patients begin to enter this active dying phase, I often talk to them about the body giving up control and regulation. I ask patients or ask families to focus on how the patient appears. Do they appear comfortable? Because we know that the numbers are going to fluctuate. Overall, I may look at trends, but I think my priority is how does the patient look? And I think patients and families have been kind of through our culture of the ICU and having the numbers flashing at them do worry about that. And so I often try to redirect them. I find that in this phase that some counseling and anticipatory teaching is very helpful. Families become very fearful as they see some of these changes, and they do want to know what to expect. I know in my hospital system there are some papers and some books that we give patients and families about what to expect at the end or as death approaches that can be helpful for them. And so the thing that many breathing changes occur at the end of life. As I counsel family, I often discuss that these reflect the body releasing control over breathing. It's common that patients are spending less time awake and more time asleep at this stage. And so I often will use an analogy of snoring. Sometimes this brings up really kind-hearted jokes about the person and the family. And so that's always nice. But it also gives them some perspective on the changes that they're seeing and that the patient is very relaxed and that they're comfortable at this point. Also, that snoring is something that's not bothersome to the person doing it, but can be much more alarming to the people around them. And I think that analogy goes well with a lot of these breathing changes. So I'm going to talk about them a little bit more here. So Cheyne-Stokes breathing is not uncommon, this progressive faster pattern, and then pauses and breathing. As you can imagine, those pauses and breathing can be surprising to families. So some anticipatory counseling about that, and that we're going to expect that to happen, and that the pauses may get longer and longer, and that's a common occurrence. So another common symptom that we see in patients in the last days of life is terminal secretions. Often I've heard the term death rattle. I don't use that term, and we usually don't use that term, but it has kind of a medical understanding about what that is. It's the pooled secretions that occur when a patient's not able to swallow anymore. Often it's just a little bit of saliva on the vocal cords, and that breathing in and out, it sounds really loud and terrible, and patients' families are terrified that they're drowning. But really, it's just a little bit of saliva, and they're not swallowing the way that the rest of us do. And so this symptom really has some evidence supporting its really last day or two of life. And so that snoring analogy works well here, in that it's louder for the people around them and often much more distressing to the family in the room than it is for the patient. So how do we manage it? Often repositioning is the best thing that we can be doing. Because of how deep it is, that suctioning with a Yonker is not usually helpful. And maybe in fact more distressing and cause more trauma. But I find this to be a good opportunity to talk about discontinuation of additional fluids that may be contributing to volume overload in the case of patients who have PEG tube feedings going or who have IV fluids going at that time. There are some pharmacologic agents that can be used to help dry up secretions that are before they're produced, but it won't reverse any secretions that are already present. My preference is glycopyrrolate as opposed to atropine and scopolamine. They're all anticholinergics, but glycopyrrolate is a quaternary amine that doesn't cross the blood-brain barrier, so it doesn't have as much effect on mental status and has a bit longer half-life, and so it's often more effective without risking somnolence or constipation. Another breathing change that we often manage is open mouth breathing. Previously referred to as agonal breathing, but obviously we don't use that term because it implies agony. But you know, I think you can imagine that breathing style of kind of lax jaw, the mouth's open, rather ineffective breathing. It's hard to describe, but I think folks who've seen it know what I'm talking about. Sometimes this can again be associated with some vocalization, or almost moaning sounds can occur with this in somebody who's quite relaxed and often not awake. If we're worried about pain, we do treat pain and see how they respond in case there's a pain component, but often it's just the breathing pattern itself. So oxygen at end of life, kind of put this in with the breathing changes that we see. As I said before, dyspnea and hypoxia are different. Oxygen may be helpful to patients who are hypoxic and dyspneic, but if there's not a component of hypoxia, then oxygen is less likely to be helpful. But it has really important medical symbolism for families. I think especially as I care for patients at the end of life and we are focusing exclusively on comfort, we've moved away from the ICU setting most of the time, and so we don't have a lot of those other medical interventions. In our society, dying has been moved into the medical realm. It's been moved away from home with families over the last 50 years. And so, excuse me, they often expect something medical to be done, and that oxygen in place can fill that void for families. And so it's more complicated than turning off a therapy that's not helpful. It really requires some conversation and a thoughtful approach of whether or not this is helpful, or some families can recognize that it in fact may prolong the dying process, but it depends on where we are, what our goals are, and what the symptoms are that we're managing on whether or not it's something we continue. Other changes that we see as we approach end of life are vascular changes with cyanosis that progresses peripherally to centrally, modeling of the feet and ankles and knees, and then the loss of pulses. Probably in BLS and ACLS you learn that radial pulse is lost at blood pressure less than 80 or 90. And so our kind of literature supports that often a prognosis of around less than 12 hours once you've lost a radial pulse. In the dying process, patients can lose the fat pad in their eyelids, and so sometimes it's difficult. They are unable to close their eyes thoroughly, and so that can be quite distressing for patients or for families to see patients that way. Sometimes in the trauma setting, they'll use shields, or in surgery they'll use shields to hold the eyes closed, but we find that that's pretty upsetting to the family to have that. It's kind of disfiguring. So really just focus on using lubricant for the eyes. So if many times we see patients perk up kind of in the days before death. They may have been going down this course and time was looking really short, and then it's Saturday, their family is there, they wake up and they're talking to everybody, they have a peanut butter and jelly sandwich, they go down the hall, they feed the fish. We don't have a great explanation for this. Kind of like some of the visions and some of the disorientation that occurs, we don't have a great medical explanation, but it happens enough, and I've seen it enough, that this is real, and we call it the rally. And so when this happens, we encourage patients and families to make the most of the time that we have, and enjoy being together and try and do some of the things that are most meaningful to them that we're able to provide at that place. Because often there's still an irreversible medical illness that's ongoing and underlying that we're not going to be able to turn around. And so, you know, I've seen this on Saturday or Sunday and the person passes away Monday morning after everybody's left. In my experience, that's where I've seen it the most. But trying to support the families through that can be really difficult at times. And so I encourage, and I often will recruit some of my chaplaincy colleagues, kind of recruit all of my interdisciplinary team to help support the patient and the family at this time, to make sure that we're making the right decisions for them. So based on all of the things that I've kind of, my formatting is a little funny here, but you can get the idea. One of the questions that I get is, should we stay? And so some of the symptoms that we've talked, you can't even see this one's a little bit better. These are slides from the 2 studies that are looking at patients with cancer and really end-of-life symptoms. And so as I mentioned in this slide, some of these breathing changes are really the last day to 2 of life. And I encourage families that if it is important for them and for their loved one that they be present at the time of death, that those are the signs to call folks in and to have them come to bedside. As I said when I started, everybody's symptoms are unique, and I can't guarantee which ones that someone is going to have and what the exact time course is. Is the urine output over the last 12 hours going to be less than 100, or the apnea? Everybody's course is unique, but when I see a conglomeration of these symptoms coming together, the more of them I see, the more confident I am in my recommendations that I'm looking at hours. I think, as I mentioned at the beginning of my talk, I work at the VA, and I have found that that patient population doesn't always fit the data that I have from the civilian population, particularly relating to what I think is some psychological struggle that they often encounter in the last days and weeks of life. They may not be awake and talking with us, but I can see struggle in their face, and there's often more distress there than I see in my other patients. And so some folks take a harder road at the end. And so our goal is to try and use the symptoms that we know to give the families the best advice that we can, but no matter what, trying to take the very best care of them in those final days and hours. And so things that I encourage all families really as we approach the end of life are to be present if that's something that's comforting for them. Using calm voices, bringing blankets from home or other comfort items, playing music that someone loves, be that Johnny Cash or hymns, whatever it is that's meaningful to them. And then that talking is really important. Saying goodbye, saying I love you, saying thank you, giving forgiveness to them, asking for forgiveness for things that have happened. Even if your loved one isn't able to talk to you at that time, our evidence is such that they can still hear, and I think that that's really important, not only for the patient, but for those who will survive them. I think, as Christy mentioned, that the emotions of the family in this time are really complicated, and so trying to support them as well and using your interdisciplinary team to do that, chaplaincy, social work, nurses, having anyone involved that you can to help. And then I think at the time of death, as medical providers, we also play an important role. As I mentioned before, death has moved from the home into often institutions, and so we have many generations who are not used to seeing dying and seeing death and aren't sure how to approach someone at this time. And so through the ritual of death pronouncement, I think it's important that you hold your patient's hand or say goodbye or say thank you for letting us take care of you. Just touching the person and letting the family know that that's okay. And then giving the family permission to be with their loved one and to grieve, allowing them to spend time with the body. And as I said, kind of modeling how to say goodbye. So despite the great variability in diagnoses, most patients in those final days follow a very similar course, and providing anticipatory guidance for the patient and for the family can really help alleviate some of those fears and help everyone cope in that process. As I've said, the timing is unpredictable, but we look for trends so that we can give the most helpful information that we can. And then normalizing this process. And if you can, reframe that they've had a good death as best we are able. A couple of resources that I find helpful include Fast Facts. This is put out through the Palliative Care Network of Wisconsin. It's a free app. It's free one-page articles that are peer-reviewed. There's over 360 of them covering any number of issues that you can encounter in caring for patients at end of life, be it difficult symptoms, communication, and management. So it's something I have on my phone, and I encourage all the learners that work with me. I work with the internal medicine residents and our palliative care fellows quite a bit that we use. Up to date, I'm not sure if you have an institutional relationship with that here at St. Vincent's, but they also have a lot of good resources regarding end-of-life care. And then for nationally, the Center for Advancement of Palliative Care is a big organization for palliative care. There's CAPC.org for providers, but there's also a public-facing website that can be helpful in providing information about palliative care and resources for families. And then locally, if you care for patients, the Amelia Center at Children's of Alabama is a resource for children of either people who are affected by loss and grief. So if they've lost a grandparent that they're close to, this is a good resource to point the family to. Or if they've lost or losing a parent, a sibling, any number of kind of important relationships. But I often give this to patients and families because I think for patients it's hard to talk to children about what's going on and how. And then I'm not a child psychologist. I don't know what to expect in the grieving process for children at different ages, but they have good resources for that to help parents and schools and everyone kind of know what to expect and how to help take the very best care of those children. And so with that, I'm finished. Are there any questions I can help answer for you? Yes, sir.
In the hospice
Mm-hmm.
care, level of medical support is, are they going to be attending the patient before they go?
So hospice care, as Christy was saying, there's 4 levels of care. There's basic care, which is a nurse coming in. With the basic care, it's usually kind of up to an hour daily. But as symptoms escalate, there can be an increasing nursing presence. The goal usually with hospice is to really try and manage the symptoms at home and make medication adjustments at home. And so it may be more nursing time at bedside. They do have what's called continuous care, which don't quote me very specifically on this, but I think is up to at least 8 out of 24 hours a day of some presence in the home through the hospice company. And then there's the ability to escalate care to general inpatient admission if symptoms are severe. Often the changes that we see in patients as they approach death, we've made medication adjustments along the way. And that there may be some increased pain or dyspnea or other agitation really in those final days, but usually that can be managed at home with hospice. So in the hospital we're used to using IV medicines, and earlier in disease we use oral medicines, but with hospice we actually have high concentrated oral formulations of morphine, oxycodone, and haloperidol are the common ones that we use that can be absorbed buccally. And so usually with those medications we can find a good regimen to control most symptoms at home.
I was really looking at, is this an RN or is this what level of provider?
Okay.
It's getting to another question.
Okay. I'm trying to stay right here and where I can hear you. So usually the care in the home is provided by an RN. With certifications, there's nurse practitioners and physicians that provide those evaluations, but usually the care at the bedside is provided by an RN with a physician backup. And so there's a physician backup available 24 hours a day. The hospice really developed out of nursing, and it really wasn't until I think the 80s, 90s that physicians came in and became more oversight in it. And so it really is a nursing-driven care model.
Well, the reason I was asking is, let's say a patient, I'll give you an example I know about.
Yeah.
The patient had ischemic heart disease without congestive heart failure. Well, it was reported to me that the patient was drowning. Unfortunately, it could be congestive heart failure, new development, or
Yeah.
just fluid on the
Yeah.
or something. So
Yeah.
you got an RN or family there. This is developed. It's different. How does a mechanism occur to decide whether this is a new development that could be treated?
Mhm.
Is LASIK very efficient?
Mhm.
Or do they just stay there in comfortable fees, which is what we've done?
Okay. Asking for nurse physical exam and vital signs is something that I always do, and I have to trust, kind of based on their physical exam. Can they hear the lungs? What are the lung sounds? How do we manage it? So I'm not a hospice medical director. So hospices have a medical director that provides the direct patient oversight, but they can all patients on hospice can also have another physician as record. And so through my position at both UAB and the VA, we are sometimes the physician of record. So I do manage hospice patients at home. And so what will happen often is that the nurse at the bedside will give us a call and say, this is what's going on. And then I call the nurse back and say, can you look at this and this and this? Can you check some vital signs? And try and get more information about exactly clinically what's going on. Sometimes it is, on hospice, medications can be recommended and obtained at home without the person having to come in and be evaluated. So often it'll be something empiric where I'm like, oh, they have Lasix at home. This has been an issue before. Go ahead, let's do a dose of Lasix now. Let's see how their symptoms are doing. Do they have good urine output? Do we need to escalate the dose? Or do we need to do 3 days of Lasix? Let's adjust the comfort medicines while we work on getting the symptom treated, and then have them reassessed.
So if they deteriorate, they're already protocol to contact their physician.
So a physician's available 24 hours a day.
You're switching physicians though, aren't you, from the private physician or the hospital physician to a hospice doctor?
So you can. And that's what most providers choose to do, particularly hospital providers will hand over care to the hospice medical director. As palliative care physicians, we feel very comfortable managing these patients, particularly if we've been caring for them in the hospital. If we've been caring for them in the hospital, it's sometimes with more complicated symptoms or more difficult to manage pain, something that's complex, such that in those cases, we ask to continue to be involved. And it may be that we ask that the hospice medical director take over, or we ask that if they have questions or concerns, please reach out to us such that we can help. Are there other questions about hospice I can help answer? Thank y'all so much. over.
So my name is Brent Boyette. I'm an addiction medicine specialist from Hamilton, Alabama, and I'm going to take a little bit of a broad swing. We're going to go from talking about hospice and palliative care to opioid-induced hyperalgesia, which is a little bit of the opposite end of the spectrum. In fact, in this big conundrum that we're faced with these days, are opioids bad or are opioids good? It really depends, right? So, in palliative care, in a hospice situation, opioids may be a gift from God. But in a 35-year-old construction worker with low back pain, or a 40-year-old patient with fibromyalgia, chronic use of opioids might be a curse from the devil. So, do opioids ease pain or do they create pain? The answer may be yes to both of those things, through a process called opioid-induced hyperalgesia that has been described in the literature for decades to centuries. So it's important to understand that as an addiction medicine specialist, I hold this fact to be true, that at the root of all addiction, there's always pain. In fact, I have healthcare professionals all the time ask me the question, do you believe that she's really in pain, or do you think she's just become addicted? See, the question itself illustrates to me that the the person asking the question doesn't really understand addiction. Because at the root of all addiction, there's always pain. Physical and emotional pain. A heroin addicted person will call up the drug dealer and say, "Man, I'm hurting. Can you help me out?" That pain is very real. So, the way we think about the use of opioids and the way we think about pain has changed over the past several decades. As a matter of fact, at the end of the last century, from the 1800s into the 1900s, we had a similar opioid epidemic in the United States. At the end of the Civil War, there were some new inventions like morphine and the hypodermic needle, and soldiers came home with what was called soldier sickness, which was probably some combination of what we now know as PTSD and opioid dependency. And it became such a public health crisis that in 1914, Congress took the unprecedented act of passing the Harrison's Narcotics Act, which put restrictions on the use of opioids. And there was a case that went before the Supreme Court a few years later in Memphis, Tennessee, called Webb versus the United States, where a doctor and a pharmacist were found to be guilty of providing opioids to opioid-dependent patients for opioid maintenance. And at that point, with that precedented case in Memphis, Tennessee, doctors in the United States really withdrew the use of chronic opioid use through most of the 20th century. What Webb versus the United States effectively said was that it is illegal for a doctor to provide opioid maintenance for an opioid-dependent patient. The doctor in Memphis, Tennessee, was providing morphine as an opioid maintenance program. So, during most of the 20th century, opioids were reserved for acute pain management, that is in the days following an acute injury or a surgery, or end-of-life care, just like our last lecture. And generally speaking, during most of the 20th century, opioids were administered in the hospital setting, not take-home self-administered opioids. If you were sick enough to be on an opioid during most of the 20th century, you were sick enough to be in the hospital. But in the 1980s, we began the dehospitalization movement, right? Because keeping people in the hospital for 2 weeks, 3 weeks at a time became too expensive and unsustainable. And so home health became a thing, home hospice became a thing, and take-home self-administered opioids became a thing. See, there was this feeling among healthcare community that morphine and some of the traditional opioids were dangerous and addictive, but somehow oxycodone and hydrocodone were less addictive. And so doctors began to prescribe more and more take-home, self-administered opioids to be used at the patient's own discretion. We begin to see it, first of all, in medicine and surgery, and then we begin to see it expand out to dentistry. I went through the University of Alabama School of Dentistry back in the early 1990s as we were beginning to really raise the ramp up on prescribing of opioids. And in a post-operative pain management course taught by an oral maxillofacial surgeon, at the end of the lecture, one of my classmates raised her hand and said, "Doctor, how do you know how much pain medication to give a patient after a simple extraction or a root canal?" And the doctor down here at UAB grinned and leaned over the podium and he said, "You give them enough that you don't get phone calls." That's how cavalier and how we thought about opioids during the 1990s. So during the 1980s, we began a dehospitalization movement where we began to prescribe opioids as a take-home self-administered dosing to put the onus on the patient. And then pain management became a metric for quality measures. The Joint Commission began to grade hospitals and doctors on how well they treated pain. And it became a measure of what is a good hospital and what is a good doctor. So if Dr. A was able to get your pain from a 10 to a 2 and Dr. B was only able to get your pain from a 10 to a 5, Dr. A was rated as being the better doctor, as administering higher quality of care, as were their hospitals. So in hospital boardrooms and conference rooms across America, hospital administrators and doctors and nurse administrators begin to say, how can we get our patient satisfaction scores higher and our pain scores lower? Well, that's easy. Medications do that quite effectively in the short term. And so we begin to see opioid prescribing both in the hospital setting and the outpatient setting go up each year throughout the course of the 1990s. Pain became known as the fifth vital sign. And those metrics became the metrics of what is good health care. And there were even financial incentives linked to this. Hospitals and doctors were able to get bonuses based upon patient satisfaction scores, Press-Ganey scores, and also low pain scores. Throughout the turn of the century, not only did the number of opioids being prescribed increase, but so too did the strength of them. If a little is good, then more is better, right? Because if the measure of a good doctor or a good hospital or a good nurse is who can provide the best measure of chemical comfort, then I can write oxycodone, hydrocodone, and yes, even fentanyl and Dilaudid with the best of them. It doesn't take a great deal of sophistication just to write ever accelerating doses of opioids. And so about a decade after these paradigms begin to shift, we begin to see opioid overdose deaths rise. And those begin to increase each year. Today, you know the statistics. I won't go over them and hash them, but you're more likely to die of an overdose death in the United States than you are of an automobile accident. 73,000 Americans died of an opioid overdose last year in the United States, and those estimates probably are underestimated. So we began to see the opioid epidemic move into three phases. First was the doctor-prescribed pain pill phase, followed by the heroin phase, followed by the fentanyl phase, the synthetic fentanyl phase, which is being supplied by Mexican cartels, which are connecting us with the Chinese manufacturers. Now there's a fourth phase that we're entering into, which is the combined controlled substance phase, which is prescription speedballing, which is prescribing opioids with CNS stimulants like Adderall and Vyvanse and Ritalin and phentermine, or combining benzodiazepines with opioids to create an added dopaminergic release in the nucleus accumbens of the brain. So we are beginning to see more and more patients combine both stimulants and opioids or stimulants and benzos together in a very toxic soup that just bathes the brain in various different ways of dopamine release, stimulating the mu receptors, the GABA receptors, the cell membranes themselves, all of which have one thing in common, which is the release of dopamine in the nucleus accumbens. This is 2011 data from the Centers for Disease Control, and a couple of things I want you to pay attention to. Unlike epidemics of the past, which tend to affect teenagers and young adults, the modern opioid epidemic affects primarily the 45 to 55-year-old age range. You, in 2011, were more likely to die of an overdose death if you were between the age of 45 and 55 than any other age group. But also pay attention to the fact that for every age group, in 2011, you were more likely to die of a doctor-prescribed opioid than an illegal opioid. So, in 2011, American doctors kill more people than American drug dealers. And we all bought into this, that opioids are safe, opioids are not addictive, opioids are an effective long-term solution to pain control. One of the eye-opening statistics that reported by the World Health Organization in 2011 was the WHO reported that the United States, which makes up only about 4.5% of the world's population, in 2011 consumed over 80% of the global supply of prescription opioids. That same year, American doctors prescribed 99% of the global supply of hydrocodone. This was during the era when hydrocodone was a Schedule III, as opposed to oxycodone, which was Schedule II. We were taught, and we believed that for some reason, hydrocodone, because it had a little different side chain, was less addictive and less abusable than oxycodone or fentanyl or heroin or so forth. There may be difference in potencies, but that's easy to overcome with dose, right? And especially when you manipulate the delivery system by crush and snort or injection, which patients who self-administer their own medications without oversight, oxycodone, hydrocodone, Dilaudid, often do. So in 2013, stimulated by the World Health Organization report showing that American doctors use far more opioids than any other nation in the world, the CDC began to look at who was prescribing these opioids and why. And by the way, benzodiazepine prescribing tends to follow the same patterns. Interestingly enough, overprescribing of antibiotics tend to follow the same kind of prescribing patterns too. It turns out in 2013, according to the CDC, that there was not an equal distribution among opioid prescribing in the United States among American doctors. That while the United States prescribed far more than the rest of the world, it was the Appalachian region of the United States that prescribed more opioid pain relievers than the East Coast, the Midwest, or the West Coast. The public health community began to coin the phrase the Appalachian Pillbilly region to describe our region who was so dependent upon prescription opioids for self-administered use and prescription benzodiazepines for self-administered use. And according to that data, in 2013 by the Centers for Disease Control, Alabama led the United States, while the United States led the world for per capita opioid prescribing. Tennessee was a close second, but Alabama ranked number 1 in 2013, and we still rank number 1 today. Opioid prescribing in the United States has declined since 2013, and opioid prescribing in Alabama has declined since 2013. However, we still lead the nation. There's a strip through North Alabama here when broken down by county and by parish, where you can see that opioid prescribing kind of leads the United States. Also, there's an area in East Tennessee. And according to a study done by Harvard back in 2018 that looked at per capita opioid prescribing broken down by United States congressional district, Alabama's 4th congressional district, Robert Aderholt's district, the little area of land that gerrymanders along Highway 278 in North Alabama, earned the distinction of being the number 1 prescriber of per capita opioids in the United States broken down by congressional district. Alabama congressional district number 1, I believe it is, or 5, down in Mobile area was in the top 5. Down in the Mobile area was in the top 5. But you can see that Alabama really leads even in that study. This is data from the Alabama Prescription Monitoring Program. And what I'll look at here is specifically 2015. 2015 was kind of the peak of our opioid prescribing. In 2015, Alabama doctors prescribed almost 6 million prescriptions for opioid pain relievers just in that 1 year. That same year, Alabama doctors prescribed nearly 400 million opioid tablets. And in 2015, Alabama doctors prescribed over 5 billion with a B morphine milligram equivalents of opium. It's a wonder that we don't have to pour Narcan in the Mobile Bay to keep the fish alive, right? So these statistics beg the question, what does the rest of the world do for their pain? Is there any evidence to believe that North Alabama experiences more pain than people in China or India or Great Britain? Well, maybe, maybe not. As you can see, we lead the world, and Alabama leads the nation. Could it be that our pain epidemic is actually iatrogenic, caused by our healthcare system. Interestingly enough, during the same period of time that Alabama ranked number 1 in the United States for opioid pain relievers and pain, we ranked in the bottom 25% for the diagnosis and recognition of opioid dependency, opioid addiction. Now, there are several reasons for that I won't get into, part of which prior to 2015, if you called it that, you couldn't get paid to treat it. Secondly, there are all kinds of laws and regulations and rules that apply to the addiction treatment world that don't necessarily apply to the pain world, and certainly didn't during the 2015-2013 era. So why is that? Well, it's kind of like that cartoon where you're looking at the ground and one person says it's an M and the other person says, what do you mean? It's a W. It depends on your perspective. It depends on the questions that you ask. It depends on your approach. So, what is appropriate? Pain management or addiction treatment? Because here's the thing. Physical somatic pain is a symptom of addiction, just like it is of a bulging disc or chronic arthritis. So, is it chronic pain or is it opioid dependency? Should it be pain management or should it be opioid maintenance? Keep in mind that Webb versus the United States in effect says it is illegal to prescribe opioids for the treatment of opioid maintenance, for the purpose of opioid maintenance in the United States, according to the Harrison's Narcotics Act. During the 1990s, the pharmaceutical industry created the concept called pseudo-addiction. Pseudo-addiction was drug-seeking behavior caused by the undertreatment of pain. You remember hearing about this. Said, well, they're not addicted, they're pseudo-addicted. That's addiction. There's nothing pseudo about that. See, addiction may start out as a motive to pursue pleasure, but over time, it becomes uniquely and unanimously driven by the desire to avoid pain, physical and emotional pain. In one retrospective study that I looked at, that looked at over 100,000 charts in review, what it found was that if a patient takes an opioid pain reliever every day for 30 consecutive days, there would be a 47% chance that they would still be taking it on a daily basis 3 years later. Are they in pain or are they addicted? What difference does it make? You've got to have it, you've got to have it. The word addiction comes from the Latin word addictos, which loosely translated into English means enslaved to. A person becomes a slave to a substance or a habit, despite adverse consequences. So let me describe it for you this way. I'm going to step out. I may actually disappear out of the frame, but I want to just draw something for you here, just so you can understand the concept of what I'm talking about. In our quest for life itself, we're all trying to survive. Survival 101, that's life, right? And in our quest for survival, we are given the perception of pain and pleasure. That's a frowny face and a smiley face. Now, by pain, I don't just mean backaches and headaches and my knees hurt, my joints hurt. It includes somatic pain, but it also includes emotional pain, fear, anxiety, sadness, depression, guilt, shame, anger. All of those things are uncomfortable and unsettling emotions, and we lump physical pain and emotional pain together, and we call that combination dysphoria, D-Y-S-P-H-O-R-I-A, physical and emotional pain. But equally important for your survival and mine is pleasure. And by pleasure, I mean physical pleasure and emotional pleasure. And we lump those two things together and we call that term euphoria. You've heard that term. The drug is associated with a strong sense of euphoria. It means wellness. It means pro-survival. This compels us toward things that are pro-survival. And this dysphoria drives us away from things that are harmful or counter to our survival. In modern American culture, we have come to demonize all pain. We have in effect said all pain is bad. If you have restless legs, see your doctor. If you have trouble falling asleep, see your doctor. If you're nervous, anxious, or depressed, see your doctor. If you suffer from migraines, see your doctor, see your doctor, see your doctor. And acute comfort provisional medications have become a multi-billion-dollar industry. We have come to say that all pain is bad. And I think it's time to actually talk about the utility of pain to our patients. Pain is a gift from God. Pain is our body's way of saying, don't do that, it's not good for you. So everything that we do, every moment of our existence is motivated by our desire to avoid pain and pursue pleasure, even altruistic motives. Pain is essential to survival, and the only pain-free state that you and I will ever achieve is death. So, pain is important to survival. And I'll just give you a few examples. I cough because I'm uncomfortable. But the real reason that I cough is because there's something in my airway that needs to be cleared is there. It may be mucus, it may be Mountain Dew if I turn it up and swallow it the wrong way, but it is in my best interest to cough and get it up. But one of the best pain medications, one of the best cough medications on the market is hydrocodone, codeine, right? It doesn't do anything to help your lungs. It just dumbs your brain up so that you can ignore the fact that you've got a problem in your lungs, to which I say to patients, let me ask you a silly hypothetical question. If I were to stick my hand in the fire and the fire began to burn the flesh off my hand, should I A, remove my hand from the fire, or B, just leave it in the fire and take a pill so that I don't feel the pain of my hand's destruction? See, the modern American mindset says in effect, oh my God, my hand's burning, what can I take for that? So I leave my hand in the fire and I take something so I don't feel the pain, and then I wonder why I can't write with my hand anymore. I lose function. I sacrifice function for the sake of comfort. And we do it all the time in modern healthcare. See, I used to put people to sleep. I used to do anesthesia. And sometimes I would give people a little bit too much Versed and fentanyl. You know, titrate it, they'd still be awake, touch you a little bit more, and then I'd overshoot the runway. And their jaw would fall back in their throat, their tongue would fall back in their airway, and they would become apneic. And if you looked at the pulse oximeter, it would go from 95 to 90, 85 to 80, 75 to 70. And if somebody didn't step in and give positive pressure ventilation or a chin lift, jaw thrust, or a little stimulation, then that patient would quietly and comfortably succumb to an overdose of euphoria. See, it's in the patient's best interest to feel discomfort of hypoxia. The reason that I breathe, the reason that I stop between my words to you and take a breath is because it becomes a little dysphoric to go too long without a breath, and it gives me a little bit of pleasure or a reward to take a breath in every once in a while. You give me enough Dilaudid, and I'll lose that motivation. I'm good. I don't care if my pulse oximetry does read 55. Feels fine to me. So it's important to maintain a homeostatic balance of euphoria and dysphoria. We were born with this, and it drives our footsteps. If I go too long without drinking fluids, then my needle moves toward dysphoria. I develop a form of dysphoria called thirsty, and I'm compelled to stop what I'm doing and go get a drink of water or Coke, and I don't die of dehydration. When I go too long without nutrition, my needle moves toward dysphoria. I develop a form of dysphoria called hungry, and I'm compelled to go get something to eat, and that's good for me. Everything that we do, even the position you've chosen in this chair right there, you've chosen the position because it's comfortable, but it's comfortable because it's functional. You wouldn't stand on your head while you listen to this talk, but it wouldn't be very good for your brain and your soft tissues either. So you've chosen a position that's functional. And if you sit on one butt cheek for too long, and you compress those capillaries in that butt cheek, long before you start developing skin breakdown and pressure sores, you're going to get a little uncomfortable. And you're going to be subconsciously compelled to shift your weight from the one butt cheek to the other butt cheek. Blood flow will be restored to those capillaries and you won't get skin breakdown. But in the ICU, we can put you on a propofol drip. give you so much chemical comfort that you will ignore your own body's well-being. And that's a high duty for an anesthesiologist. You take away a patient's reflexes, then you are responsible for those reflexes. Whether that be a gag reflex to control that and protect that airway, to pressure sores or pinching a piece of tissue between the gurney and the mattress. You're responsible for that because you've taken away that patient's own ability to detect that problem, and that's a high duty. Take-home comfort medications like benzodiazepines and opioids are a higher duty than we realize. It's important that we have a homeostatic mechanism that maintains a balance, and that the variation in the needle between dysphoria and euphoria is caused by our circumstances and not our the chemical content of our blood. So this is how it happens. A person bulges a disc, they go to the doctor, they say, I haven't slept in 2 weeks, I'm miserable. The doctor says, I'm going to give you some oxycodone or some hydrocodone. You take it, so you go home and you take a Percocet and you swallow that thing. Within 15 minutes of that activity, you become a better person. The bulging disc, the radicular pain doesn't hurt as much. Your trauma of your past life, the fact that you were sexually molested when you were 12, that doesn't even bother you as much. The stress of life doesn't bother you as much. You're thinking, my God, where's this stuff been all my life? This completes me. But over the next 3 to 4 hours, that Percocet wears off. And you move just a little bit to the dysphoric side of where you were before. So then you take a second Percocet, but the second Percocet doesn't quite give you the relief that the first one did. It's helpful. It's still wonderful medicine. This is a miracle drug. But boy, the first one was really incredible. So rather than waiting 4 hours or 6 hours to take another one, I'll go ahead and take another one after about 4 hours. And I begin to learn on a subconscious mesolimbic level that it's a dose-dependent process, that the more of the little white tablets that I take, the better I survive. Pills equal survival equal life. But over time, that effect wears off. So then we would develop dose creep, where I have to take a 7.5 Percocet, and then a 10. And then that wears off. If you notice over time, the dots are moving further and further away from each other on this hedonic tone scale. And if I were to stand hedonic tone scale up on a vertical axis with the way that pleasure's at the top, pain's at the bottom, and I were to pull time across this axis, what I've been describing here over time would look something like a roller coaster effect. A roller coaster ride in which the highs and the lows do not correlate well with the circumstances of my life, and they're only determined by the chemical content of my blood as it courses through the capillaries of my nucleus accumbens. It's highs and lows that over time go downhill in the sense that the highs are not as pleasurable as they were in the beginning, but the lows become far more painful over time. Here's the thing. When a person uses an exogenous dopamine-releasing agent to push hedonic tone into an area of euphoria repetitively, the brain will try to reset baseline in an effort to establish a homeostatic balance. And so what that means is when the pain pills, the fentanyl, wear off, over time, I don't go back to the middle with an equal balance of pain and pleasure. When pain medicines wear off, I become chronically dysphoric. I develop dopamine resistance in the same way that a type 2 diabetic develops insulin resistance. The over stimulation of dopamine receptors results in a dopamine resistance. Solomon and Corbett in 1974 described it according to their opponent process theory. What they said was that any stimulus that acts on the brain's pain and pleasure centers will have an opposite reaction. So you can see the action of the drug. If you can imagine the smiley face being at the plus 100 and the frowny face being at the bottom 100. Then alcohol, benzodiazepines, opioids, methamphetamine, Adderall, whatever the dopamine releasing agent. When you swallow it, you get a positive effect. When you ingest it, you get a positive effect. And that lasts for a period of time, and then there is a rebound effect. The positive effect Solomon and Corbett called the A process, and the rebound effect Solomon and Corbett described as the B process. Now, that's not a big deal if you take hydrocodone or Percocets for a short period of time. You get over it, it's very subtle, not a big deal at all. Same thing if you just have a binge drinking episode every once in a while. You'll have a little hangover the next day, but you'll get over it and it won't be such a bad deal. But when you begin to stack the A processes and the B processes B processes together, you get a downhill roller coaster effect that is sustainable and results in chronic dysphoria. Chronic dysphoria includes an amplification and a perpetuation of physical pain and emotional pain. This is a study that was done in Strasbourg, France a few years ago, and I'll just describe the study. This was done, this is the assessment of morphine-induced, an opioid, morphine-induced hyperalgesia and analgesic tolerance in mice using both thermal and nociceptive modalities. So let me just tell you what the researchers did in plain English. Researchers took the mice and they handled them every day for about 2 weeks so the mice did not become stressed by being handled by the researchers. And then they measured their pain tolerance. They did it 2 ways. Number one, they took the little mouse's tail and they stuck it in a vat of hot water. And it was about 45 degrees centigrade. Hot enough to hurt the tail, but not hot enough to cause tissue destruction. And they recorded the amount of time that the little mouse could leave their tail in the hot water before they became agitated and began to squeal. It's called a squeal test. And the second way that they did it is took the little mouse's tail and put it in a specially made vise that slowly clamped down on the mouse's tail with pressure. And they recorded the amount of pressure in terms of grams of pressure that the little mouse could stand before they became agitated and began to squeal again, the squeal test. And then they randomized the mice into 2 groups. The researchers didn't know which mice were getting what medication, but one group of mice got a shot of morphine every day. The other group was randomized to placebo, saline, salt water. And then they measured their pain tolerance in the hours or the minutes following the injections. Let's look at this data. Notice that the mice on day 1, and by the way, the first graph to the left is day 1, and the second graph to the side is day 6 or day 7. So they did it each day, one time during the day. Notice that the mice that received the morphine injected, that's the the black dots, or the black circles, are able to keep their tails in the hot water much longer than the mice who received normal saline or placebo. No big surprise there, right? Morphine increases pain tolerance. But look what happens as the morphine wears off, even after the very first dose. At about 160 minutes following the morphine dose, the mice who received the morphine injections actually begin to squeal quicker than the mice who were receiving saline. They repeated this each day, and by day 7, notice that the mice who receive the morphine get a little benefit, but it's not much, and it certainly doesn't last as long, and the rebound effect, the B process, as described by Solomon and Corbett, is much more profound. Does that hang around even hours after the medicine's completely worn off? The morning after, before they injected the mice with anything, they actually looked at pain tolerance in those mice. And the mice, and this is the days, on the horizontal axis is days with each day of injection. Notice that the saline-treated mice, the morning after the injections, are able to tolerate much more tail pressure in the vise than the mice who received the morphine injections the day before. And with each day of administration of morphine, the pain tolerance gets worse and worse and worse. The same thing's true with the tap water immersion test. The saline-treated mice, the morning after the saline injections, are able to tolerate much more time in the hot water than the mice who received morphine the day before. So the interpretation of that is chronic, long-term use of opioids may be like dealing with the devil. That because of the B process, opioids relieve pain in the short term, but they create chronic pain in the long term. Benzodiazepines have the same effect. Benzodiazepines are CNS depressants, just like alcohol. They work on GABA A. They cause slowing of neuronal firing, a calm brain. But you take benzos every day, and you stack those A and B processes together in that downward roller coaster ride that goes downhill, and then abruptly discontinue the benzodiazepine or alcohol, you get the ultimate CNS excitation. It's the ultimate B process, which is a seizure. The same thing's true with somatic pain, there is a rebound effect. There is so much to talk about in opioid-induced hyperalgesia, there is no way to even scratch the surface of all the different mechanisms that occur and to take it to what we understand it into. But let me just hit a few of the high points. Some of the mechanisms of opioid-induced hyperalgesia involve dopamine receptor downregulation in the periactoductal gray matter and the rostral medulla. I'll show you a picture of that. We also see a loss of glutamate feedback inhibition from the prefrontal cortex and its effect over the nucleus accumbens to control craving and to control urges. So there's a loss of urge control. And then there's also good scientific evidence to suggest that chronic opioid use results in the loss of the natural descending anti-nociceptive pain pathways that may be what prevents chronic pain in China and India for patients who don't get on opioids. So pain is a funny thing. If these were my feet, this would be a very painful situation. But if I did it every day for months and weeks and years on end, I might get like this guy. I might. Everybody says, well, he just has calluses on his feet. Well, that's true. His skin gets thicker. There are calluses. That's part of it. But there's much more going on with this guy than just calluses. There's also central nervous system changes that occur at his perception of his feet. It has to do with a process known as salience. You remember this from neurophysiology? Salience is the quality of being particularly noticeable or important or prominent. It's priority of importance. So if you were to ask me right now, do you have shoes on your feet? Yep, I got them there. I got shoes on my feet, I got a collar against my neck. It's not a big deal. It has a low order of salience. It's not important to me, and it has very little emotional charge. But you stick a nail in my foot. Now that's different. I care much more about that. So where is that salience determined? Is it determined in my foot? No, it's determined in the central nervous system. It's determined in the rostral medulla, in the periactoductal gray, in the hypothalamus, and the thalamus itself. That's where the emotional charge gets added. That's where the caring is added. So the way this works is, this is an arthritic joint. It could be a nail in my foot. It could be any source of inflammation or pain or tissue destruction. That impulse is carried through a pain fiber, a nociceptive fiber, is carried through my dorsal root ganglion, crosses over to the contralateral spinal thalamic tract, and then ascends up my spinal thalamic tract. And as it enters into the rostral medulla and the periactoductal gray, these areas here in the little blue ovals, that's when the pain is added. That's when the central nervous system awareness is added. And that's where one of the main places that opioids act. They work there to dampen the salience of the impulse. They also work at the dorsal root ganglion, and we'll talk a little bit about that in a chronic way. These are the anti-nociceptive pain pathways. I won't get into that. You all are familiar with the spinal bulbar tract and the spinal thalamic tract and those kinds of places. But this is a little simpler diagram of how it happens. What happens in that situation with that barefoot runner is this. If I did it every day, just like in the old show Kung Fu, when the guy hits the thing every day and the knuckles get tougher, the brain will recognize that impulse pattern, and it will in effect say, Brent has been running on these rocks for several weeks now. It's obviously not caused him to lose his feet yet. Apparently, the threat is not as bad as we thought it was. Central nervous system is saying this. So we're going to discount this thing because he's been seeing these rocks for a long time and he's not dead yet. So what will begin to develop is a descending anti-nociceptive pathway that will come out of the thalamus and will come back and will cross over to the contralateral dorsal root ganglion, close the gate or mitigate the gate of that pain so that that is not a high order of salience anymore. When we feed our brains and our dorsal root ganglions opioids, that process is mitigated. You can see that opioids do work in the, I don't know if my pointer works, opioids do work in the dorsal root ganglion, and when we overstimulate those receptors, that process never comes into effect. It has to do with the process of epigenetics and genetics, but epigenetics is the process by which genomic expression, DNA protein synthesis, can either be turned on or turned off based upon environmental influences. Very much like a bear grows fur in the fall and sheds it in the spring. It's an epigenetic process. So a gene codes for proteins, and that, based upon environmental influences, that situation can be either turned on or turned off by curling up around these histones. So let me just show you what we're talking about here. This is a G protein. It's nothing more than a protein. It's a dopamine receptor. So if I move hedonic tone to euphoric, or to push it, start overstimulating those receptors, the brain will say that's too much reward, and it will compel the genes that code for protein synthesis to replace old and worn out dopamine receptors, to fold up on these histones, and in effect reduce the replacement of dopamine receptors. So what I get is a reduction or a downregulation in dopamine receptors in the rostral ventral and the parietal gray and the dorsal root ganglion, among other places. As a result of this downregulation, the dopamine receptors get old and dysfunctional, and they don't work very well. And I develop a process known as anhedonia, or pleasure deafness. See, I tell patients, if I listen to loud music all the time or listen to loud noises all the time without hearing protection, there's a chance that I will become desensitized to noise. If you overstimulate dopamine receptors by exogenous rewards, the same effect happens. It's a downregulation in the replacement of dopamine receptors, and a person becomes dopamine resistant in the same way that a type 2 diabetic becomes insulin resistant, and that results in chronic dysphoria. I don't go back to the middle. Now I'm living in this way. I'm having good days and I'm having bad days, but once I overstimulate and develop the disease of addiction, my best day hurts more physically and emotionally than everybody else's worst day. See, the way it's supposed to work is this: reward. Things are rewarding in life. That's the reason we get up in the morning. I'm hungry, I want a reward. I'm thirsty, I want a reward. I want the acceptance of you guys. I want you to like me. There's survival in that, and that's rewarding to me. So if somebody says, boy, I really enjoyed your talk, it was helpful to me, or if somebody says, let's go eat a donut, then I'll get a little dopamine release. The dopamine in effect says, hey, that just happened, that was a good thing, remember it and try to replicate it. And I'll get a little dopamine release. If my daughter goes and sits in my lap and says, Daddy, I love you, you're the best daddy, I get a dopamine release from that. And that's natural. It compels me to be a better daddy. And that's a good thing. But if I overstimulate that with opioids and benzos and methamphetamine and alcohol and marijuana, then in effect I develop a chronic dysphoria, so that I become pleasure deaf, and my daughter saying, Daddy, I love you, falls on deaf ears. It means very little to me. Nothing is rewarding unless my opioid receptors are occupied and it's being stimulated. Nothing is okay unless, if I'm a cigarette smoker, unless my nicotine receptors are occupied and being stimulated. You know? That's what I celebrate. It's the way I celebrate. The best meal here in Birmingham is not rewarding to me until I go outside and burn one and occupy and stimulate those nicotine receptors. The same thing's true with opioids. So, rather than having natural modulators of euphoria and dysphoria, I have overstimulated these things and I become dopamine resistant, and these are the little receptors. You can see in the presynaptic site, we see exogenous, rather than just little wimpy natural beta endorphins that are released by natural events. Now we're giving me oxycodones and hydrocodones and fentanyls, and these things just flood the synapse with dopamine, overstimulating these postsynaptic D2 receptors, creating reward, pleasure, contentment, but over time creating anhedonia, or chronic dysphoria. So what we have always said is just say no to drugs, right? Okay, your brother says no, why don't you just say no? Well, the truth is, once the brain becomes dependent on the dopamine releasing agent, street name dope, then it becomes an unsustainable mission. Studies have shown that once a person develops an opioid use disorder, even if they go through 12 steps and withdrawal management and detox, there is a 90 to 95% chance that the person will relapse back to opioids within 1 year of that detox, even with 12 steps and cognitive behavioral therapy, all of which I'm a strong advocate for and believe in thoroughly. It's over time, the opioids damage the brain's pain and pleasure center. I tell patients, I say, you know, I would venture to guess that nobody ever sat you down and said to you before they wrote you that first hydrocodone prescription, this medication that you're about to take can change your life forever. Because there's no cure for addiction. It's a chronic disease. It can be managed, but it is not curable. And it is not substance specific. Treating the disease of addiction is very much like playing the game whack-a-mole. You know, you hit alcohol over the head and opioids pop up. You hit opioids over the head and stimulants pop up. Now in the state of Alabama, we have this epidemic of adult onset attention deficit disorder because we can't prescribe opioids the way we used to, but we got to have the dopamine, right? Now we're seeing 35 and 40 and 50-year-old people that are on Adderall plus an opioid. Prescription speedballing. The street perfected that a long time ago. See, it's important to understand that Adderall works on the brain's reward center exactly the way methamphetamine does and cocaine. It prevents reuptake of dopamine in the nucleus accumbens. So opioids release dopamine and stimulants block the reuptake. You see what the net effect is. Prescription speedballing. The street learned a long time ago you can mix heroin with cocaine or heroin with methamphetamine and create a turbo boost euphoric effect. So there is basically, this is the way I describe the disease of addiction on a larger scale. The prefrontal cortex, well, let's first talk about the VTA, the ventral tegmentum area. All of the stuff that I've been talking about here occurs in the VTA, the mesolimbic cortex. This hedonic tone stuff that I talk about. This the emotional center of the brain. It's based on urges and desires and compulsions, but it's not very sophisticated. It's very powerful, but it sees things in similarities. It's the lizard brain, for crying out loud. It's a primitive part of the brain. It just compels us to breed at certain times and to eat at certain times and to do all those sorts of things. It is only concerned with now. It has no temporal perception. Have you ever talked to a lizard about their future? They'll just look at you. A lizard does not understand future. It understands now. Right now I'm hungry. Right now I want to breed. Right now I want to get out of this hot sun. But human beings have evolved a prefrontal cortex, which has aided in our survival. A prefrontal cortex is our moral compass, so to speak. You know about the story about the guy from Harvard, the Harvard brain who had the frontal lobotomy and he lost his moral compass. It is able to look into the future and to understand things like delayed gratification. That is, I'll go to nursing school for X number of years, even though I don't like it, for the reward of a better career on the end of that. You can't get a dog to do tricks for years for a treat 4 years later because their prefrontal cortex can't project that far into the future. It understands consequences. It understands the fact that it might be fun to steal money from the cash drawer at work and go out and have a shopping spree, but even the guilt associated with that would not be worth that temporary reward, and I won't do it because I have a prefrontal cortex that is able to look at the consequences of that over the long term. So you've got one part of the brain that's only interested now and another part of the brain that considers the future. And sitting nestled between the two is the nucleus accumbens. And it's basically got the VTA, the mesolimbic cortex, whispering or yelling in one ear, and the prefrontal cortex yelling in the other ear. And based upon who gives it the strongest signal is the way the individual will follow. So the further the needle moves toward dysphoria, the greater the neuronal control over the nucleus accumbens the VTA has. So you can swim upstream for a while. I promised my wife and kids I'm not going to use any more of those drugs. I'm not going to drink. I'm determined I'm not going to drink anymore. I'm quitting smoking. But as that needle begins to move further and further this way, and keep in mind that life itself throws stressors at us and triggers and temptations. So the needle's constantly being moved by life circumstances. It's swimming upstream. And you can swim upstream for a while, but it creates a chronic, painful situation that compels the person to go back to doing what they were doing before. So over time, the question with the use of opioids for months and years on end is, do I take opioids because I'm in pain? Or am I in pain because I take opioids? Because of opponent process, because of dopamine receptor downregulation, because of an increasing salience and a lowering of the pain threshold over time, opioid use, benzodiazepine use results in dose creep in many cases, right? And increased suffering if the patient doesn't have dose creep, where you start out with 5s, then you go to 7.5s, then to 10s, and then increase your frequency of dosing. So if you look at the package insert on most of these medications, the black box warning of CNS stimulants says use for the shortest period of time possible. I think that the area that we found ourselves in, listen, I'm not anti-opioid. So it's easy to hear a 1 hour snippet of this and say that, well, Dr. Boyette says he's against all opioids. No, of course not. But we trained for a long time, and we've gone through a lot. And it's important that we consider both the short-term gain along with the long-term sacrifice. You know, we shouldn't be able to say that right now I'm just going to give you these medicines and I'll be retired by the time your life falls apart. That is not the way we should be able to think. We need to be able to see the big picture. And so that's the importance of opioid-induced hyperalgesia. Is it universal? Absolutely not. There are genetic variabilities that make some patients more susceptible to dose creep, tolerance, and dependence than others. There is also past life experiences, childhood traumas, PTSD, that increase the risk of tolerance, dose creep, and so forth, and there are multiple factors. But I will tell you this, the pendulum in the 1990s and the early 2000s, I think most of us would agree, has swung far more toward the overuse of prescription chemical comforts. And that includes benzodiazepines, CNS stimulants, and opioids. Any questions or comments or arguments? Yes, ma'am. Yes. Nobody what?
Nobody loses.
Okay, yes.
Everybody gets an award.
Yep.
So if you talk about that, and I'm thinking about children now that are 7, 8, and 9, and say they're depressed and they're having all this anxiety, and parents somehow wanted to manage that, just looking at the graphic you gave us, are we not helping our children understand that life happens?
Yep. That's right. That's right.
That it makes me wonder when they hit those teen crises now, they have not developed any life experiences that let them know that it's not always fault.
That's right. So let me state your question or your comment, and so that everybody online can hear. The comment is it's a societal comment, I think, a cultural comment that says. Basically, everybody gets an award in competition. There should never be any losers. Everybody, what I'm hearing you say is our cultural bias now is nobody should ever feel pain. It's kind of what I'm hearing, okay? Nobody should ever feel pain. according to Solomon and Corbett and all the research, and there's lots of research about this, there is no pleasure unless it's relevant to some pain. So with regards to the pharmaceutical industry, if you look at the new products that were developed during the 1990s, what the pharmaceutical industry found was there is great, there's a big market for chemical comfort. There's a big market for providing comfort to people. And comfort became more of a goal of research than function. And in many cases, opioids, benzos, we sacrifice function for the sake of comfort in the long term. And I think the same thing is true with regards to the children. It's hard to appreciate a real reward if you just, awards are just always there. That's not pleasurable. And I think it has to do, as a cultural situation, and I'm not a psychologist or so forth, but in my personal opinion, all of that is part of this. You know, nobody loses, nobody should feel pain. You know, there has to be, our goal is to have a homeostatic balance of pain, but if I've been driving a truck for 2 days straight, I need to be sleepy and tired. I don't need to take a stimulant to override that feeling. That's the effect. And I think it's true of pain, I think it's true of anxiety and those kinds of things. Anxiety in one environment is counterproductive. In another environment, it's hypervigilance. It helps us with survival. Anyone else?
Are they doing anything about the Walker County area with high use of narcotics?
Yeah, it's a good question. As you know, the DEA and the Department of Justice has really raised their efforts in reining in high prescribers. And they're looking at several different types of phenomenons, those prescribers that tend to prescribe combination of controlled substances. Now, I can't get away with prescribing those massive amount of morphine milligram equivalents that I could 5 and 6 years ago. So now I'm going to augment my opioids with gabapentin, Lyrica, Adderall, phentermine. All of these things cause a release of dopamine in the nucleus accumbens, which basically turbo boost the euphoric effect. The opposite of pain is euphoria. The opposite of pain is and that's how this works. So we have seen doctors being prosecuted. We also are working, I'm on the Alabama Opioid Committee, and one of the big goals is what I'm doing here, which is educating people. Let's shift the paradigm more toward a balance of responsible use of all these medications. And it's not just opioids. My God, when we focus on opioids and then we let benzos and stimulants go wild, then we're just trading one problem for another. I think it has to do. I think that partial agonists such as buprenorphine probably will have a greater role in pain management in the future. Education through the Alabama Board of Medical Examiners. There are some regulations now. Pain management clinics have more regulations now than they did a few years ago. Addiction clinics, buprenorphine clinics are developing regulations around them so that we don't go from the pill meal era to the bute meal era, which is important to put guardrails in place there. Does that answer your question? Okay, well, thank you all very much. If you want to talk afterwards, I'll be around. Thanks.